requires clinical diagnosis and histopathological definitive diagnosis. And this signifies that dental practitioners in our center exhibit a commendable ability to actually accurately diagnose this condition based on clinical assessment. And in addition to that, it could also be due to a high number of specific lesions, such as denture-related lesion and other lesions like candidiasis, which were commonly observed in clinical practice, thus making accurate clinical diagnosis simpler. Lastly, we observe that the category of OPMDs coexisting with malignant lesion was the most accurately diagnosed category with a 100% concordance rate, and other than that, OPMD showed a high concordance rate of 91.3%. However, we also acknowledge that distinguishing these from the malignant lesion remains a challenge and hence lead to a 6.3% misdiagnosis rate in our study. Then, errors in clinical diagnosis are often attributed to overlapping in clinical features, dynamic nature of the lesion, and the presence of multiple lesion manifestation as mentioned by Condori and Garcia in their papers. To sum up and conclude everything, we believe there is a high relation in our study towards Indians, females, and patients from the age group 25 to 59 years old. And next, positive association of socio-demographic features and high-risk habits with clinical features can be seen as we discussed before. And lastly, histopathological diagnosis portrayed a substantial concordance with provisional diagnosis in our center. Nevertheless, we humbly acknowledge that our study itself had bias and limitation that need to be addressed. Due to relying on self-reported patient history on reports, this can lead to recall bias and lack of standardization during history taking, biopsies, and clinical description of the lesion, causing certain data to be excluded and missed. Lastly, presence of larger sets of data within the several classification also affecting the study, which may be due to its highly distinctive criteria and relation to oral lesion. For recommendation for future research endeavor, we suggest prospective study design by collecting a real-time data to minimize bias. And next, standardization of data collection by using a trained personnel according to standardized guideline can reduce ambiguity. And lastly, we also recommend an allocation of consistent sample size for each classification to prevent disproportionate bulk of certain groups. Last but not least, we would like to thank our supervisors and clinical statistical consultants for the guidance throughout our research. This is our reference list. And hence, we thank all of you for listening.
Thank you for sharing your work. Now, I would like to open the Q&A session to the judges.
All right. Interesting study. Now, in your results, I realized 45% of the study population are Indians. You know the ethnic diversity in this country, if you look at the percentage, they are the smallest. But 45% of your lesions are from Indians. How do you explain that?
We believe that the Indians in our ethnic population, even though having the smallest population in Malaysia, actually had among the highest is the highest in our result, and hence I believe that
any particular reason for that?
From the literature that have been reviewed, we has noted that some of the study reported Indian has the higher genetic susceptibility to this lesion.
I believe that this is because of their habits, which are chewing betel nut, as compared to other ethnic, which is the Malay, which has and also not alcohol drinking because of their religious beliefs and cultural norms.
In your understanding, what is the commonest group of oral mucosal lesions?
For Indians,
in your general practice?
OPMDs, the oral lichen planus for Indians.
What about reactive lesions? Your fibroepithelial polyps, mucoceles.
In our study,
aren't they the commonest?
However, in our study, we observed that Indian has the highest OPMDs.
It's a little different from the normal distribution of various oral lesions, isn't it? Reactive lesions are by far the commonest. Now, why do you think the buccal mucosa is the common site for your OPMD samples?
Because usually OPMD occur bilaterally on buccal mucosa.
What is the reason you think? Did you compare the habits with the prevalence of OPMDs?
From the literature review, we see that some study has reported that high-risk habit is related to the occurrence of this lesion on buccal mucosa, and due to the habits of chewing betel nut occurring on this buccal mucosa side, therefore this lesion often occurs on this side.
All right, good.
Thank you, judges, for the questions. Now, I'm pleased to introduce to you our next presenters, Nur Amani Izzati binti Rosli and Ahmad Nazran Hakim bin Muhammad Razali, who will be presenting on OP3 entitled The Perspective of Universiti Malaya Undergraduate Dental Students on Clinical Record Keeping, a Qualitative Study.
Mic test, 1, 2, 3.
To the presenters, you may begin.
I quote Fred Clark's law: sufficiently advanced incompetence is indistinguishable from malice. In other words, ill intention. My name is Nur Amani Izzati, and this is my partner Najwan. Good morning and assalamualaikum to everyone, to the judges and everyone in this hall. So we are here to present our elective project titled The Perspective of Universiti Malaya Undergraduate Dental Students on Clinical Record Keeping, a Qualitative Study. So in this presentation, we wish to explain thoroughly what is our study about, how it was carried out, and what we found out throughout the whole duration of study. So clinical record keeping is any item of information related to a patient, regardless in any form or medium. This is the definition provided by the Malaysian Dental Council, and the record retention differs between countries and the legislation that governs it. But in Malaysia, the minimum record retention is 7 years. And clinical records functions to facilitate effective communications between clinicians, and but not only that, it also provides a foundation for the good dental care. So in this slide, this is the most recent past studies on clinical record keeping, and as everyone can see, most of the studies are done in UK and also Australia. One study that we reference most in our project is the one by Chong in 2014, and it is titled Clinical Audit Teaching, and it was done in IMU KL. So why are we concerned about this? Because there is lack of studies that properly observe how the dental undergraduates, who are the future of the profession, perceive and engage in clinical record keeping. So this inadequate monitoring of students' progress in clinical record keeping is concerning because there are uncorrected mistakes may go unnoticed, as well as the threat of data privacy breach is looming on the horizon with increasing use of social media use. So in this study, we aim to explore the perspective on clinical record keeping practices among undergraduate dental students in their clinical training years at Universiti Malaya. With this goal of ours, we also wish to represent experiences of students in regards to clinical record keeping, and also identify the facilitators and barriers they face, and also how the training and education has impacted them. We also wish to investigate their perceived importance as well as attitude and knowledge level regarding clinical record keeping.
Moving on to materials and methods, we use a purposive sampling technique to include clinical dental graduates from 3rd to 5th year and exclude those in preclinical years who have yet to treat patients. We made initial contact with interested participants using WhatsApp messaging app and encouraged them to refer to other eligible individuals. After we had enough participants, we grouped them into 2 groups for each academic year. And lastly, we conducted an online meeting using Google Meet on an agreed date and time. To collect the data, we set up a meeting in English using a semi-structured focus group discussion, FGD methods. And in the meeting, one researcher assumed the role of the interviewer, leading the discussion using a topic guide that had been developed and validated by 2 dental specialists. Each group consists of 4 to 6 clinical students from the same year, resulting in total of 6 FGDs, and each of the FGDs lasting approximately 1 hour. To validate the data, we compare both audio and video recordings, field notes, and participants' feedback. During the interview, we asked the participants to turn on their cameras to capture verbal communication and also non-verbal cues such as body language. After the session, we reviewed and cross-referenced the field notes with the interview transcription to ensure consistency. Next, in order to improve the data reliability, we set up an audit trail, which comprises example of coding, details on moving from individual codes to teams, and explanation for grouping codes into teams. This is to clarify decision making and demonstrate a logical analysis path based on the participants' narrative. To analyze the data, we transcribe all discussion word for word, and we use QDA Minor Light software to manage and organize the data using thematic approach. For this, the two researchers independently conduct an open coding, assigning codes to different parts of the transcript, and eventually performing axial coding, which combine individual codes to form bigger teams based on the study objective. We compared the similarities and differences in the study. Any differences were resolved through consensus, and this was confirmed by the other researchers in the team. In terms of ethical consideration and data protection, the participants gave their written consent prior to all discussion, and they are assured that their information will be anonymized and they can withdraw at any point of time.
Now on to the results and discussion. For demographics, we managed to recruit 31 participants of different backgrounds, ethnicity, and gender to maximize the variation in our study. So for gender, 12 of the participants were male, 19 were female, and then for academic year, 10 of them were from year 3 and year 5, another 11 were from year 4. For ethnicity, 25 of the participants were Malay, 4 were Chinese, and another 2 were from Iban and Indian. So this is our results. One domain emerged from our coding, which is perceptions, and this is further divided into two main themes, which is positive and negative. From these two main themes, 3 subthemes also evolve under them, which implies that the students showed a mixed response between positive and negative to record keeping based on their experiences. For the first positive perception subtheme, which is personal growth, majority of the participants said they had felt personal growth contributed by the accumulation of knowledge as they progress through their clinical years. From these quotes, we see that the participants have mentioned that their clinical record-keeping skills as well as photography skills have improved, and some of them had even transitioned from using physical written records to using electronic ones such as Excel for easy reference. Majority of them collectively agreed that DAISY is a good system to study clinical record keeping for beginners. Another subthemes under positive perception is well-informed of basic principles. What this means is that majority of the participants have good understanding of basic principles of record keeping as well as its functions. They explain the importance of consent in record keeping as it acts as an explicit approval from the patient to accept any treatment. And also, they explain that when the record keeping has been done properly, it serves as a protection for both of the patients and also the clinician. And the last subtheme to evolve under the positive perception is confidence. When we asked the participants to assess their clinical record-keeping habits, whether it was good or poor, participants answered with confidence and were certain of their abilities. So from these two quotes, we can see that the participants were taught in a way that they should write their clinical records full of details and completely without skipping any steps. Despite the positive perception towards clinical record keeping, there were also negative ones, such as frustrating experience. So one example that they gave was some of the participants had received referrals where the history taking and also dental charting were poorly done, thus leading to false diagnosis and treatment plan. Another participant also mentioned that when they had to do multiple revision as in the clinical session due to different expectations of the varying supervising lecturers. Another subtheme under the negative perception is outdated system. So almost all of the participants complain about the in-house DAISY system being not user-friendly, has an outdated interface, frequently has connection problem as well as technical issues. For the outdated interface, the participants explain that DAISY limits them from writing specifically and providing more elaboration. And almost all of the participants mentioned that technical issues were one of the major problems they had while dealing with clinical records.
For the last sub-theme under negative perception is insufficient teaching session. Majority of the participants across the years mentioned that the training and education that the faculty provided was incomplete. One of them mentioned that the demo given during early third year was incomplete and unclear, and the principle of record keeping were taught quite late in the year. Due to this, some of the senior participants mentioned that when they were in year 3, they were unsure of how to do referrals. And also the year 3, the younger participants mentioned that the session they had was only one and it was quite general and they had to self-learn throughout the year. So when we asked them, the younger participants, about the legalities of clinical record keeping, such as record amendment and also storage duration, they exhibited hesitance when we asked them.
Moving on to discussion, our findings revealed that the participants demonstrate a good understanding of clinical record keeping and their responsibilities. However, they struggle in legal aspects like record amendment and retention. And this is partly due to a lack of teaching session, creating knowledge gaps. And this is supported by Chong in 2014, who reported that several students recommended for record keeping instructions to start when they begin treating patients. And this indicates an earlier record keeping training in the curriculum may have a greater impact on the students. Next, the participant expressed frustrations when dealing with different supervisors with different expectations. Dental students generally have to present their case history to the attending supervisor. However, some of the participants were frustrated because different supervisors have different expectations, forcing them to revise their clinical records, which eventually leads to clinical time loss. And this is supported by Patient in 2004, where the student expressed confusion when the initial treatment plan needs to be modified when treating a single patient under multiple supervision, which caused difficulty to provide and concise history to the attending supervisor. The students are also inclined to make mistakes as they have yet experienced with clinical records, and these findings is linked to inadequate teaching session. And this is supported by Rasmussen in 1994, who reported that the dentist age have a strong correlation with record quality than the amount of time since qualification, and dentists in their mid to late career had better record quality than those starting out. Brown in 2015 also discussed barrier leading to maintaining adequate dental records, claimed graduates are still adapting on the theory learned in school to the real world practice and may adopt a lesser standard than taught. Improvement that could be made for our faculty is to have record keeping lectures should be given in year 3 to avoid confusion and lacking knowledge in practice, and also upgrading the DAISY system into a system that provides guidelines to match international standards. We also could implement multiple methods of ingraining principle of record keeping, aside from lectures, demonstration tutorials, and inquiry-based learning. Chong mentioned by combining a brief lecture, student research, and others for record-keeping expectations result in positive outcome in compliance measure. The limitation in this study are findings may not be generalized to dental schools, dental students in under dental schools with different curriculum. And they were constrained in using the Google Meet platform. The 1 hour imposed time limit has prevented us from diving deeper into the discussion. However, the setting allowed for an open and comfortable discussion. The participants were engaging and passionate throughout the session, and finding a date and time that suit all participants was possible. In conclusion, the varying perspective of participants has provided useful insight into the standard of record practice, keeping practice in the university. Both positive and negative aspects of the practice are indicate for further improvement to elevate our quality of practice matching the international standards. We would like to express our gratitude towards the supervisors for their guidance and to the participants who volunteered for this research. And this is our references. With that, thank you.
Thank you for the presentation. Now, I would like to open the Q&A session to the judges.
Thank you very much, Madam Chairman. To the speakers, thank you very much for your presentation. An eye-opening, for me actually. So the first question is, why do you choose FGD as your technique to collect the data?
Okay, so we chose FGD to collect the data because from our discussion with our supervisors, surveys and also questionnaires have a low response rate, and we also wanted to capture non-verbal cues such as we explained just now, like their emotions as well as body language, in order to fully understand how they felt about clinical record keeping.
Okay, thank you. There are other methods of doing it. When you are doing FGD, you should have another one, upper one, which is more general, and you get, because to me, your sample is biased. Why do I say that? Because when you presented just now, you collected the samples of 31 students across year 3 to year 5, right? And then you use the WhatsApp and voluntary. Okay, don't you think your sample is biased?
Bias in terms of personally, because we don't know everyone.
Why don't you do it on a more randomized kind of sampling procedure rather than asking who would like to join? I mean, that's my impression when I see your slides.
Oh, actually, at first we actually blast the whole participants needed for the whole entire clinical years, year 3, year 4, year 5. But there were quite a few interested participants. So at the end of it, we had to come up with a more direct approach towards them, and we asked around personally.
Okay, but just be careful, yeah, because you are collecting and then you put them in the same group. Even though you have each year in 2 groups of them, but you're putting them in the same group. Their experience in terms of clinical recording may be different because the senior ones may be more experienced relative to the junior ones. Yeah, but I can see you have a lot of browsers there. Yeah. So another question is, do you think the system, DAISY system is outdated or is it not user-friendly? Thank you.
Thank you to the judges. Now, I would like to welcome our last presenters for this session, Habib Frizik bin Hasanusi and Putri Noalia binti Khalid, who will be presenting on OP4 entitled Root Canal Detection in Mandibular Incisors, a Microcomputed Tomography Study. To the presenters, you may begin.
Bismillah, good morning to distinguished judges, my friend, colleague, and audience. I am Habib and this is Alia. This is actually our honor to present our study entitled Root Canal Detections in the Mandibular Incisor, a Microcomputed Tomography Studies. All right, moving on. This is our outline for today's presentations. Ladies and gentlemen, it's actually essential to understand and to have adequate knowledge regarding root canal anatomy, not only to have a successful root canal treatment, but for a dental professional to evaluate the complexity of each tooth type. The canal anatomy itself may have variation in terms of shape and configurations as the photo shows, and it has been studied using a complex and advanced imaging method, for example, micro-CT in the lab studies, and CBCT and IOPA in the clinical studies. The tooth in question today is mandibular incisor. Despite being known as the smallest teeth in the mouth, it apparently have relative complex root canal system, which include variation in terms of position, configuration, and of course, intercanal communication that complex that need to be considered during root canal treatment. If you treat a vital tooth with a missing canal that have a pulp tissue, it will cause pain prior to get infected. While if you treat a non-vital tooth with a missing canal, it will get a persistent infections and a treatment failure. Global studies have shown that the different populations have effect toward the complexity of the anatomy of the mandibular incisor, while in Malaysia itself, one study showed there's no significant incidence of finding two canal or mandibular incisor, depending on the age and tooth size, while another study showed that age, sex, and ethnicity do have impact toward the anatomy of the mandibular incisor. For example, in comparison between Malay, Chinese, and Indian, Malay have higher variations of the root canal anatomy variation. So far, there is no study actually examine the root canal anatomy of the mandibular incisor within Malaysian populations that uses a micro-CT technology and a two classification system. That's why of our objective in the study, we prioritize to examine the initial root canal detections after the cavity preparation with reference to the micro-CT scanning and followed by the evaluations of canal configurations to a two-system classification system, which are a Bertucci and Ahmad classification. Moving on to our material and methods, Our teeth and sample are initially scanned by the high resolutions of microcity, but the result were actually blinded to the both operator, which is Habib and Alia. And then we did access cavity to each tooth in the sample. And then we did initial canal detections. The result were then compared with the microcity scanning. Following that, we did a second attempt of the root canal detections on the same sample. But this time around, we did a random sequence and the data were analyzed. And we have a total 140 mandibular incisor within our sample that collected in Malaysian population that were unknown ethnicity and age group. And it have to follow a certain exclusion and inclusion criteria as follow. The sample was stored in the saline until the moment of usage and with number in a separate compartment. In terms of microcity itself, we generated a 2D view using a materialized mimic program, and it's from a three-plane view, which is sagittal, coronal, and axial. While in terms of the root canal detection, we use a stainless steel K file size 6, 8, and 10. The file was then pre-curved prior to slowly introduction to the root canal system for it able to engage the buccal and lingual wall, and the data were recorded. The 2D scan just now that I mentioned were converted to a 3D database, and then we set the dentine to a constant transparent format for us to reveal the root canal anatomy. And the both operator analyzed the teeth in 2-dimension and 3-dimension and will classify it according to the classification system. In terms of calibration, it was performed between the two operator and two supervision endodontic. The both operator were trained how to actually read a microcity scan in a pilot study containing of 20 samples. The both operator read the microcity scan and then the single data were obtained. And then after discussion about the disagreement, the consensus were established.
Thank you, Habib. Ladies and gentlemen, the classification that we use in this study is firstly Virtusi 1984. Here, there are 8 types of canal configuration. According to the figure, each represent type 1 until type 8 respectively. Virtusi classification has been widely used for many decades. However, recent microcity studies have shown that it cannot classify teeth with complex anatomy, and it also does not take into account the apical deltas and also accessory canals. So, our next classification that we use is Ahmad 2017, and this classification addressed the shortcomings and proposed the root canal classification, providing a more detailed information including the total number of roots and internal configurations despite its complexities. This classification is divided into 3 components, which is the number of roots, root canal configuration, and also tooth types. For instance, one mandibular incisor 1-2-1-2-1, which means mandibular incisor has one root with one canal from the orifice, bifurcates into 2 coronally, reunite as one, and redivide again as 2, and merge as 1, and exit the apex as 1 canal. As for the results, it is divided into 2 parts, which is the classification of canal configuration and also canal detection. As for the first part, the percentage of root canal configuration being able to be classified by Virtusi is 60% in type 1, 20% in type 3, 2.86% in type 5 and type 7, and note that 14.29% is non-classifiable, whereas the percentage of root canal configuration, which has the similar types from previous mentioned Virtusi, can be classified by Ahmad et al. With 1 plus point, which is 14.29% can be classified by Ahmad but not Virtusi. These are the examples. Moving on to the canal detection, the percentage of both operators being able to be consistent with microcity from the first round is 48% and improved to 71% on the second round. And the sensitivity of both operators are also known as the true positive rate. For the operator 1, it managed to get 59% on the first round and improved by 10% on the second round. And for operator 2, managed to get 59% from the first round and improve up to 78% on the second round. As for the specificity of both operators, or also known as a true positive rate, operator 1 managed to get 75% on the first round and improved by 6% on the second round. And operator 2 managed to get 76% and improve up to 92% on the second round. The percentage of both operators able to find one canal consistent with microcity initially is 60% and improve up to 96% on the second attempt, and we both being able to find 2 canals consistent with microcity initially is 29% and improve up to 93% on the second attempt. And these are the examples of the canal configuration that we be able to detect correctly.
The finding of our current study actually consistent with a different study. For example, within a Turkey population that was that was examined by the study observed there's a 60% of the mandibular incisor contained of the two canal, while another study in Al-Qaeda and Al-Wada described within the Jordanian population, actually 26.3% have two canal in mandibular incisor. We would like also to discuss regarding disagreement between both operator and inconsistency with the microcity. It can be due to several reasons. Number one, the initial access cavity may not be adequate to detect a complex root canal. Second, a classification applicable to the RFEs may cause a hinder in the bifurcation detection. Following that, the absence of magnification, for example, microscope and loop. Following that, we'd like to discuss regarding morphology itself. As you can see in the picture, it's actually a flattened canal that both of us operator thought it was a two canal, but apparently after scan with the microcity, it's actually one canal. In terms of the microcity itself, we believe it's able to provide us an accurate, non-invasive, high-resolution method to actually examine the root canal anatomy, and the 3D reconstruction parameter able to help us in quantifications of the shape of the canal.
Members of the hall, not to forget Ahmad's classification as configuration is straightforward, precise, and capable of accurately classifying all of the sample studies. According to the Virtuti categorization, 14.29% of the sample in this current study were non-classifiables, and those non-classifiable types can be briefly and precisely categorized based on the number of roots and existence of bifurcations using Ahmad's system.
Thank you, Alia. And with that, we would like to give a few clinical recommendations that I believe will be a very great help to all of us. Number one, you have to have a systemic approach during access cavity. You need to have a clear outline. When you talk about mandibular incisor, it should be triangular in shape. You should achieve a straight line access at the long axis of the tooth and the removal of the lingual shelf for a better visualization and detection of the canal. Whenever you encounter with the mandibular incisor of two canal, usually the buccal canal are easy to locate because it's straighter than lingual canal. But lingual canal, on the other hand, they are usually hidden by the lingual shaft of the dentine. So we will suggest you to extend the access cavity linearly to the cingulum and also to pre-curve the file to easier detection. And in terms, whenever you do a radiographic investigation, we would like to recommend a method of parallax whenever you do periapical radiograph, because we believe it is beneficial actually to separate a buccal and lingual canal. However, we have to understand there's a few limitations. For example, handling, magnification, superimposition, and distortion. Whenever it's indicated, use CBCT because it's able to provide us additional information regarding the root canal anatomy. For example, like distortion, curvature of the root, level of bifurcation, and number and positions of the canal. And also use a magnification, for example, loop and operating microscope, because it's not only able to help the operator, especially in the case of classifications.
Dear audience, recommendation for this future study is so that micro-CT studies to also be done on other tooth types, especially in Malaysian population, and also detection of canals to be examined in other teeth. The limitations in this study is that the age, race, and gender were not known. However, this has been studied in previous report which showed variation in root canal anatomy of mandibular incisors in different ethnic groups as shown in Karobari study on Malaysian populations. Ladies and gentlemen, what we can conclude from this study is that the root canal anatomy of mandibular incisors in Malaysian population is complex, and the detection of canals in mandibular incisor is challenging and requires careful attention during access cavity preparation and pre-curving of files. Micro-CT scan teeth can act as a useful education tool for understanding the wide variations in canal anatomy and detection of canals with undergraduate students that improves with training. Members of the hall, with that, thank you.
Thank you for your presentations. Now, I would like to open the Q&A session to the judges.
Okay. Congratulations on the very detailed work. I would like to ask. Oh. It's red, so it's on and off. I would like to know. Indicator. And then again, you say, so can you be clear? Are you saying that when you when you are doing RCT for lower incisors, should micro CT be done?
Thank you for the question. So we have to understand in terms of what setting that we're gonna do the patient. For example, in clinical setting, we suggest the indications of use CBCT instead of micro CT because micro CT itself is in vitro, which is in vivo, which is can be used for the patient, while micro CT is for the lab setting. And we did say just now the CBCT were indicated. We use CBCT whenever it's indicated.
Okay, so sorry, I made a mistake. I mean CBCT. So CBCT is a must or not?
It is when indicated.
When is it indicated?
Whenever.
No, sometimes you say it's a must, and then when indicated.
Okay, Ken. Okay. It depends.
So I'm confused because tomorrow I'm treating a lower incisor.
Okay, there are several factors. For example, when you first meet a patient, whenever the detection that you have suspicion they have a two canal in mandibular and you are unable to detect the second canal, but CBCT can be indicated the reason why, even though the CBCT imaging are quite inferior to the micro CT, but it able to provide us the presence of second canal. And that's essentially enough for the operator to search for the second canal in every method they can do. For example, pre-curving the file or taking the parallax method of the IOPA. Whatever it is, we have to understand it is able to provide the operator that the present second canal exists.
So you mean I have to stop my treatment, then send my patient for CBCT, then only I continue? But can't you make a proper recommendation based on your finding?
We can clinically what we can do is we can improve our access cavity and also pre-curving the fold, and also we can extend to remove the lingual shoulder for us to be very determined whether there is presence of second canal or only one canal.
Okay, thank you. Before I'm stopped, do I have time? No.
Almost
Okay.
finished.
Thank you.
Thank you, everyone.
Thank you, judges and presenters. And that concludes our first session for the oral presentations. The next oral presentation will begin at 11:45 a.m. I will pass the floor back to the MC. Thank you.
I want to go toilet. Do they connect now? I think so far this is the best presenter lah. Yeah. Very well. Where is it indicated that we have to write our initial?
No, you want to look back.
No. I already put marks here. But if you want that next time, you put our initial.
No, if you want to.
Makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif.
I'll do that 1 minute.
Yes.
Yeah.
Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif.
Tapi I ada prepare slide. 9 minutes slide. 9 minutes slide.
Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan
Good morning, ladies and gentlemen. If I may have your attention, please, I would like to introduce our Dean, Dr. Zamri Ratzi, for a special announcement.
Thank you. Thank you very much, both of you. A very good morning to everyone. How's everything today? So this is a very special event for us. We are celebrating our silver anniversary of the Dental Student Scientific Conference. And it is our event. So we would like to make it, this is a very historical one that we will remember for many, many years to come. So as some of us are still upstairs listening to the poster presentation, so what we would like to have actually, those who are already here, to fill up the front seats, yeah? To fill up the front seats, come and fill up the front seats. And what will happen today, during the opening ceremony, we will have our distinguished guests to officiate our event today. And it will be followed by a keynote speech, a keynote lecture by our former Vice Chancellor. So the former Vice Chancellor will be talking about an individual, a personality of high esteem that we would be able to emulate. Yeah. So as the slides, the former Vice Chancellor only have 3 slides. The first slides will be the title. The second slide, it will appear the photograph of the individual. As the photograph appeared, we would like to show our appreciation to that individual. So we would then give a standing ovation. We will all stand up, yeah? We'll stand up and we give a big round of applause for half a minute and then we'll sit down. So it is something that we want to cherish. We want to give the honor to the person, and it's something I believe we all will remember this moment. So thank you very much, everyone. Make most of this event. Yeah. Please be as much as possible, gain the most from the oral presentation and poster presentation. So during this opening ceremony, everyone will gather here, and then later on you would be able to decide whether you want to attend the oral or poster presentation. But we'll be here for the opening ceremony. So thank you very much, everyone. Please come forward. Yeah, we will start very soon, and all your cooperation much appreciated. Thank you so much, everyone. Thank you. Over to you. Thank you, wonderful, our wonderful MC. Thank you.
Okay. Thank you so much, Professor. So, good morning, everyone. Good morning. Morning. All right. So, a little bit housekeeping announcement. So, ladies and gentlemen, a gentle reminder on housekeeping rules to ensure that everyone will enjoy this conference and is not interrupted. Kindly ensure that your mobile phones are silent to minimize interruptions during these sessions. And if you do need to take a call, we encourage you to step out of the hall to minimize interruptions. Restrooms are located outside the hall, and if you do require assistance or directions, our staff members are ready to assist you.
Please refer to the conference agenda provided to you for details on session timings, locations, and topics. Sessions will start promptly on the scheduled time, so we recommend arriving a few minutes early to ensure you don't miss anything. Please do familiarize yourself with all the nearest exits in case of an emergency. These exits are located to the left and right of the hall, as well as at the back of the hall.
Here, I would like to request the cooperation of all the students and lecturers, dear audiences, from the back of the hall to come forward and fill the front seats. Thank you. I would like to repeat, if the students and lecturers kindly cooperate and move forward, please.
To my dear colleagues, I would like to repeat, please do fill the front row of seats. There are still several rows left empty. I kindly request your cooperation to fill these seats. Thank you.
To my dear students, who I can see you guys there, can you kindly move forward? Yes, I'm making eye contact here. The students back there, please come forward. Yes, come forward. Thank you.
Ladies and gentlemen, we will be starting shortly. A kind, gentle reminder for everyone to make sure that your phones are silent to minimize interruptions during the conference. And also, if you do need to take a call, we encourage you to step out of the hall to minimize any distractions. Thank you. Ladies and gentlemen, audience of the hall, as our distinguished VVIP makes their way into the hall, I kindly request that you join me in showing them the warmest of welcomes. And as they enter the hall, let us all stand up and show our collective appreciation for their presence today. Thank you.
Ladies and gentlemen, announcing the arrival of Yang Amat Berbahagia, Toh Puan Dato Seri Haja Dr. Aisyah Ong, Pro-Chancellor, Universiti Malaya, accompanied by the dignitaries. To formally start today's program, please kindly remain standing for the singing of the national anthem Negaraku, followed by Universiti Malaya and Faculty of Dentistry songs.
Universiti Malaya, kebanggaan kita semua. Bertambah para ilmuwan di berbagai lapangan. Kami bertekad di hati mencapai cita bumi. Kasih kecemerlangan menepati wawasan. Di sini kami sedang berbakti terus berinovasi. Kami harapkan generasi muda terus nusa dan bangsa. Kasih kesayanganku sungguh pada dasarmu, membentuk insan mulia berilmu berbudaya. Di sini kami sedang berbakti terus berinovasi. Kami harapkan generasi muda terus nusa dan bangsa. Kasih kesayanganku sungguh pada jasamu membentuk insan mulia berilmu berbudaya. Pendidikan fakultiku di Universiti Malaya. Di sini ada cahaya bersinar dan terus megah. Pendidikan seruakan hidupku, ilmu dan juga imanku. Semarak jiwa berkobar, melangkah terus mencapai. Majulah fakulti ini, kibarkanlah bendera, bangkitkan semangat jati untuk bangsa dan negara. Pendidikan di hatiku berjaya terus berjaya, fakulti terbilang dan maju, terbang ke angkasa raya. Majulah fakulti ini, kibarkanlah bendera, bangkitkan semangat jati untuk bangsa dan negara. Pendidikan di hatiku berjaya terus berjaya, fakulti terbilang dan maju, terbang ke angkasa raya.
Yang amat berbahagia Tuan Puan Dato Seri, Dato, ladies and gentlemen, please be seated. Yang amat berbahagia Tuan Puan Dato Seri Hajah Dr. Aisyah Ong, Pro-Chancellor Universiti Malaya. Yang berusaha Profesor Dr. Sabri Musa, Deputy Vice-Chancellor Student Affairs Universiti Malaya. Yang berusaha Profesor Dr. Zamri Ratsi, the Dean of the Faculty of Dentistry Universiti Malaya.
Yang berbahagia Datuk Kapten Bersara Profesor Emeritus Dr. Hashim Yaakob, the 8th Vice Chancellor of Universiti Malaya and former Dean Faculty of Dentistry Universiti Malaya. Yang berusaha Associate Professor Dr. Ros Anita Omar, Chairperson of the 25th Universiti Malaya and 3rd International Dental Students Scientific Conference.
Yang berbahagia Major General Bersara Datuk Dr. Haji Muhammad Termitsi Haji Junaidi, President of Dental Alumni Universiti Malaya. Yang berusaha Profesor Madya Dr. Mas Suryalis Ahmad, President Malaysian Dental Association. Yang berusaha Profesor Dr. Rahima Abdul Kadir, former Dean, Faculty of Dentistry, Universiti Malaya.
Yang berusaha Profesor Dr. Rosna Muhammad Zain, former Dean, Faculty of Dentistry, Universiti Malaya. Yang berbahagia Datuk Profesor Dr. Zainal Arif Abdul Rahman, former Dean, Faculty of Dentistry, Universiti Malaya. Yang berusaha Profesor Datuk Dr. Ahmad Termizi Zamzuri, Dean, Faculty of Dentistry, Segi University.
Yang berusaha Profesor Madya Dr. Farid Ghazali, Deputy Dean, Faculty of Dentistry, Lincoln University. Yang berusaha Dr. Ahmad Zulfikar Samsudin, Deputy Dean, Faculty of Dentistry, University Science Islam Malaysia. Deputy Deans, Heads of Departments of the Faculty of Dentistry, Universiti Malaya. Lecturers, sponsors, distinguished guests, esteemed faculty, and fellow dental students.
Ladies and gentlemen, it is with great pleasure that we welcome you to the 25th Universiti Malaya and 3rd International Dental Students Scientific Conference 2024. Theme, Technology, Ecology, and Education, a trifecta for dental excellence. I am Rafiq Tan.
And I am Jaskiran Gill. And
We will be your MCs today. Let us take you through a quick overview of the program schedule. The program lineup for the morning session has already begun with a 4 oral and e-posters presentations. And we will soon proceed with the recital of Dua, opening remarks from our beloved Dean Professor Dr. Zamri Radzi, the opening ceremony by Yang Amat Berbahagia Tuan Puan Pro-Chancellor, and keynote presentation by Yang Berbahagia Datuk Captain Bersara Professor Emeritus Dr. Hashim Yaakob, followed by a photography session and a tea break. Now, we would like to call upon Mr. Muhammad Munif, President of Persatuan Pelajar Islam Pergigian Universiti Malaya, to proceed with the Doa recital.
Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Al-Fatihah. In the name of Allah, the Beneficent, the Merciful, praise be to Allah, Lord of the worlds. Let your blessing and your peace be on your servant and your messenger Prophet Muhammad sallallahu alaihi wasallam and on his family and his companions. Allahumma ya Allah, on this glorious day, in conjunction with the 25th Universiti Malaya and 3rd International Dental Students Scientific Conference, we uphold our hands to pray gratefully to thank on your infinite favor to us till we can live in peace and harmony to perform our tasks as your servants. O Allah, we ask for your blessings to make this occasion a success. We seek your guidance for a smooth running of our event and to steer clear of matters that will affect it. Allahumma ya Hayyu ya Qayyum ya Dzal Jalali wal Ikram. You are the embodiment of mercy and you are the Lord of the universe. Grant us mercy from your presence and guide us to righteous conduct in our life. We ask for beneficial knowledge and sustenance that is good for us and deeds that are acceptable. O Allah, help us to remember you, to thank you, and to worship you in the best of manners. Forgive us, have mercy upon us, guide us, and give us health, and grant us sustenance. Allahumma ya Hafizul ya Raqib. O Allah, you are the most forgiving and one who loves forgiving. Therefore, forgive us and grant us a very pleasant and memorable event today in our beautiful university. Amin ya Rabbal Alamin.
Thank you, Mr. Muhammad Munif.
Now, we would like to invite our Dean, Professor Dr. Zamri Radzi, to deliver his opening remarks.
Thank you very much, Rafiq and Jaskiran, our MC. Thank you very much. Yang amat berbahagia, Tuan Puan Datuk Seri Hajah Dr. Aisyah Ong, Pro-Chancellor Universiti Malaya. Yang berbahagia, Datuk Captain Bersara Professor Emeritus Dr. Hashim Yaakob, the 8th Vice-Chancellor of UM and the former Dean of the Faculty of Dentistry. Yang berbahagia, Professor Dr. Sabri Musa, the Deputy Vice-Chancellor of Student Affairs, representing the Vice-Chancellor of the University of Malaya, and the former Dean of the Faculty of Dentistry, University of Malaya. Yang berusaha, Associate Professor Dr. Wan Azrina Wan Hassan, Deputy Dean of Undergraduate Faculty of Dentistry. Yang berusaha, Associate Professor Dr. Ros Anita Omar, Chairperson of the 25th Universiti Malaya Dental Student Scientific Conference. Yang berbahagia, Major General Bersara Datuk Dr. Haji Muhammad Termizi, Haji Junaidi, President of Dental Alumni Universiti Malaya Muda. Yang berusaha, Associate Professor Dr. Mas Suryalis Ahmad, President Malaysia Dental Association, MDA. Yang berusaha, Professor Dr. Rahimah Abdul Kadir, former Dean of the Faculty of Dentistry. Yang berusaha, Professor Dr. Rosnah Muhammad Zain, former Dean of the Faculty of Dentistry. Yang berbahagia, Datuk Professor Dr. Zainal Arif Abdul Rahman, former Dean of the Faculty of Dentistry. Yang berusaha, Professor Datuk Dr. Ahmad Termizi bin Zamzuri, Dean of the Faculty of Dentistry, Segi University, alumni of the University of Malaya. Yang berusaha, Associate Professor Dr. Farid Ghazali, representing the Faculty of Dentistry, Lincoln University. Associate Professor Dr. Zulfikar Samsudin, representing Faculty of Dentistry, University of Science Islam Malaysia. Deputy Deans, Head of Departments, Head of Discipline, Academic Staff, President of DENSOC, President of PIPUM, President of DEPAN, Advisor of the International Dental Network, University Malaya, our sponsors, distinguished guests, esteemed fellow, and the faculty members, ladies and gentlemen, all the students from year 1, 2, 3, 4, and 5, and our postgraduates. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, today is very, very special and very, very historical for various reasons. So today we gather here to celebrate our 25th anniversary of the Dental Student Scientific Conference. And very special indeed because our Honorable Pro-Chancellor, Yang berbahagia Tuan Puan, is here today with us. Yang berbahagia Tuan Puan, without fail, always accept our invitation and always here to support Faculty of Dentistry, University of Malaya. Despite her busy schedule, in her many roles to help the society at large, the country and our nation, a very noble role that she served in various capacity. Previously as a chairman of our very own University Hospital and various associations, Bhakti, Magna, Carif, Alzheimer Association, Arthritis, Hemophilia Association, Mental Health Association, you name it, there are so many of it. And Tuan Puan, we are very proud of you. Thank you very much once again. We are deeply touched with your presence today. Thank you so much, Tuan Puan. Ladies and gentlemen, it is very special indeed because this is one occasion that we gather so many former deans of ours in one sitting, in one congregation. Thank you very much, all former deans of ours. For the past 25 years, a quarter of century, they are the ones who are standing here with the opening ceremony and the closing ceremony, whereby 25th batches of students of the talented one passed through this hall and became, many years later, the top-notch, very, very influential dental specialists, dental surgeons in the country and beyond. So thank you very much, all the professors, all the former deans. And also very special today that we have our president of Dental Alumni Muda, without fail, always here to support our dental faculty. Thank you very much, Dato'. Dato' served the army and revolutionized the army, the service, the dental the dental army services, and also the dental faculty of IIUM, and many more in various capacities, as well as Malaysian Dental Association. Leading to another figure whom we are very proud to say, our alumni, Prophet Mas. Thank you very much for being here. Always here to support our event. We are very proud of you. And her role as the president, you can see so many initiatives that she introduced. And we are very, very proud of you. Thank you very much for being here. And also our alumni, Prof. Tarmizi, thank you very much. Again, without fail, always accept our invitation. Thank you very much once again. Ladies and gentlemen, I am entrusted to sampaikan the salam. Warmest regards from our Vice Chancellor, who are not able to be here, but in now, as we speak, attending a very important meeting for our country. He sent his warmest regards, and I'm sure it has been conveyed to Topuan by our Deputy Vice Chancellor. And also, our longest serving Dean, Datuk Professor Ishaq Abdul Razak, sent his warmest regards to everyone. He wouldn't be able to attend because of another official engagement today. Ladies and gentlemen, we are also very proud that today's event are sponsored by our loyal sponsors. Thank you very much, Helion. Thank you very much, Ultraden. Thank you very much, Southern Lion, Colgate Palmolive, and also our very proud alumni, Dr. Wong and partners. Thank you very much for all your supports. Without your supports, we wouldn't be able to continue to organize this event. And this event, when we look at the records that we have, 25 years ago, 1999, when our former Vice Chancellor, Datuk Prof. Hashim, was the Dean at the time. He was the one who introduced the Dental Student Scientific Conference, and our former Dean, Prof. Rahimah, was the chairperson at the time. And the Vice Chancellor at the time, none other than the late Tan Sri Dr. Abdullah Sanusi. In his remarks, he said this, "Saya percaya persidangan saintifik ini akan dapat memperkukuhkan daya pemikiran serta meneruskan latihan dinamik for all dental students who are here." Al-Fatihah to Arwah Tan Sri. This is the first program book that I kept, my own copy, and I treasure this. It is already 25 years and still not faded. So in this, there are so many records of how great the work has been done 25 years ago. And with this, we have fulfilled the aspiration, the dream of the first Dean, the late Professor Ibrahim Yassin. When he first started, from the records of the Board of Studies, he wrote it down. The scientific inquiry is one of the elements which is important to be instilled in the graduates of dental faculty, University of Malaya. And he shared the dreams of the Vice Chancellor at the time, Professor Diraja Unku Abdul Aziz, of which this very hall is named after. So ladies and gentlemen, Al-Fatihah to both of them. So ladies and gentlemen, this year, it is very special too, because we have the participation of international segment. We have the participation of 55 groups of international students from 15 institutions in 7 countries. So they participated in e-poster, and if you look at the abstract, it is evident from the abstract of high level of the high standard of their work. And we thank all the deans of 15 dental institutions who encourage all their students to participate in our conference today. Thank you very much. We know that they will hear what we have today through various means. Thank you very much, all the international partners. Ladies and gentlemen, it is very kind of everyone to be here, and we really appreciate the attendance of year 1, whom 4 years from now will be standing here just like his senior to be speaking, to be presenting their work. Same goes for the year 2, year 3, year 4. You are here to train yourself, to be exposed to all the scientific inquiry that we expect from each and our graduate. Ladies and gentlemen, we thank you for all this. We maintain this tradition as one of the scientific tradition, and soon will be followed by DESTIC, Dental Students Talent and Innovative Competitions. We make it a two separate event, and not long after that, we are going to celebrate our Majlis Shawwal, and we welcome everyone on the 29th Monday at the Pekarangan Faculty Pergigian. And we also hope everyone would be able to join the CLAP run on the 23rd of June to support our CLAP patients and to support their parents too. Ladies and gentlemen, it is something that we are very, very proud indeed to see the standards of the presentations of the research work become better and better each year. Saya akhiri dengan doa. Our Lord, bless all of us here. Bless our Pro Vice Chancellor. Bless all our VIPs, all our former deans, those who are here with us, as well as those who are no longer with us. Bless all our teachers. Bless all our alumni. Bless everyone here, all the students, as well as the staff of ours, those who are with us here today and no longer with us here today. God Almighty, make us those who are very close to you, who will always be near to you in both worlds. Ya Tuhan kami, berkatilah kami dan lindungilah kami. Dan hari ini kami menyaksikan mahasiswa-mahasiswa Fakulti Pergigian yang nantinya akan menjadi sarjana yang terbilang, yang saujana mata memandang, yang akan menjadi orang yang terkemuka, yang dulunya menjadi orang-orang yang kami tekuni selama mereka berada di Fakulti Pergigian ini. Dan mereka ini adalah umpama benih yang tumbuh, yang menjadi bunga dan menjadi buah. Yang bunga harum baunya, yang buah sedap rasanya. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Dr. Zamri Radzi, for the wonderful opening remarks.
We would now like to invite Yang Amat Berbahagia Tuan Puan Datuk Sri Haja Dr. Aisyah Ong, Pro-Chancellor Universiti Malaya, to address this gathering.
Terima kasih Tuan dan Puan Pengerusi Majlis. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Yang berbahagia Profesor Dr. Zamri Radzi, Dean of the Faculty of Dentistry, Universiti of Malaya. Yang berbahagia Profesor Dr. Sabri Musa, Deputy Vice Chancellor, Student Affairs, Universiti of Malaya. Yang amat berbahagia Datuk Kapten Besara Professor Emeritus Dr. Hashim Yaakob, an old friend and the former Vice Chancellor of the University of Malaya. Welcome. Nice to see you back to your old place. And yang amat berbahagia Major General Besara Datuk Dr. Haji Muhammad Tamizi bin Haji Junaidi, President of MUDA, Deputy Deans, Heads of Departments, distinguished guests, esteemed faculty and fellow dental students, ladies and gentlemen. Welcome to the 25th University Malaya and 3rd International Dental Students Scientific Conference. As we gather here today, we celebrate not just the remarkable achievements and groundbreaking research, but also the steadfast and dedication displayed by the future leaders of dentistry amongst our midst. It fills me with immense honor and excitement to stand before you very humbly as we embark on the enriching journey of knowledge sharing and intellectual exploration. It's a journey that began in halls not unlike these, although in London, surrounded by peers and mentors who shared a common goal, that is, to innovate and improve the healthcare for all in this country. This conference is a testament to our commitment to excellence and our collective passion for advancing oral health and patient care. The Faculty of Dentistry at the University of Malaya has always been a beacon of innovation and a pioneer in embracing the profound impact of research on both national and international stages. Through investment in cutting-edge technology and a culture of innovation, we have driven transformative change in dentistry, positively affecting the community and the patients we serve. I am particularly moved by the students' innovative ideas aimed at progressing the field of dentistry. Your dedication to scientific exploration is remarkable. Standing at the threshold of a new era, armed with knowledge, skills, and a resolute determination, you are the architects of the future of dentistry in this country. This conference is your arena to exchange groundbreaking ideas, exchange existing paradigms, and enrich the collective wisdom of our profession, of your profession rather. I'm a doctor, I'm not a dentist. As we navigate the realms of dental research and innovation, let us stay focused on our shared mission, that is, to enhance the oral health and well-being of our patients in Malaysia. Our duty is to turn knowledge into practical solutions that can overcome the challenges faced by individuals and the community at large. I extend my heartfelt appreciation to all conference committee members, participants, faculty mentors, sponsors, and volunteers. Your relentless support and dedication are the foundation of this event's success. I wish you all an inspiring and productive experience at this Dental Students Scientific Conference. May your efforts today shape the future of dental care for generations to come. Thank you, and let the conference begin. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Thank you, Yang Amat Berbahagia Top 1 Pro-Chancellor, for the remarkable opening speech.
We now would like to invite Yang Amat Berbahagia Top 1 Pro-Chancellor, Yang Berusaha Professor Dr. Sabri Musa, Yang Berusaha Professor Dr. Zamri Ratzi, Yang Berbahagia Dato Captain Bersara Professor Emeritus Dr. Hashim Yaakob, and Associate Professor Dr. Ros Anita Omar for the opening ceremony. Ladies and gentlemen, kindly direct your attention to the screens for the montage presentation.
Access granted.
Berjaya terus berjaya, fakulti terbilang dan maju. Bangsa raya, majulah fakulti.
Thank you. Now we would like to invite our Dean, Professor Dr. Zamri Ratzi, to present a token of appreciation to Yang Amat Berbahagia, Tuan Puan Pro-Chancellor.
Again, we would like to invite our beloved Dean, Professor Dr. Zamri Radzi, to present a token of appreciation to Yang Berusaha Professor Dr. Sabri Musa, Deputy Vice Chancellor and former Dean, Faculty of Dentistry, Universiti Malaya.
Thank you, Yang Amat Berbahagia, Tuan Puan Pro-Chancellor, Yang Berusaha Professor Dr. Sabri Musa, Yang Berusaha Professor Dr. Zamri Ratzi, Yang Berbahagia, Dato' Captain Bersara Professor Emeritus Dr. Hashim Yaakob, and Yang Berusaha Associate Professor Dr. Rose Anita Omar. Please kindly proceed to your seats.
Without further ado, we would like to invite our respected keynote speaker, Yang Berbahagia, Dato' Captain Bersara Professor Emeritus Dr. Hashim Yaakob, to deliver his lecture entitled Stand Up and Be Counted.
Assalamualaikum warahmatullahi wabarakatuh dan salam hormat dan salam sejahtera. Bismillahirrahmanirrahim. Yang kami sekalian kasihi, yang amat berbahagia Tuan Puan Datuk Seri Hajah Dr. Aisyah O. Div-div kehormat jemputan yang kami muliakan, serta staf Fakulti Pergigian dan anda-anda sekalian yang sekarang sedang menjadi penuntut dan akan segera menjadi doktor pergigian, insya-Allah. Saya banyak berhutang budi kepada Tuan Puan Aisyah O. Saya berhutang budi demi untuk anda sekalian dan staf-staf dan juga pelajar-pelajar fakulti ini pada waktu itu, tahun 1987 lebih kurang pada waktu itu, iaitu ketika saya menjadi dekan, Dan fakulti pergigian adalah kurang dalam serba-serbi. Tetapi fakulti perubatan sudah kuat sebab mereka lebih tua dari kita. Dan yang amat berbahagia, Tuh Puan adalah pengarah PPUM pada waktu itu. Jadi setiap kali saya kesempitan wang, kesempitan fasilitas, saya akan menghadap beliau dan minta tolong. Dan Tuh Puan tidak pernah menghampakan permintaan itu. Dan apabila dia beri bantuan itu, bukan hanya di dalam perkara-perkara yang sebut tadi, tetapi juga di dalam bantuan meminjamkan kita lecturers yang kita sangat short pada waktu itu. Ya, siapa yang mengajar tuan-tuan sekalian dalam anatomi, dalam fisiologi, biochemistry yang kita tak pandai. Saya minta pertolongan yang amat berbahagia Tuh Puan lah itu. Dan akhirnya oleh kerana bantuan beliau dan sebagainya, kita mendapat inspirasi yang amat tinggi untuk memertabatkan fakulti kita ini. Maka pada tahun selepasnya itu, kita pun bilang kita mesti ada satu standard. Dan kita bekerja kuat dengan seluruh staf bekerja bertungkus lumus, dibantu juga oleh pentadbiran dan kita mendapat anugerah, iaitu anugerah, apa nama anugerah itu? Recognition by the General Dental Council of Britain kepada bachelor degree kita. Ya, maka jadilah kita suatu fakulti yang dikagumi. Dan graduate kita pada waktu itu boleh saja pergi ke mana-mana negeri yang di bawah Commonwealth dan bekerja tanpa mengambil apa-apa peperiksaan. Tuan Puan, waktu malam memasang pelita untuk menerangi malam yang gelap. Memandang wajah Tuh Puan begitu jelita, burung yang terbang berhenti hinggap. Apakah yang hendak saya katakan selain daripada untuk memberi semangat kepada anda sekalian. Anak saya yang paling tua sekarang sudah berusia 40 tahun. Jadi anda sekalian, bolehlah jadi anda saya kepada saya. Stand up and be counted. Apa makna stand up and be counted? Stand up and be counted ialah sesuatu yang kita mesti ada di dalam diri kita. Sama ada di dalam ilmu pengetahuan, kepercayaan diri, jati diri, self-esteem. Kita mesti ada. So that you can stand up to anybody and be counted in your life. And of course in the next life too. Yeah. So what do you do? What do you do to stand up and be counted? One good example is the one which this faculty did before. We stood up and got counted by the General Dental Council of Great Britain as the faculty that delivers a curriculum for the Bachelor of Dental degree equivalent, same standards as the ones in Britain. Therefore, we have stood up. Now, untuk anda sekalian, whoever you are, whether you are in the first year or the final year, you must stand up. Own it to yourself. Be yourself and stand up so that you have got your own jati diri. So what do I do today? Today I wish to describe someone. I wish to describe someone whom you can make as your icon, to give you inspiration in your life. Now I'm going to describe this person now. And pay attention to this so that you could be like this person, or near to this person, or be even better than this person. This person is a lady, was a girl. And she studied in St. Mary's Girls' School, Kuala Lumpur, in the beginning. Then she went to St. Francis Girls' College, England. You all tak pernah pergi. So you must treat that as an inspiration to reach to that level. Duduk sini pun tak apa, go later, okay. Then she studied medicine at the Royal Free Hospital, University of London. And after registering with the GMC, General Medical Council, and later received a postgraduate qualification in primary care. And in 1971, where were you in 1971? Received a qualification in obstetrics in London. And in 1973 until 1975, the lady served the Ministry of Health at the Kuala Lumpur General Hospital as a medical doctor with those qualifications which I have just mentioned. And then at Tanglin Hospital, you know about this. You go there to eat your nasi lemak sometimes next to the Tanglin. And in 1975 until 1977, she went into the private clinic, Young and Newton. I have just joined the faculty in 1975. And I was about 25 years old after graduating BDS and became a lecturer at this faculty, 1975. And sometimes when I got sick, my panel doctor was Young and Newton. I went there to have my sickness cured, but I was very unfortunate because I never was treated by this lady. In 1978 to 1985, the Bapak Kemerdekaan and the first Prime Minister of our country invited her to join a pro bono clinic, means free lah, just give service for free. A pro bono clinic run by Perkim, where she became a volunteer doctor. How many of us volunteer in our profession? Free charge. Tanyalah. 1978 until 1986, this lady became the chairperson of the board of directors for University Hospital UM, now known as PPUM, Pusat Perubatan Universiti Malaya. 1987 to 1996, and then up to 2003, she was member of the University Malaya Council. Now it is called LPU. People like to change names. As one leader comes, they change the names. The only thing which we have not changed is Fakulti Pergigian Universiti Malaya punya nama. You know, we must not change it because in the British General Dental Council, our faculty is inscribed as Fakulti Pergigian Universiti Malaya. You change it to something else, they will not recognize you anymore. Maintain it. Certain things will have to be maintained unless it has got to be done, something new. Now, I became professor in that year, 1987, when she became the director of the hospital university, and I became a professor. And there was the time I would go to her meekly begging, saya punya fakulti kecil, boleh ke pinjam ini, boleh ke tolong ini, boleh ke tolong itu. This person was the chairman of the hospital board, and she had a lot of power. So when you have a lot of power, use it to do good, and then you make everybody happy. Now, from 2003 till now, she became the pro-chancellor. By now, you must know who I'm talking about. She became the pro-chancellor of the University of Malaya, the first lady to be appointed to the post in this country. She loves this faculty very much. As far as I remember, she comes here all the time unless there is something else which is more urgent. As far as I know, the pro-chancellor do not go to other faculties as often as she comes to this faculty. There must be something special about you people. Now stand up and own to it. This is something which you can stand up and be counted. You are loved by the top people in the university. Now she was and is, among others. I will not mention everything. Otherwise, by evening, I will still be reading these things. Therefore, I will make it a little shorter because the general is looking at his watch. She was the founding committee members of Badan Amal. Badan Amal. Badan Amal is not Badan Kerajaan. This is doing goodness for the people, especially for the poor and non-privileged ones. Badan Amal dan Kebajikan Tenaga Isteri Bakti. It is called Bakti at that time. And she was chairperson of Bakti Welfare. Badan Amal, Welfare. Now that tells you why she was very, very, very ready to help the dental faculty through me last time. Because she was involved in Badan Amal, Kebajikan, Welfare. All right? Now, then became director of Bakti Tun Hasmah Muhammad Ali building. Pergi carilah, she was the chairman of the building of that, trying to build. And it is not easy to become chairman of things, Hard enough to become a deputy dean already. What more about chairperson of building a building? All right. Chairs of MIND, M-I-N-D, which stands for Malaysian Information Network on Disabilities. You people do not fall into this because you are all fit, able-bodied men and ladies. But she was looking after the disabled people. Founder and director of Institute Kemajuan Wanita Malaysia. Why are the Malitas not giving a hand in claps? This is for you, Wanita. I think because you are all paying attention, that is why you forgot your hands. You were so involved in the mind, you forgot about your hands. Never mind about that. Now, Board of Trustees of Maybank Group Welfare Fund. Welfare again, Board of Trustees. People do not appoint you if you are not trustworthy. I am not trustee of anything because I think nobody thinks that I am trustworthy. Now, Board of Trustees of Maybank Group of Welfare. Welfare, bukan group. Fund, Group Welfare Fund. And she was Rhodes Scholarship Selection Committee for the British Council. You nak pergi belajar luar negeri through the Rhodes Scholarship. She was there to determine whether you are fit enough or not. Now, she was board member Tun Hussein Eye Hospital. Siapa sakit mata pergi sana. Kalau doktor tak mau jaga you betul-betul, You know to whom you can speak to now. She was a patron of Cancer Link. Cancer Link. These are all Badan welfare. Chairperson of Malay Male Welfare Fund. And you can see the welfare trustee, and so on and so forth there. Council member of the Associations of the Blind. See, another one. The blind, come to her, and she will do something for her. Member of Council of Perkim, Muslim Welfare Organization of Malaysian Women, Perkim, for the women's side. Now she was a council, and now remember this is either is or was, ya, daripada dulu sampai sekarang. Ada yang berhenti dah, ada yang masih sampai sekarang. Council member of Badminton Association of Malaysia. 1994 to 001. And at that time, Malaysian badminton players were champions. Pergi England, jadi champion England, pergi sana, champion sini, sana. Not just a kampung champion. She left in 2001. What happens after 2001? Now she is the trustee of the National Cancer Council, Makna. Prof. Rosnazin is in there juga kan, Makna. Oh, I thought you were there one time. Never mind. And National Heart Institute Foundation. Siapa sakit jantung, siapa sakit cancer, she is there to look after your interests from the top to bottom. And she is patron of Arthritis Foundation Malaysia. Tengok semua orang sakit. Then she is there to do something, to do service to the people who are less privileged. Trustee of National Health Welfare Fund. Kalau mau masuk surga, there are two things which are very important. Surga siapa pun lah. One is education, be involved in education. The other one is health. Health and education. That is the most important thing in life on this earth. You have no education, you are nowhere. You have no health, you'll be don't know where. The nice words of Steve Jobs, read about his last will, his last statement, how he said he had so much money, but he was bedridden. What would I do with my money? Money cannot buy his health. And she is director of the board of the Malaysian Philharmonic Orchestra. Philharmonic Orchestra Petronas. Anak saya is a graduate in music. I'm just waiting for a chance when I could go to her and say, what is the chance that my son can join the apa benda ni, Philharmonic Orchestra? Well, the first chairman of Healthcare Promotion Board for Malaysia. Dulu kan kita nak promote health and so on, she was the first chairman. Patron and trustee, Alzheimer's disease, Arthritis Foundation, mental health. Siapa rasa nak a little bit going cuckoo now? So you have got all this, right? Honorary member of the Inner Wheel Club of KL. And this is something, it is an honor given to people, to persons who have contributed without calculations of interest. Now, in appreciation of her deeds, the lady was awarded the Johan Mangku Negara, JMN. Tun Fatimah Gold Award, the Sri Kandi of this country. Distinguished Fellowship by the IMU. We at the University of Malaya cannot give her any award at the moment, simply because She is the Pro-Chancellor. So therefore, if you want to give her anything, you must remember until she no longer holds any position. I have been waiting for 16 years now. Now, Darjah Yang Mulia Pangkuan Negara Pulau Pinang. Darjah Datuk Paduka Selangor. Darjah Gemilang Pangkuan Negara Pulau Pinang. Dan juga anugerah Saudara Islam Gemilang oleh Jakim. And Golden Heart Award. Golden Heart Award. Hati Emas. Ladies and gentlemen, you are at the moment in the presence of the person whom I have just described to you. Can we see the slide, please? Can we see the slide? Yang amat berbahagia Puan Datuk Seri Hajah Dr. Aisyah Ong. Right, you may sit down there now for me to go on. Otherwise, I will not be able to go on. Now here is an icon for you. Whether you are a man or a woman, you must be inspired by that. Mula-mula, somebody suggested to me, talk about yourself as an icon, as an inspiration. And then I said to myself, I am too small compared to Yang Amat Berbahagia Puan. Much achievement is nothing compared to that. So I should present to you someone yang saya rasakan can be an icon to you, be inspired by her achievement. Set up the goal. Now, Yang Amat Berbahagia Puan Datuk Seri Hajah Dr. Aisyah Ong married Allah Yarham Yang Amat Berbahagia Tun Datuk Seri Haji Omar Ong Yuk Lin. He was a former cabinet minister. Tun Datuk Seri Haji Omar Ong Yuk Lin. And a former Senate, Dewan Negara. Bukan Senate kat Universiti Malaya ya. Dewan Negara. President of the Dewan Negara in 1974. And they are blessed with 3 children. Arifin, Rohani, Taufik. Ladies and gentlemen, saudara sekalian, I've turned to the next page and it is blank. This means that I have finished delivering my lecture. So Puan, thank you very much and thank you very much for coming in. And we have always find a lot of pleasure in meeting you, seeing you. I almost forgot about the next slide. Next slide, please. Now, this is a photograph of Yang Amat Berbahagia Puan. When she was just a little bit older than you all, Ananda sekalian. Yeah, that was her. So, you are all about that age. Sekejap lagi. So, be inspired by that. Be excellent in your dental profession. not only in dental profession, but try to do and pursue your hobby, whatever it is, seriously. Yeah. And then by then you can be considered by others that you have stood up and you are being counted. I must tell you just a simple story. Just give me about 1 minute. I stood up and be counted since I was a boy. My father was all of you know perhaps, was a rubber tapper. Never went to school, cannot read and write. And his wife, my mother, definitely must be the same breed. He can't be marrying a professor. Father said, we have nothing in our life. You stand up and be counted. Be someone. Today I must say to my departed father and my departed mother, Ayah, dan Mak, I have stood up. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Yang Berbahagia Dato' Captain Bersara, Professor Emeritus Dr. Hashim Yaakob, for the very insightful lecture. We will try our best to emulate the respectable figure which you have described, beautifully described, which is Yang Amat Berbahagia, Tuan Pro Chancellor. We would like to request Yang Berbahagia Datuk Captain Bersara Professor Emeritus Dr. Hashim Yaakob to kindly remain on stage.
We now would like to invite our Dean, Yang Berusaha Professor Dr. Zamri Radzi, to present a token of appreciation to our esteemed keynote speaker, Yang Berbahagia Datuk Captain Bersara Professor Emeritus Dr. Hashim Yaakob. Thank you, Yang Berbahagia Dato' Captain Bersara Professor Emeritus Dr. Hashim Yaakob and Yang Berusaha Professor Dr. Zamri Radzi. We will now move on to the photography session. We would like to invite Yang Ahmad Berbahagia Puan Pro Chancellor, Yang Berusaha Professor Dr. Sabri Musa, Deputy Vice Chancellor Student Affairs, Universiti Malaya, Yang Berusaha Professor Dr. Zamri Radzi, Dean, Faculty of Dentistry, Universiti Malaya. Yang Berbahagia Dato' Captain Bersara Professor Emeritus Dr. Hashim Yaakob. Yang Berusaha Associate Professor Dr. Ros Anita Omar, Chairperson of the 25th Universiti Malaya and 3rd International Students Scientific Conference. All the VIPs, lecturers, and distinguished guests to please gather at the center of the auditorium. Everyone, please kindly congregate at the center of the auditorium.
Okay, please everyone, panas sini dulu. Biasa dulu. Ekor dulu. Okay, get it. 1, 2, 3. Sekali lagi. 1, 2, 3. One more. Get it. 1, 2, 3. Okay. Okay, get it. 1, 2, 3. One more. 1, 2, 3. And one big time, please. Get it. 1, 2, 3. One more. 1, 2, 3. And hooray. Thank you.
Thank you. We have come to an end of our opening ceremony. We will now adjourn for a break and refreshments. The VIP guests are kindly requested to proceed to the VIP lounge. Ladies and gentlemen, please remain standing and at your place as the delegation of dignitaries and deans will now leave the hall. To all our distinguished guests, please proceed to the cafe for refreshments and to the foyer for the trade exhibition. See you back at 11:45 for the next presentation session. Thank you.
Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif.
Situ tak sure tapi tadi macam
Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif.
5, 2.
Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif.
Hello.
Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan dia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru Melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, dia sangat efektif. Adakah anda tahu gigi sensitif kebiasaannya
Okay. Ladies and gentlemen, we would now like to proceed with the next group of oral presentations. With that, I now hand over the proceedings to the moderators.
Welcome back to the oral presentation. I, Stephanie Hui Kawai, a Year 4 undergraduate student, am honored to be the moderator for the second session of the oral presentation. For this session, there will be 5 presentations from the contestants. The timekeeper for this session is Noor Anish Shuhada. A gentle reminder to all the presenters, you are given a total of 12 minutes to present your research and 3 minutes for questions and answer session from the judges. Signals will be given by the timekeeper during the presentation as follows. First bell and the green light marks the start of presentation. Second bell and the yellow light marks the 10 minutes of the presentation. Third bell and the red light marks the end of presentation and start of Q&A. Fourth bell, which is a long bell, marks the end of Q&A. You will be notified when the time is up. You will need to stop presenting and begin the Q&A. Gentle reminder, every presenter is requested to introduce your names before starting with the presentation. Without further ado, we will begin with the first presentation of this session. Let's welcome Chong Chi Chi and Lu Zhiyun, number OP5, to present their research on comparison of flexural strength of different thicknesses of 3D printed denture resin. To the presenters, you may begin.
Are you curious about the future of dentistry with 3D printing technology? Imagine the future that dental fabrication is revolutionized by 3D printing technology. I'm Chi Chi.
I'm Ziyun.
We are final year dental student UM. We are honored to share with you our latest research about comparison of fractal strength of different thicknesses of 3D printed denture resin. In this study, we dive into the core aspect of denture fabrication, aiming to shed light on optimal thickness of 3D printed denture-based resin for enhanced durability and functionality. Without further ado, let's dive into our finding. Our content will be divided into 5 parts as shown. So now, let's move on to the introduction. When we talk about denture-based material, the first thing that crosses our mind is PMMA. PMMA is known as polymethyl methacrylate, which is a material being used for a long time since 1930. The composition of material is shown as above. PMMA comes with powder and liquid, which the liquid content is monomer methyl methacrylate. The processing technique of PMMA is known as conventional method, which involves mixing of the powder and liquid into the ratio, processing it into the denture flask, and then continue with hot water bath. At this stage, the monomer will be heat activated into the polymer. PMMA It's a material being used for a long time because it does have a lot of advantages, including the cost, aesthetic, and lightweight nature. However, there are several drawbacks which cannot be ignored, including the processing time and processing technique. This is why a lot of research being done from years to years in order to improve or overcome the drawback of PMMA. I believe that everyone sitting here starting to witness the evolution of denture fabrication from conventional material and method to utilization of 3D printing technology. This technology has low technical sensitivity and stable with high accuracy, which mark a significant leap in dental prosthesis field. So how denture is fabricated using 3D printing technology? First, the denture will be designed using computer-aided design software, and then it will be printed by depositing the material in specific layer orientation and printing orientation and layer thickness. After finishing and polishing, the denture is ready to issue. However, this 3D printed denture faces the same challenge as conventional matte denture, which is a denture fracture. According to this multi-center prospective study in UK, it showed that although clinician preference toward 3D printed denture as well as patient satisfaction in terms of retention and stability, 3D printed denture fracture is one of the unexpected outcome in this. So in order to reduce the incidence of denture fracture, in terms of denture fabrication, we tend to increase the thickness of denture base, as it will increase the fracture strength since we assume that the fracture strength is directly proportional to the thickness of denture base. So what is fracture strength? Fracture strength is simple term is to know the denture base polymer's resistance to fracture deformation experienced during chewing. So in order to achieve a desired fracture strength, we tend to fabricate a thicker denture base which make a patient more discomfort. What if we able to provide a thinner denture base as long as able to withstand deformation and fracture while it provide a greater comfort to the patient? So in our study, we uncover this concerning trend, which is the unexpected fracture incident of 3D printed denture base, which raises a critical question about the true reliability and structural integrity of these seemingly advanced dental processes. And also, the current standard of defining minimum thickness threshold of 3D printed denture-based resin is still inadequate in this field, which is still new. So our study is the effect of thicknesses and material time of 3D printed denture-based resin on fracture strength. And objective of study is to determine the fracture strength of 3D printed denture resin of varying thickness and materials compared with conventional denture resin. Now, hypothesis of study is different thicknesses of 3D printed denture-based material of varying material type have no effect on fracture strength.
I'm June. Let me guide you through on how we conduct our study. We use 3 types of materials, which include 2 types of 3D printed denture-based resin, which group 1 is represented by Denka Denture Base 2, group 2 Nextend Denture 3D+. As for our control, we use heat-curing denture-based polymer, which is PMMA for our last group of the material. The minimum sample size for our study was 10 specimens per subgroup, which was calculated using G-power freeware. For printing of Denka and Nextend specimen, we first designed the specimen using Blender 3.0 software and Autodesk Mesh Mixer software to clean and clear the mesh. The dimension of the specimens were determined based on ISO standard, which has 10 mm of width, 65 mm of length, and 3 different thicknesses, which is 2.5 mm, 3 mm, and 3.5 mm. Then, we printed the specimen out using SprintRay Pro 95S 3D printer unit and 90-degree printing orientation and 50 micrometer layering thickness. After that, post-polymerization of the specimen were conducted using SprintRay Pro Cure Light Polymerization unit. For fabrication of PMMA specimen, we first duplicated 3D printer denture-based specimen using duplicating silicone in a denture flask. After that, 3 modeling wax was melted into the mold to make wax bar specimen, and 3 wax bar specimen of same thickness were invested into a denture flask. After that, second half of the denture flask was filled with stone. After the stone has set, the denture flask were immersed in hot water for dewaxing. And then, all PMMA specimens were fabricated using the conventional method. We also do finishing and polishing for all the specimen. And before we proceed with the flexural test, we verify the dimension of each of the specimen using digital caliper. In order to investigate the flexural strength value for our specimen, we decided to use 3-point bending test under universal testing machine. And the specimen will be placed on 2 supports of diameter of 5 mm. They were spaced 50 mm apart, and all specimens will be loaded under 5 kN load cell and a rate of 5 mm per minute. And all of the specimens will be loaded at the center until fracture occur, and all fracture fragments will be collected for future reference and investigation. The flexural strength value for our specimens were calculated using this formula by the software, which F stands for the maximum forces exerted on the specimen, L is the distance between the support, B is the width of the specimen, and H is the height or the thickness of the specimen.
After all the data are collected, the data was analyzed statistically using SPS software. So now let's look at the result. You can see in the graph, generally Denka show the highest fracture strength among all these three groups in any thickness. And for the next stand, it shows the lowest fracture strength among these three groups in any thickness. But are these values significant? So in comparison of fracture strength between different thicknesses of same material, we can see that for conventional PMMA, there is no significant difference shown among all these three thicknesses, as well as for group Nexen. For the group Denka, there is significant difference when they're comparing each other at each thicknesses, except when comparing 2.5 mm and 3 mm. We also compare the fracture strength between different material at same thickness. So at the thickness 2.5 mm, there is significant difference across all the group when they're comparing each other, and Denka show the highest fracture strength while Nexten show the lowest fracture strength. At thickness 3 mm, there is significant difference when comparing each other among these three groups, except when comparing Denka and PMMA. But both group is higher than the group Nexten. In the thickness 3.5 mm, Denka, there's significant difference across all these three groups when comparing each other, while group Denka remains the highest fracture strength and group Nexten show the lowest fracture strength.
After getting all the results, we can come to a conclusion that our null hypothesis was partially rejected. This is because Nexten and conventional PMMA show no significant difference across different thicknesses group. This is suggesting that there's relative independence of flexural strength from the material thickness. Clinically, this allows fabrication of thinner denture base that will provide more natural feel, more natural speech, and more comfort to the patient. While for Denka specimen, there's significant difference across different thicknesses group, except when we are comparing 2.5 mm and 3 mm group. And this result is suggesting that change in the thickness of Denka specimen by 3 mm or above only will affect or change its flexural strength. Let me help you to put this in sequence. Generally, Denka has the highest flexural strength, followed by conventional PMMA and Nexten specimen. So why do the outcome differ so drastically, even though Denka and Nexten are being produced from the same technology, which is 3D printing technology? This is because mechanical properties of 3D printed denture-based materials also affected by factors like printing layer thickness, laser speed, laser intensity, printing angle, and printing direction. But however, in our study, all of these factors have been standardized. Then what is the reason leading to Nexten having the lowest flexural strength, especially when it is compared with the Denka specimen? We believe it might be due to the manufacturer factors. This is because 3D printed denture-based materials have been evolving dramatically recently, and the manufacturers have been trying hard or working hard to improve the mechanical properties of the materials. So the difference in flexural strength value between Denka and Nexten is believed to be caused by the material itself. According to ISO 20795-1 2013, the minimal ultimate flexural strength for denture-based polymer should not be less than 65 megapascal, and all tested 3D printed denture-based materials in our study fulfilled this requirement and thus suitable for denture fabrication. Interestingly, there's some supplemental finding in our study, which is the fracture pattern demonstrated by our specimen. As we can see from the photos here, Denka specimen fractured into multiple pieces under loading of universal testing machine, while for Nexten and conventional PMMA specimen fractured into half at the center under the loading of universal testing machine. Why do Denka has this kind of unfavorable fracture pattern under universal testing machine? We believe that there might be a few possible causes, like the material defects, inhomogeneities, impurities, voids, or other defects. These effects can act as a stress concentrators to initiate crack and make crack propagate in an unexpected direction. Second, the material properties itself, like hardness, toughness, and ductility. Material with low toughness and ductility can more prone to brittle fracture and unfavorable fracture pattern. And due to this unfavorable fracture pattern, we can foresee the future challenges that we might face when we want to repair denture made from Denka material clinically.
Now that we have dived into the coach aspect of our study, it's important to recognize the limitation inherent in our study. First, our experiment is done in vitro, which is a laboratory test. It provides valuable information about mechanical properties of 3D printed denture-based resin. However, 3D printed denture shall be evaluated as well in clinical practice. Second, the thicknesses in our sample use is limited, which we involving only three thicknesses, which is 3.5 mm, 3 mm, and 2.5 mm. With the development of 3D printing technology, thinner denture base may be evaluated as well. So, based on our finding, we can draw the following conclusion. Both materials and thickness exert significant effect on fracture strength of 3D printed denture-based resin. Second, the fracture strength of the tested 3D printed denture-based resin were higher than the ISO standard at the minimum tested thickness, which is a 2.5 mm. That's all for our presentation, and we would like to take time to acknowledge Dr. Jimmy for providing 3D printed sample, Lab for providing UTM machine during experiment, and Lab Student Lab for providing guidance during sample preparation. Thank you.
Thank you, presenters. Now, I would like to open a Q&A session to the judges.
Thank you very much for your presentation. When I look at the fractured portions of one of the material, we can see various. So have you looked into the printing fidelity?
Thank you for question, doctor. For our sample being used, they're actually printing in the same printing setting for Nexen and Denka.
Do you know what is printing fidelity? You're doing 3D printing, right? It's okay if you don't. Do you know or you don't know?
Sorry, doctor, we don't understand so much.
Okay, that's fine. That's fine. I can move to another question.
Thank you, doctor.
Your sample, you have thickness, you have material.
Yes.
So your data may be influenced by the interaction because you do one-way ANOVA, but you have two variable. Can you comment on that? Why do you use one-way ANOVA when you have two variables? One is thickness and one is material.
Because, thank you for your questions. Under the guidance from the statistician from our faculty, we decided on one-way ANOVA statistical test because we separated the comparison, which is, for example, we compare the materials, same materials at different thickness. And another one is we compare different materials at the same thickness. So in each comparison, we only use one variable that's changing. So that's why we choose one-way ANOVA.
Yeah, but that's not that's not true because there may be interaction between material type and thickness. So if you do a two-way ANOVA, you will see whether there is interaction between that or not. So you cannot treat it independently. Okay, so there may cause some. There is some information that is missing.
Okay, I want to ask you just one question. Okay, I know you are doing it in the lab, but you imagine yourself as a clinician. Which would you recommend? At what thickness? And what about cost factor?
Thank you for your questions. As we can see from our result, our Nexten and conventional PMMA, there's no significant difference in flexural strength across all thicknesses. So we recommend a clinician to go for thinner denture base for greater patient comfort because even if you increase the thickness, the flexural strength will not increase as well. But if for the clinician is going for Denka material, and if the clinician wish to increase the flexural strength of the denture base, then he can go for 3 mm or above thickness because other than that, the thickness has no significant difference in flexural strength value. Thank you.
Thank you, judges. Now, I would like to welcome our next presenters, Tan Ziliang and Tan Kesin, number OP6, who will be presenting on morphology and characterization, comparison between various calcium phosphate and bioactive glass. To the presenters, you may begin.
Ladies and gentlemen, imagine for a moment that you possess a key to unlock a material that is so tiny yet so mighty they have the potential to revolutionize the landscape of medicine. Welcome everyone, I am Kesin and this is my partner Ziliang. Today, we are diving into the world of biomaterial to explore on the topic of morphology and characterization comparison between various calcium phosphate and bioactive glass. This is our table of contents. Ladies and gentlemen, I'm pretty sure that all of you are very familiar with the word bone graft, right? So when we talk about bone graft, it can be referred to bone augmentation. That means we put the new bone into an existing bone and cause our body to stimulate the new bone in that space. So where are we today? There are actually 4 types of bone graft material, which includes autologous, allogenic, xenogenic, and lastly, alloplastic bone graft, which is also known as synthetic bone graft material. So our main character in our topic, calcium phosphate and bioactive glass, are actually grouped under the alloplastic bone graft material. So what is calcium phosphate? Calcium phosphate is a type of material that consists of both calcium and phosphate ions. It is biocompatible and osteoconductive, meaning it can stimulate new bone growth and it can integrate well with the surrounding bone tissue. This is why it is widely employed in orthopedic and dental surgery. What about bioactive glass? Bioactive glass, which is also known as SCPC, it consists of calcium phosphate phases, but in addition of silica. It is also similar like calcium phosphate. It has its high biocompatibility and its osteoconductivity. Some of the common uses and applications of the calcium phosphate and bioactive glass include bone cement, implant coating, bone graft material, and lastly, carrier for drug delivery. So why are we using this material in our study? This is because based on the study by Shunsuke 2021, it shows that the clinician nowadays has faced a challenge in choosing the most suitable alloplastic bone graft materials for their patient. This is because these materials are still lack of literature support and this material has varied characteristics. So we have conducted this research with these 2 main objectives. The first objective of our study is to utilize the microscopic technique to identify and to compare the morphology variations between different types of calcium phosphate and bioactive glass. And secondly, we want to characterize the various types of calcium phosphate and bioactive glass. Our null hypothesis of our study is there is no significant difference between calcium phosphate and bioactive glass of their morphology at a microscopic level. So I have outlined the objective of our study. So now let's talk about how we can conduct our study. So there are a total of 5 types of material that we use in our study. Firstly, alpha tricalcium phosphate, in short, alpha TCP, beta tricalcium phosphate, beta TCP, hydroxyapatite, HAP, tetracalcium phosphate, TTCP, and lastly, bioactive glass, which is also known as silica calcium phosphate composite, in short, SCPC. All of the calcium phosphate material we get from the manufacturer from Taihei Industrial Company from Japan, and the bioactive glass granule, we get it from the Shefa bone from United States. So all the sample has undergone the morphology analysis by using these 3 key techniques, which includes scanning electron microscopy, which is SEM. From this, we can know about the particle size and shape. And for Fourier transform infrared spectroscopy, FTIR, from this, we can know about the information of the molecule and the functional group that contains in the sample. From XRD, X-ray diffraction, we can know about the crystal phase that's present in our sample. So all the data collected will be processed and analyzed by using their respective software.
Thank you, Kersing, for passing me the mic. I'm Ziliang and I will guide you through the most exciting part of our research today. So here comes our result. First and foremost, let's have a look at SEM. So these are the images that we have obtained under scanning electron microscope under 3000 magnification. After processing with the software, we identified this table. In this table, there's two main components that is very important. That is the area, which represents the grain size of the particle, and the mean gray value, which is the porosity. And to put them into comparison, TTCP stands out as the material with the largest grain size, and bioactive glass is the material with the smallest grain size. With bioactive glass as the material with the smallest grain size, bioactive glass displayed the highest porosity level, and HAP is the material with the lowest porosity level. What about shape? So all the materials basically display shape that is quite similar to each other, that is spherical in nature. Except for TTCP, it is the only one material that has complex structure with neck-shaped regions. Next, let us have a look at the FTIR. From the spectrometer, we have discovered certain functional group across each sample. And to put them into comparison, all samples contain of phosphate vibration and carbon dioxide vibration. Bioactive glass was the only one sample that has the additional silicate vibration. And for XRD, this is the result that we have obtained after cross-referencing with the JCPDS cards. We have successfully identified the crystal phase for each materials. For beta TCP, it showed weak locate mineral phase, HAP showed apatite phase, TTCP displayed multi-phase nature, and bioactive glass displayed cristobalite and quartz phase. Now, let's move to our discussion. Firstly, for scanning electron microscopy, alpha TCP with the materials that is a small size particle and petal shape, it has the ability to improve the particle cohesion, thus forming a material with increased mechanical strength. Beta TCP is very similar to alpha TCP, but it is better because the compact configuration compared to alpha TCP. With the compact configuration, it has the ability to enhance hemostatic events and form crystal of higher mechanical strength. On the other hand, if you have a look at HAP, being the least porous materials, it is unfavorable for bone implants because the lacking of 3D porous networks to facilitate bone cell migration. TTCP has the largest area, which exhibit neck-shaped regions and enhanced microstructure, and their grain boundaries lead to crystals of greater fracture toughness. Finally, bioactive glass with the smallest area and optimal porosity has the ability to exhibit enhanced resorbability. From the FTIR, we have confirmed all samples consist of phosphate bonds, and bioactive glass has the additional silicate bond. So the implications of the silicate bond is the increase in bioactivity and increase in mechanical properties in bioactive glass. And to put this into a visual diagram, so in physiological condition, phosphate groups is formed within the apatite crystals. With the addition of silicate group, the silicate group can substitute the phosphate group and form crystals of larger volume and larger compactness, thus increasing the crystal mechanical strength. Finally, before I move to XRD, due to the carbon dioxide absorption from the atmosphere, all samples presence of carbon dioxide vibrations, and this is because that we stored the samples under room conditions. Next, for our XRD, beta TCP has matches with liquid locate mineral phase, and HAP has the apatite phase. However, we have discovered a very small amount of rhyonite and beta TCP, which is identified as secondary and minor phase, and this is due to the thermal decomposition of beta TCP. For TTCP, it is multi-phase nature, which means that the crystal formed by TTCP is of irregular pattern. And this is particularly because synthesis of TTCP involves the co-precipitation of HAP and calcium carbonate and the process quenching. Finally, bioactive glass showed XRD patterns of alpha cristobalite and quartz phase. This has suggested there is calcium silicate and calcium silicate molecules has formed at the crystal lattice. And with that in mind, we can deduce that there's no significant difference between calcium phosphate and bioactive glass in their morphology at the microscopic level. And hence, our null hypothesis for our study is accepted.
Now, ladies and gentlemen, let me make a conclusion for our study. So within the limitation of the in vitro study,
TTCP exhibit the largest size with the neck-shaped appearance, while bioactive glass has the smallest size with compact structure. Lastly, HAP has the lowest porosity, which is unfavorable for the bone graft and implant. All the sample contains mainly phosphate bond. Except for the bioactive glass, it has an additional of silicate bonding, which improves its in bioactivity and the mechanical strength. For XRD, unique diffraction pattern identifies different crystal phases across all the samples. We also encounter some limitations in our study. The first limitation is that we have exclusive reliance on sample from a single company. And the second limitation is that all of our sample only have a single round of testing. So to address this constraint, future investigations should obtain the sample from multiple companies to provide a more comprehensive understanding of the sample. And secondly, we can also use a more advanced analytical technique, for example, the laser scattering particle size distribution analyzer. And lastly, we can employ Raman spectroscopy to gain more insight into specific molecular vibration. These are our key references. And these are the people that we want to acknowledge. With that, thank you with your kind attention and we welcome for all the questions.
Thank you, presenters. Now I would like to open the Q&A session to the judges.
Thank you. Good presentation. A simple question. Now, could you tell us what is the clinical application or the translational value of your research? You have looked at 5 materials, compared it with bioglass.
Okay.
What is the translational value?
Thank you, Professor, for your question. So, based on a study by Shinsuke on 2021, nowadays clinician is facing a problem that is selecting the suitable material, the allomastic material in specific for the patient. And this is because that each company, they develop a material with its own characteristic. There's no standard characteristic, and the literature support for these materials are actually quite limited, as mentioned in the study. And hence, what are we going to? We are trying to investigate the morphological pattern and develop a formula which is suitable for most of the patient. And in turn, we want to suggest the manufacturer or develop a material that can actually suits the patient with a strong literature support and provide the best treatment outcome for our patient. This is the transitional value.
Hi. I noticed that you also put pore size and porosity as one of the important parameter, right? For
Yes,
bone graft material. What was the, I wasn't clear about the results because the porosity is one of the most important.
Yes.
Between those graphs, which one, which is the give the best results?
Okay, there is no one result that overcomes the other result. But based on porosity, HAP is the result. HAP actually display the lowest porosity and hence is unsuitable to use as bone engraft solely because it actually it does not facilitate the bone cell migration. So preferably we have to use the result the powders in combination so we can get the properties in between both materials. Thank you, Prof.
Thank you, judges. So for now, I'm pleased to introduce to you our next presenters, Wei Zhiwei and Suprini Anapurampan 9 people, number OP7, to present their research on perception between orthodontists, orthodontic postgraduate students, and patients on orthodontic treatment needs assessment using conventional and modified index of orthodontic treatment need aesthetic scale. To the presenters, you may begin.
Good afternoon, honorable judges, distinguished guests, ladies and gentlemen. Imagine a world where every smile tells a unique story, where the artistry of orthodontic care allows the pursuit of perfection. Today, we delve into this fascinating world of aesthetic perception and its profound implication on orthodontic treatment. I'm Uizi Wei, and it's a pleasure to be here alongside Suprin Yi as we present insight from our research titled Perception Between Orthodontists, Orthodontics Postgraduate Student and Patient on Orthodontic Treatment Needs Assessment using conventional and modified as Index of Orthodontic Treatment Need Aesthetic Scale. Let's take a quick look at the roadmap of our presentation. Ladies and gentlemen, malocclusion not only leads to dental issues such as caries, but also significantly impact aesthetic, affecting an individual's psychosocial well-being. To categorize malocclusion according to the level of treatment need, a variety of orthodontic indices have been developed. Among these, the Index of Orthodontic Treatment Need IOTN stands out and is globally recognized. IOTN comprises two elements, the dental health and the aesthetic component AC. Our research focuses on the latter, which consists of 10 colored photographs illustrating different levels of dental attractiveness, ranging from grade 1 to 10. However, limitation of AC has been noticed where certain features were not displayed, such as class 3 incisor relationship or anterior open bite. This is critical as based on the annual report by Ministry of Health, class 3 malocclusion was ranked third among the type of orthodontic cases treated. Hence, to address this, a modified aesthetic scale was developed among the Malaysian population, featuring 16 photographs. This scale includes additional abbreviations starting from grade 5, incorporating more types of malocclusion features. In 2013, a local study was carried out using the validated MA. 16-year-old school children and one single examiner took part in the assessment. There was higher agreement between school children and the examiner when applying MA compared to the conventional AC. Building upon this, our study expanded the age range to 18 to 30 years, and we included orthodontic postgraduate students to compare their fresh perspective against the expert orthodontists. By undertaking this study, we aim to address the following research question. Firstly, is there any aesthetic grading difference among orthodontists, postgraduate students, and patients by using conventional aesthetic component of IOTN, CA? Secondly, by using modified aesthetic scale, MA. And thirdly, does the modified aesthetic scale better represent the aesthetic perception of the raters? Therefore, we conduct this study to compare and evaluate the difference in dental aesthetic grading among orthodontists, postgraduate students, and patients by using CA and MA.
Thank you for the insightful introduction. Our research began with ethics approval from the Medical Ethics Committee. Training and calibration was conducted for both skills among the orthodontists and postgraduate students who involved in our study. Our study was conducted on patients who attended orthodontic postgraduate clinic from April to August 2023. After that, grading among the raters and data analysis was conducted. Now, let's meet the three groups responsible for assessment of orthodontic treatment need. First up, the patients. We recruited consenting individuals from 18 to 30 years old who completed at least secondary education. According to our calculation, we need at least 77 patients to achieve statistical accuracy. And for our study, we managed to get 82 patients. Other than that, 5 postgraduate students and 3 experienced orthodontists joined the ranks. Patients were being guided step by step to perform their self-evaluation. Sitting upright on the dental chair under sufficient lighting, CA followed by the MA was displayed to the patient. The patients were asked to compare their dentition to the images and choose the closest match for both skills. After that, intraoral photograph was taken with standardized camera setting. No image angle correction was allowed post-capture. These photographs were then digitally stored and renamed with the patient's registration number to be evaluated by the orthodontist and the postgraduate students. After we gathered all the data, we regrouped the data according to the IOTN guidelines which mentioned that grades 1 to 4 indicates no or slight treatment need. Grade 5, 6, and 7 suggest a moderate need, while 8, 9, and 10 signifies a great need for orthodontic treatment. Our data analysis was conducted using SPSS version 26. We began with analyze the patient's demographic. Other than that, we also utilize heat map analysis. Unlike the traditional numerical analysis, heat map allows us to have a visual view of a large data set and allow us to compare the dental aesthetic grading between the raters and also both scales. Chi-square test was also being used by us to compare the differences among grades in each group between CA and MA.
Moving on to the result, among the 82 patients, there were more females, most of them aged between 20 to 24 years old, and Chinese constituted the majority. Let's look into the distribution of the grading categories for each group of raters. Starting from patient, while using CA, the majority of their self-gradings falls into no or slight need category. But with MA, the most falls into moderate need category. A similar trend was seen among the postgraduate student where the most graded category shifted to moderate need when MA was used. Among the orthodontists, there was no common consensus on the most graded category when applying CA, but with MA, we observed the most grading falls into moderate need. The heat map visually represented the majority aesthetic grading assigned by patient, orthodontist, and postgraduate student. Our color scale ranged from gray to yellow and finally green, representing different need category. The bar chart on the right displays the percentage. Looking at this CA heat map, the patient column was mostly shaded in gray, with 81.7% categorized as having no or slight need. For orthodontists, a more balanced distribution of gray and yellow shade can be observed. For postgraduate students, we predominantly observe gray shades with 65.9% categorized as no or slight need. From this CA heat map, it shows the grading agreement among 3 rater groups was not great. Moving on to the MA heat map, from the patient column, we observe a similar distribution of gray and yellow shade. While for orthodontists and postgraduate students, we observe most yellow shades. Comparing the two heat maps, we observe a shift in shades towards yellow and green in the MA heat map, suggesting a notable increase in moderate and great need category when applying MA. In addition, MA heat map also shows a more harmonious color pattern, suggesting a higher level of agreement among the raters when applying MA. Chi-square test results show no significant difference between CA and MA when used by patient. However, significant difference can be seen between the two scales when used by orthodontists and postgraduate students.
Moving on to discussion. Age is a pivotal factor in our study. The inclusion criteria of 18 to 30 years old individuals align with the latest definition of youth by National Youth Development Policy in Malaysia. This age range of patients is believed to have a comparable cognitive ability, similar self-awareness level, and dental health status. When using CA, most patients' grade fall into the no or slight treatment need, which is in contrast to the common belief that patients seek orthodontic treatment mainly due to aesthetic purpose. We can explain it by there's actually diverse factors influencing patient decision for orthodontic treatment, not only the aesthetic. While for MA, majority patients' grade shift to moderate treatment need. The shifting to a more severe category when using MA can be due to the limitation of CA, which is no class 3 malocclusion features included. Chi-square test revealed that there is no significant difference between CA and MA for the patients. This is because lay people has limited capability to assess their malocclusion and they are not familiar with the assessment. The opposite result gotten by the orthodontists and postgrad students further revealed that clinicians focus more on the malocclusion features and severity compared to the layman. For each subgroup, variation in giving the aesthetic grades is noticed. This is because of the diverse perception in dental aesthetic assessment among individuals. Around the study, we also realized that orthodontists give a more uniform gradings compared to the postgrad students. This can be attributed to the different professionalism, clinical experience, and educational background. For future study, we would like to suggest for a larger sample size to enhance the statistical power and have a more comprehensive understanding for the study. Another limitation for our study was the reliance on selecting the majority's grade for the subgroup. This may produce the subjectivity. To overcome this, we might utilize another more advanced statistical analysis, or maybe we can build out the consensus among the graders.
Ladies and gentlemen, for conclusion, let's highlight a few key points. We observe distinct pattern in aesthetic perception among raters when applying CA, suggesting poorer inter-rater agreement, answering our first research question. Our second research question is also answered, in which we observe consistency in assigning moderate grades among the raters when applying MA, suggesting better inter-rater agreement. The answer to our third research question is yes, as we observe higher agreement among them when MA is used. Hence, we do recommend incorporating MA in Malaysia, which will enhance the accuracy of the assessment and also better represent the treatment needs of our local population. Our study offered valuable insight in clinical practice. We have to understand the discrepancy between patient and also professional assessment. And also, we have to emphasize the importance of incorporating patient expectation in treatment planning to achieve a more patient-centered care. MA will also optimize the communication between patient and clinician. These are our references. These are our acknowledgement, and thank you very much.
Thank you, presenters. Now I would like to open the Q&A session with the judges.
Thank you very much. Very interesting presentation. Yeah, well done. Just that I noted that when you were using the MA, it was first verified by only one orthodontist. Yeah. I mean, when you were going to use it last time, I noticed that you said only you verified that
the
with one
previous study,
orthodontist.
Yeah.
Then how can you recommend that the MA to be used at the national level?
Actually, based on the previous study, only one examiner was involved in the assessment, but the examiners has been calibrated by two other orthodontists.
I see. For this one, you are using 3 orthodontists. Are
Yes.
they calibrated?
Yes, we have
They're
conducted a
calibrated.
calibrated test.
Yeah, so I didn't see the results of the calibration. Yeah. So, so the other one is when you were doing on the when you said you mentioned the verification was done on 16 years old, but you didn't mention how many you were involved. Is it just one 16 years old?
I think around, I don't remember the exact number, but it's
Okay.
around 200 something.
Yeah, but you need to have details, okay? Because then it shows up a different picture altogether. Okay, and then my impression from your presentation is that for the patients, they are actually being pressured as a peer pressure thing, isn't it, to go for orthodontics treatment? Do you think so?
Sorry, Prof, come again.
Because you were saying that, you know, towards the end of the presentation, to us, it looks like this is a peer pressure thing. They go for treatment, orthodontic treatment, not because there is a need for it. For the patients, from the perspective of patients.
Thank you, Prof, for the question. No, this is because throughout our study, we realized that majority of the patients come seek for orthodontic treatment, mainly due to the aesthetic purpose. But of course, there is also diverse factors influencing their aim to have auto treatment, but we can't deny that aesthetic plays a main purpose.
Yeah, because the orthodontists and the postgrads, you know, they are the one who shows up the need for greater treatment needs. You know, they're going to go bankrupt if the patients decided not to come. Okay, any questions?
Yeah.
30 seconds, judges.
Now, your assessment, MA showed very good results with students and orthodontists, right? The addition to that compared to CA is the class 3, right? You think the general population think class 3 is acceptable?
Yeah, I think it is not acceptable. That's why we incorporate MA so that they can actually evaluate their aesthetic perception better by using this modified scale. Yep, thank you.
Thank you, Prof.
Thank you, judges. For our next presentation, I would like to call upon Joycelyn Lai Under and Wu Wei Ni, number OP8, to share their presentation on effect of Lactobacillus helveticus exposure on the expression of Porphyromonas gingivalis fimbriae genes. To the presenters, you may begin.
A very good afternoon to our esteemed judges and dear audiences. Welcome everyone. My name is Joycelyn Lai and she is Uwini. Today, we will be presenting our research titled Effect of Lactobacillus helveticus Exposure on the Expression of Porphyromonas gingivalis fimbriae genes. These are the content of our presentations today. Ladies and gentlemen, have you ever wondered how much of bacteria are inside our mouth? So our oral cavity is actually...
I'm sorry to interrupt. There is some glitch currently. Please bear with us. Okay, to the presenters, you may start again.
So, a very good afternoon to our honorable judges and dear audience. Welcome everyone. My name is Joycelyn and she is Uwini. Today, we will be presenting our research titled Effect of Lactobacillus helveticus Exposure on the Expression of Porphyromonas gingivalis fimbriae genes. So these are the content of our presentations today. Ladies and gentlemen, have you ever wondered how much of bacteria are inside our mouth? So our oral cavity is actually a habitat that harbors a diverse array of microorganisms. And Porphyromonas gingivalis is one of the anaerobic opportunistic microorganisms, which is also known as rat complex in periodontitis. So they can cause disease due to one of their virulence factor, which is fimbriae. So this is a bacterial cells, and when we zoom in, this is how fimbriae looks like. So they are responsible in the initial colonization of the bacteria, as well as they are mediating the host cell invasion, which could eventually lead to periodontitis. In our study, we focus on the subunit protein of fimbriae, which is FimA. And due to the nucleotide sequence variations, we have subtype of FimA genes, which are type 1, 2, 3, 4, and 5 FimA. There's a recent proposal proposed that to manage the recolonization of periodontal pockets by harnessing the potential of probiotics. Clinically, we manage the periodontitis patient by non-surgical periodontal therapy. However, we know that the nature of periodontal therapy itself warrants a long-term follow-up. Hence, today, if probiotics has a potential to be one of the adjuncts in periodontal therapy, and that will be amazing. So in our study, we focus on the Lactobacillus species, which is Lactobacillus helveticus. L. helveticus is a lactic acid bacteria which can enhance the protections against the oral pathogen. In previous study, most tested probiotics can reduce the adhesion and colonization of the pathogens, which can result in the destruction of destructive organism response. So, do you think L. helveticus have a potential effect on the expression of FimA genes by P. gingivalis? Therefore, we came up with our objective to identify the presence of FimA genes when we expose our P. gingivalis culture to Lactobacillus helveticus. Moving on to our methodology. After obtaining the ethical approval, we started our study with the bacterial growth and plating. We cultivated the P. gingivalis on the BHI blood agar plates and we incubated them overnight at 37 degrees Celsius by using anaerobic gas pack. Also, we cultured L. helveticus on the Lactobacilli MRS agar at 37 degrees Celsius.
Gram staining was done to confirm our culture and we were examined under the microscope. And then we resuspend the P. gingivalis and L. havaticus on the BHI broth and we incubated them overnight at 37 degrees Celsius. Here, we can appreciate the Lactobacillus havaticus colonies on the Lactobacilli MRS agar, as well as the P. gingivalis black pigmented colonies on the blood agar from the first two images starting from your left. Well, for the gram staining, we were able to obtain the violet coloration of L. havaticus as they are gram-positive rods, and for the distinctive pink coloration of P. gingivalis since they are gram-negative coccobacilli. And then we expose the P. gingivalis to L. havaticus. So in our study, we have two main groups, control groups and test group. So in our control group, we have P. gingivalis culture and BHI broth, whereby in our P. gingivalis culture, we have 10 to the power of 8 of Porphyromonas gingivalis cells. And in our test group, we have P. gingivalis culture and L. havaticus culture together, and their cells ratio was 1:1. We run our study in technical triplicate, and hence we have C1, C2, C3 for the control group and T1, T2, T3 for the test group. And then we expose the P. gingivalis to L. havaticus for 24 hours, 48 hours, and 72 hours respectively. Besides, we also run our study in biological triplicate, which means the whole cycle mentioned previously was repeated twice. Hence, we came up with cycle 1, cycle 2, and cycle 3, and the reason behind it is because we wanted to enhance the reliability and reproducibility of our study. So now, we have 18 samples for each cycles, so with a total of 3 cycles now, we have a total of 54 samples in our study. And then, after 24 hours, 48 hours, and 72 hours of exposure, we extract the RNA by using the total RNA extraction kit and following their protocols. Then, once we get the RNA extracted, we use the spectrophotometers to measure our RNA purity. The extracted RNA was stored in negative 80 degrees Celsius. And then, we can proceed with the cDNA synthesis by using the cDNA synthesis kit. Again, we use the spectrophotometer to measure the ssDNA purity. And the cDNA products was stored in negative 70 degrees Celsius. After that, we can proceed with the polymerase chain reaction PCR. So in our study, we use gene of GAPDH as our positive control. And then we start our PCR by mixing the PCR sample and following their protocols. And then we run our PCR in Verity thermal cycler. So in our PCR, we have 5 steps: initial denaturation, annealing, extension, and final extension. So as you can see, we have different temperatures and duration for each step, and we would have to transfer all the data into the PCR machine before we start running the PCR cycles. Up to this point, I would like to highlight on one phase, which is annealing step. It is a little bit crucial for us to always ensure that the annealing temperature is 5 degrees Celsius lower than the melting temperature of each primer. After that, we can proceed with the gel preparation. So in our study, we made our own agarose gel powder in TAE buffer, and this is one of our gel samples with 25 lengths in total. So as you can see, our first length is always reserved for the gene ruler DNA ladder, while the rest of the lengths in our gel were our PCR samples. So once the gel is ready, we can proceed with the gel electrophoresis under 100 voltage with a duration of 30 to 40 minutes. After the gel electrophoresis, we can finally proceed with the gel imaging. So in our study, we were using Odyssey XF imager to obtain all of our digital image of our gels. And finally, we can continue our study with the results analysis.
Good day, everyone. My name is Winnie. Now I'll bring you into the results of our study. So, does L. havaticus affect film aging expressions in P. gingivalis? Let us look at the outcomes of our gel imagings. Ladies and gentlemen, may I have your attention on the first picture from the left, which we have NTC and GAPDH. For your information, we use NTC as our negative control in the PCR cycles and GAPDH as our positive control. So, what is NTC? NTC is known as no template control, which we didn't include any sample of cDNA in the PCR cycles. That's why the length of NTC appears empty. Next, we have GAPDH as positive control, and this is the bands produced by our gene of positive control. Now, let us look at the bands produced by type 1 film aging on your right side. So as we can see, LAN 1 to LAN 3, which contains P. gingivalis and L. hepaticus as our test group, showing dimer bands compared to LAN 4 to LAN 6, which contains P. gingivalis only as our control groups. So what this indicates? This indicates that when P. gingivalis is exposed to L. hepaticus, type 1 film agent expression in P. gingivalis is reduced. Next, let us look at the bands produced by type 3 film agents. As you can see, all the bands from LAN 1 to LAN 9 showing the same intensity, right? This indicates that L. hepaticus has no effect on type 3 film agents of P. gingivalis. Moving on to the quantitative analysis of our results, we can conclude that L. hepaticus only caused slight reductions on type 1, type 2, type 4, and type 5 film agents, and caused no reductions on type 3 film agents. Next, our statistical analysis also showed that the p-value is greater than 0.05, which means our result is insignificant and our null hypothesis is accepted instead of hypothesis. Going into discussions, our hypothesis that state that there is a negative correlation between L. hepaticus exposure and the expressions of fimbrogen's expression is rejected. This is because L. hepaticus only caused minimal reductions in type 1, type 2, type 4, and type 5 film agents, and caused no reductions at all at type 3 film agents expressions. However, there is a study state that in 2022, probiotics such as LA5, Lactobacillus rhamnosus, and Lactobacillus reuteri is able to reduce the amount of P. gingivalis. They support our findings that L. hepaticus as one of the strain of probiotics also able to reduce film agent expressions even though it's not completely inhibited. No matter how, we are unsure about the methods of inhibitions by L. hepaticus and the amount of reductions in P. gingivalis. So, we suggest to further study to quantitate the exact amount of gene expressions by RT-PCR and qPCR. Besides, we also suggest to study the effect of L. hepaticus on other subunit proteins such as SYNC, FIMD, and FIME because they are also important virulence factor of P. gingivalis by the assembly of fully functional fimbrate. Going into limitations of our study, we cannot overcome the smearing of bands and the formations of primer-dimer, which they are both caused by inappropriate primer concentration and annealing temperature. To achieve an accurate primer concentration and annealing temperature, multiple cycles of optimization is required and time has become a great limit for us. Besides, it's also tricky to prevent degradations of RNA to maintain its stability because RNA need to be always stored at negative 80 degrees Celsius and it highly depends on RNA's free water. Due to that, in our study, we have actually repeated for multiple low purity samples to achieve a normal range of purity which is from 1.7 to 2.3. In conclusion, our findings reveal that film agent expressions was reduced minimally when P. gingivalis bacterial cells is exposed to L. hepaticus, resulting in statistically insignificant outcomes. However, how this conclusion impacts us clinically? First, we can see the ability of L. hepaticus to reduce virulence factor of P. gingivalis to a certain extent. Hence, we believe there is a potential of L. hepaticus to be used as probiotic as adjunct in non-surgical periodontal therapy. However, is probiotic as adjunct reliable? The answer is yes. Providing with patients self-care, oral hygiene maintenance, and probiotic as adjunct, we believe we are able to reduce biofilm formations and reduce P. gingivalis recolonizations in the periodontal pockets, resulting in a more stable periodontium and reduced plaque score. So this will be a more natural way to combat periodontal disease in long term in the future. This is our reference, and with that, we would like to thank you for listening. That's all from us.
Thank you, presenters. Now I would like to open the Q&A session to the judges.
Thank you. Good presentation. Now, I just want to ask, what led you to hypothesize there is a relationship between Lactobacillus helveticus and Porphyromonas gingivalis?
Yeah, thank you for the questions. Because before we started our study, actually based on the previous evidence, that shows that the probiotics has an effect on the P. gingivalis, which is on the clinically, P. gingivalis can be reduced on the gingival epithelial cells when we apply probiotics into it. So probiotics has a lot of bacterial strains, and Lactobacillus helveticus is one of the strain in the probiotics, and hence we proceed with the Lactobacillus helveticus.
Right, good. And as you correctly said, there are different types of fimbriae in Helveticus, P. gingivalis, A, B, and C. But you have selected Fim A. Any specific reason?
So we actually plan to study the effects of L. helveticus on film A, B, C, D, and E of P. gingivalis. But due to time matters, we have actually lack of time in that because we need to do optimizations for each fimbriae for every type of fimbriae. So it has become limit for us to finish it within time. Yeah.
Do
So
you have
Prof,
any explanation why Fim A type 3 has no significance at all?
Okay, so based on the result we showed just now, we can see that all the bands which is produced from the gel imaging showing the same intensity. So this indicates that no band is dimmer from our control group, which is P. gingivalis and L. helveticus. So this indicates that L. helveticus is not able to inhibit the Fim A expressions, type 3 Fim A expressions in P. gingivalis, while others actually showing reduced band intensity compared to our control groups.
Okay, thank you.
Time's up. 30 seconds left. Okay, thank you, judges.
Okay, thank you, everyone.
For the last presentation of the second session, I would like to welcome Muhammad Hafizuddin bin Hamzan and Siti Aisha binti Sharil, number OP9, who will be presenting on oral health-related quality of life and associated factors among urban poor children and their families in Klang Valley. To the presenters, you may begin.
Imagine a small child, a window to their happiness, wellness, and also their health. And now, picture that smile is affected by many factors impacting not only on their oral health, but also the overall quality of life. Assalamualaikum and a very good afternoon to esteemed judges and fellow members of the floor. I'm Hafizuddin Hamzan, and this is our research topic, oral health related quality of life and associated factors among urban poor children and their families in Klang Valley. Here are the outline of our presentations. Without further ado, allow me to introduce three important key points from our study. First is oral health related quality of life, which is the influence of dental disorder on daily performance of individual, while the associated factors is factors that contribute to the occurrence of oral impact, such as oral behavior and poor oral hygiene, while poor urban children that defined by National Statistical Office 2019 as children in poor household living in urban area with significant social and economic challenges. And this is due to social and economic inequality, inadequate living condition, and presence of highly developed urban landscape. For the burden of disease shows by the National Oral Health Survey of Preschool in 2015, it shows the prevalence of dental caries was 71.3% with mean DFT of 4.83% among these preschool children 5 to 6 year old. And from other studies, children from less educated families reported to have higher DFT score with mean 3.16
than those in higher education family with mean 2.03, and also reported children from lower household income have higher DFT score 3.17 compared to higher income family with mean of 1.45. For the impact of oral disease on oral health-related quality of life has been assessed in Kelantan in 2019, and it shows the impact on the child frequently reported was pain for 36.7% and having difficulties in eating for 20.8%. And from that, also the impact on the family, such as feeling guilty for 22.5% and feeling the upset 20.2% due to the child dentist problem. And from this study, it shows that the impact on the family is significantly associated with the caries experience. However, there is no study was done previously to assess on the oral impact on poor urban children in the Klang Valley. And as current evidence in Klang Valley, it shows that the social and behavioral risk factor are the significant factors in developing the caries. This is important for us to investigate further to what extent this dental disorder can give the impact on their overall quality of life. From there, we come up with a research question that will be answered by 4 objectives of our study, which to assess the parent-reported oral health status of 5 to 6-year-old poor urban children, to assess oral health behavior of poor urban children and their family, to investigate oral health-related quality of life among poor urban children and the impacts, and to investigate significant factors associated with the oral health-related quality of life of poor urban children. And this is the conceptual framework from our study where we assess on the family and the child background and also their behavior towards the oral health. And this is the 3 items that we didn't assess in our study. Moving on to the materials and method, where we first received our ethics application from Universiti Malaya, and this is the reference number. From our cross-sectional study, our inclusion criteria is preschool children aged 5 to 6-year-old that come from the poor socioeconomic status with total income less than 4,849 ringgit and live in Klang Valley. Those children with chronic disease and parents who cannot converse and read in Malay language will be excluded from our study. From our prevalence study, we calculate our sample size using this formula, and 310 is our sample size. Total sampling technique was used in our study where 35 public preschool in Taman Datuk Harun, Pantai Dalam and Brickfield is selected because this is mostly the poor concentrated at, and 19 preschool has agreed to be involved in our study, and this is the list. From there, our study 2 is self-administered questionnaire that divided into 5 sections, which is section A, social demographic, section B is the parental perception on their child oral health, section C and D is the parental and child oral health behavior, while for the section C is the validated Malay ECOHIS. Zooming in into the Malay ECOHIS, where it's divided into 2 sections, child impact section for 9 items, where we assess on the child symptom, psychology, function, self-image, and social interaction, while for the family impact section, we assess on the 4 items, parental distress and family functions. From there, we did the data collection by having pre-testing of questionnaire on 10 random parents, and the license with the preschool authority was done after we received the approval from Ministry of Education, Kemas and PASTI, and then printed questionnaire was distributed to the parents and through the class teacher. Data management, we did the descriptive statistic such as frequency and percentage using IBM SPSS Net 29, which also we used to calculate the total mean of ECOHIS for 13 items. Those who answer don't know consider as missing value, occasional, often, very often, and consider as having impact, never or hardly ever consider as absence of impact. And we run this simple linear regression and multiple linear regression using Stata 18.0.
Now, ladies and gentlemen, let's move on to the next part, which is result and analysis. We start with a total of 337 respondents of preschool children aged from 5 to 6 years old participated in the study with a response rate of 60.9%. The reason why we're not reaching 100% is because of a few unavoidable factors considering the living conditions of the parents, such as parents are too busy working and they're unable to complete the questionnaire on time. And moving on to the demographic part, 62% of the children is 6 years old, 40% sense, the mother education level is in secondary school. Same goes to the father with the 55.2%. Father works in government and private sector is the majority, 62.4%, and 47.2% of the mother work in the same sector. Moving on to the number of vehicle, about 82.8% of the respondent having lesser than 2, and majority of the respondent live in a low-income residential areas such as flat and also PPR. Now let's move on to the result to address the first objective, to assess parent-reported oral health status of these poor urban children. 59.1% of them, the children, they never experienced any toothache before. 65.9% of the children has perceived need for child dental treatment. 47.2% of the child never experienced any problem with their teeth before. 41.2% of the parent satisfied with the child oral health status, and 49.9% of the parents perceive a good oral health status for their children. So we showed a low percentage of children carries experience and also problem, which directly related to annual preventive visit of the dental team that play a significant role in maintaining the child dentition. And not to forget, a good awareness of oral health among these parents in urban setting, which increase dental awareness that helps in educating the families and maintaining the child dental oral health status. The next objective is to assess oral health behavior of poor urban parents and their children in Klang Valley. We start with the parent behavior first. 86.1% of the parents, they do not have any smoking habit. 94.7% of the parents, they take sugar less than 4 times daily. And 48.2% of the parents who floss, they only do it occasionally. But 58.8% of the parents, they do not practice flossing. 77.7% of the parents, they took fluoride in their toothpaste, and 90.8% of the parents brushes more than twice daily. Looking into children behaviors, 50% of the children who floss, they do it occasionally, but majority of the children, they do not practice flossing. 61.4% of the children, they use fluoride in their toothpaste, and 73% of the children brushes more than twice daily. 63.8% of the children still require parents to assist while brushing, and 80.4% of the parents, they help to teach their children to toothbrushing, and 95.5% of the children, they take sugary intake more than 4 times daily. We show positive findings, but except for the flossing, because of a few factors, first, urban location with well-exposed correct information, and then 10 campaigns from the government and non-government. However, we find our finding will be in contrast from previous study, which was done for children in rural areas, where restriction and limitation of access toward the oral health become the main issue. Thus, they show a poor oral health behavior of the children, leading to poor oral health status, which does not happen in our urban setting, and also show low percentage of flossing between the parent and also the children, because flossing itself could be tricky and it's relatively difficult to teach a child on how to do it, especially on daily basis. And also it relies a lot on parents' role in teaching how to do it effectively. Third objective is to investigate the oral health related quality of life among these poor urban children and the impacts on the family. We start with the child impact section. 3 most commonly reported impact: 18.2% having pain, 7.4% having difficulty in eating, and 4.1% had difficulty in pronouncing the word. However, the 3 least reported impacts are 2.1% missed preschool, 2.4% irritable and frustrated, and 2.7% of the children avoided talking. Looking at the family impact section, 8.4% of the parents feeling guilty, 2.7% taken time off from work, and 2.1% of the parents having financial impact due to the child oral health status. Our overall prevalence of our impacts was 31.8%, but we have similar finding with the previous studies that shows that when a child having a pain on the tooth identified easily by the children, and then the parents feel responsible for it, thus leading to the feeling of guilty. In the same boat, active oral health promotions and prevention really relies on the parents' role to act effectively. That's why our element, that could become our element of determinations on why our finding can be found in contrast with the previous finding that shows a significant impact on financial status. And the last objective is to investigate the significant factors associated with oral health related quality of life of these poor urban children. The first factor is oral health status of the children. A children having a fair oral health status has 1.46 point EQHI score, more than a child have a very good oral health status. Second factor is child experience problem with their teeth. Child who never experienced it has 2.66 score echo score lower than a child who often having it. And the third significant factor is child toothache experience. Child who never experienced toothache has 2.21 score lower than child who often having it. So we have a similar significant associated finding from the previous study, and we can say that perceptions towards oral health directly related to oral health related quality of life. However, it doesn't necessarily mean that it matches the perceptions. It just means that they're normalizing it and not much bothered by it, does not affect the oral health related quality of life that much. And same goes to perceived oral health need. Someone with the perceptions of needing the treatment is someone with a concern of her dental status and causing the feeling of uneasiness. And to explain the third factor, when the child having a toothache will be bothered by it and be affected by his or her daily routine, situationally related to the parents and become more concerned and guilty about it, influencing both oral health life of the both children and their families. These are our limitations, our recommendations. So to conclude, 49% of the children has good oral status and 95.9% of them have perceived dental treatment, and prevalence of oral impact is 31.8%, and these are the list of significant factors. With that, thank you.
Thank you, presenters. Now we'd like to open the floor to the Q&A session to the judges.
Okay, that was a very, very fast express train presentation. Other than all the percentages that you have mentioned, what would be the take-home message that you want to tell all of us?
Okay.
In a simple terms.
Thank you for the comments. We are aware of, because of lots of results that we would like to explain and show. It would be a waste if not to show all of the research question. So, but the message that we're trying to say is overall, even though these poor urban children, they are not that privileged and often neglected, but they show a low prevalence of oral impact. So they're not much affected, and we recognize three significant associated factors related to oral health quality of life, which is similar from previous studies.
Okay, thank you. Yeah, express train. I was like, my God, you know. Okay, and a very interesting study here, and you presented well, actually. But as you already said, the take-home message. Now, my impression is that we don't need to look after the urban poor children. Am I correct?
Not really, because we just the aim is first we want to assess these underprivileged kids, even though they're in an urban setting, they are oftenly mislooked. And then when we look at the data, the prevalence is low for oral impact, but there still is. And whatever, since we are not included clinical examination, so the perception does not necessarily mean that it matches the real oral health quality of life. So for further recommendation is to include clinical examination in further study, so we can really assess the prevalence of oral impact, and then to make sure that all intervention assessed according to the three significant associated factor must be included.
Why not you extend? Okay, why not you extend and compare this study with those unfortunate children in the rural or peri-rural areas? Then maybe you get a better picture, more realistic picture. Would you want to do that?
Because if we look at the previous study done in rural areas, they show really big difference between the prevalence of oral impact. So that's why, because of the huge difference, I think we start to go more specific and deeper into this specific population.
Your questionnaire, was it pre-tested?
Yes.
We did pre-tested the questionnaire on 10 random parents that have 5 to 6-year-old children. And from there, we validate the questionnaire that we use in our study.
Okay, thank you for the last group. Thank you, judges. With that, we conclude the second session of the oral presentation. We will now proceed to the lunch break. All participants and presenters are invited to the cafe. We hope to see you back in the auditorium by 2 p.m. Thank you all for joining us for this session.
So when they introduce themselves, we cannot catch who is she the first presenter. I don't know. Depan muka only one I couldn't recognize. They look alike. They look alike. Betul gelap lah. The rest all no problem. Anyway, it's a girl and a boy is even easier. Because you see, there's no light that shows them. See, the other way around. So, because you know the one in the picture she's wearing specs, then she's not wearing specs. I'm not sure. No, because there's no light. Actually, kalau ada light yang like that, you can see lah. This is Zin. This is Zin. This is Chichi. Okay. 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 So, number 5. And number 7. Yes. Eight, isn't it? Only 8. 9. 9? 5. So we have 5 pieces. Okay. Wait. Yes, you are not. I'm later lah. But if we discuss, then we will see your method. Yeah, she's doing now. Okay. Number 8. Number 8 ni. Yang cannot can go answer. Can answer. Yeah, cannot differentiate between under. No, but next time, right, if we have one of the light shine on there. So that one, the one I thought they look alike. I think that. They look alike. I thought we had lunch just now. Lunch? We already eat again. Ayo. So many times, huh? You really feed us, huh? So for more, I need to go to the toilet. So am I. The one that so fast at train. It's like, she got 2 men. 2 men. Then in the end, it's just numbers. Highlight the name. I think we should be able to tell them that. Yeah, later we tell them lah. You know, when you have to, you will give them. I prepared 7 slides. Just things lah. You know, just whatever. But based on that, can
Lemak adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif biasanya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru, melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi
Tapi you run also never mind because I just
Welcome back for the third and final session for the day. I, Shavita Karnanidhi, will be the moderator, and the timekeeper for this session is Stephanie Hui. For this final round, we will have 4 presentations from the participants. A gentle reminder to all the presenters, you are given a total of 12 minutes to present your research and 3 minutes for a question and answer sessions from the judges. Signals will be given by the timekeeper during the presentation. First bell and green light marks the start of the presentation. Second bell and the yellow light marks the 10th minute of the presentation. Third bell and the red light marks the end of the presentation and the beginning of the Q&A session. The fourth bell, which is a long bell, marks the end of the Q&A session. You will be notified when the time is up. You will need to stop your presentation and start the Q&A session. Each presenters are also required to introduce their names before starting with their presentation. Without further ado, I would like to invite Muhammad Azim Zulfahmi bin Abdul Aziz and Muhammad Anas bin Abdul Hadi, number OP10, to present their research titled The Perception and Acceptability of Teleconsultation by Patients with Oral Cancer and Oral Potentially Malignant Disorders.
Assalamualaikum and a very good evening.
I'm
I
sorry
bid
to interrupt. There's some technical issues first. To the presenters, you may now begin.
Assalamualaikum and a very good evening. I bid to the honorable judges and respected colleagues. My name is Muhammad Anas bin Abdul Hadi and this is my research partner Muhammad Azim Zulfahmi bin Abdul Aziz. And we are thrilled to have the opportunity to share with you the findings of our research project titled The Perception and Acceptability of Teleconsultation by Patients with Oral Cancer and Oral Potentially Malignant Disorders. Now, before we dive into the details, let me give you a brief overview of what we're going to share in our presentation today. Firstly, we're going to start with the introduction, followed by the aims and objectives, methodology, results, discussions, limitations, conclusions, as well as our references. Without further ado, let's explore the background and context of our research topic. Oral cancer is ranked 18th in the cause of mortality in Malaysia with a 5-year prevalence of 2,199 cases.
Oral cancer can be preceded by oral potentially malignant disorder with multiple different etiological factors. The transformation rate of OPMD to oral cancer range from 4.9% to 11.5%. And all of these oral cancer and OPMD patients require a long-term regular follow-up for early detection of malignant transformations and promptly treatment. Now, due to delay in symptom recognition, lack of awareness, and delay in seeking medical assistance, there has been a high incidence of late presentation documented. Now, the emergence of COVID-19 pandemic has added an additional layer to the complexity of healthcare deliveries. Now, in Malaysia, telemedicine began in 1997 with the first telemedicine blueprint under the Multimedia Super Corridor project and was later endorsed by the government as a flagship application. Teleconsultation utilizing Memosa web app has been implemented in the care of oral cancer and OPMD patients in the Faculty of Dentistry, Universiti Malaya since November 2021. The Memosa web app, which is a mobile platform connecting patients and healthcare professionals, allowing patients to submit images of their oral lesions and response to clinical questions. A better understanding of the patient's perception and acceptability on teleconsultation will be important for us to improve this service. Why is this area of study so important? The understanding of the dynamic that shapes patients' acceptability and perception on teleconsultation service is important for us to identify the barrier that affects patients' participation, refining healthcare policies, optimizing teleconsultation protocol, as well as fostering a seamless integration of virtual healthcare modalities into the broader spectrum of patients' care. Ladies and gentlemen, now that we've understood the importance of our research topic, let's take a closer look at our aims and objectives that we want to achieve. Our aim is to assess patients' perception and acceptance of teleconsultation service in the Faculty of Dentistry, Universiti Malaya, while our objectives includes to evaluate the perception of oral cancer and OPMD patients on teleconsultation service, to explore the acceptance of oral cancer or OPMD patients on teleconsultation service, and to investigate the barrier of teleconsultation implementation on patients' care. In order to achieve our objectives, we have utilized rigorous methodology involving various research tools for data collection and analysis. Our study populations consist of all oral cancer or OPMD patients that have experienced teleconsultation session using Memosa web app for follow-up from March 2023 to May 2023. Now, this was a cross-sectional qualitative study regarding the perception and acceptability of teleconsultation in Faculty of Dentistry, Universiti Malaya. The inclusion criteria that we have set is that the patient must be an oral cancer or OPMD patient who have experienced at least once the teleconsultation service and should be aged 18 years old and above. However, for those who cannot communicate in Bahasa Malaysia or English, patients who refuse to participate, they are excluded from the study. The research tools involve a self-administered questionnaire, which consists of patients' demographic characteristics, factors related to the willingness of teleconsultation usage, and teleconsultation service usability. An in-depth interview was also done, focusing on teleconsultation acceptance and perception, as well as suggestions for further improvement. And this is our self-administered questionnaire and our in-depth interview. Now, how do we collect the data? Firstly, the patient was contacted via WhatsApp or phone call to participate in the study, and study was conducted through face-to-face during the clinical follow-up session or online Google Meet with written informed consent. And then patient was given a self-administered questionnaire, and the data for the in-depth interview was recorded. To analyze the data, for the questionnaire, the data was analyzed using a descriptive analysis, whereas for the recorded interview, a verbatim transcription was performed where the data was transcribed into text, and a qualitative data analysis using NVivo version 12 was used to analyze the data.
Thank you, Anas. Hi, everyone. My name is Muhammad Azim Zulfahmi, and I will continue with results and discussions. So a total of 14 patients who had experienced the teleconsultation service throughout the research study period were contacted to participate in the study. And from this, 11 patients responded to our self-administered questionnaire with a recruitment rate of 78.6%. But only 8 consented for the in-depth interview. The reasons cited were inability to speak clearly after the surgery and cannot communicate in English or Bahasa Malaysia. So this is our demographic results. Majority of our respondents aged 15 and above and accounted for 72.7%. The respondents were female predominance, around 81.8%, and only 18.2% of them were male. Most of our respondents were Chinese and accounted for 72.7%, and the rest were Indians. There were no Malay respondents in this study. So based on the questionnaire, let us discuss the factor related to the willingness of teleconsultation usage. Majority of our respondents, around 72.7%, felt comfortable complementing their clinical visits with teleconsultations and deemed teleconsultation is appropriate due to the current condition in hospital as a result of COVID-19 endemics. So these patients felt that teleconsultations give them a lot of benefits in terms of accessibility of healthcare, which was similar to the study by Maria et al. In 2022, where they also stated that most patients expressed that teleconsultations has saved them a lot of money and times, and they do not have to travel far or need to wait to get for their appointments. Now, 63.6% of our respondents agreed that teleconsultations work smoothly without any technical issues. But some of our older participants recognize some technical hurdles like setting up the sessions and making online payments, which they require assistance from their family members. However, more than two-thirds of our participants in our study expressed that they were able to use the teleconsultations without any technical issues, similar to the study by D. Hassler et al. In 2020. Even though 45.5% of our respondents perceive that teleconsultations improve their access and getting in touch with doctor, it cannot be the replacement for the regular checkups. The majority of respondents agree that teleconsultations allow them to access healthcare anywhere and anytime without needing to visit the clinics. However, 1/3 of our respondents would still prefer in-person clinical visits in view of better communications between patients and practitioner, while physical examinations contributed to relationship-centered care. Similar findings were found that patients felt better and more confident when they talk in the presence of doctor physically. None of our respondents experienced any physical or emotional discomforts or perceived any invasions of privacy throughout the teleconsultations. However, only 45.5% of our respondents would recommend this teleconsultation service to others with similar conditions. In this questionnaire, we also assessed regarding the teleconsultation service usability. So majority of our respondents perceived teleconsultation service was straightforward to learn, easy to comprehend, and user-friendly. And approximately 45.5% of our respondents effectively communicated with clinicians during teleconsultations, expressing satisfaction and willingness to continue using the service comfortably. Nowadays, as the world progresses, so does technologies, and pupils are always looking at ways that could make the life easier. So teleconsultation has changed the way people access healthcare in terms of cost and time. This is consistent with the finding in another study conducted in Malaysia, as it is stated that even in the early stages of teleconsultation's implementations, it was proven that teleconsultation was able to save costs, efficient allocations of resources, improve diagnostic options, and led to a better health outcomes. Moving on, let us discuss the result from our in-depth interview. So based on the aspects of teleconsultation's acceptance and perceptions, our participants perceive teleconsultation as an effective online platform for communications between patients and physicians without physically visiting a clinic. They upload images and use Google Meet for verbal interactions, indicating its potential role for inpatient follow-up reviews. Most of the participants opted for teleconsultation service based on the physician recommendations, reducing the hospital visits and resulting in cost saving, especially for those who stay far away from the hospital and those who are unable to drive. They also agree that teleconsultation has significantly simplified doctor visit, especially for those who are struggling with clinic phone lines. And they also think that teleconsultation has saved them a lot of time, as mentioned by one of the participants here, as she said, through teleconsultation, she does not have to wait for the queue. In terms of barrier to teleconsultations, our older participants do perceive teleconsultation as positive, but face some challenges in uploading images, setting up sessions, and online payments in which they require assistance from their family members or friends. Concerns were raised regarding interrupted internet connectivity and unclear sounds during the teleconsultation sessions. One of the participants even mentions that the line is not stable and it is quite irritating because she cannot hear what the doctor is saying. Our participants also expressed concerns regarding teleconsultations being not as interactive as the physical visits. More dentist-patient interactions during the physical visits makes them feel more confident with the treatment provided. And preference for in-person clinical visits is irreplaceable with images only, especially when they are having pains, ulcer, and difficulty in swallowing, as mentioned by our participants here. And they were also unconfident with the diagnosis accuracy based on the interview, observations, and images only without any physical examinations, as they worry the image might not be clear and that might impact the diagnosis being made. So we also asked our participants regarding the Mimosa web apps. Overall, the user of Mimosa web apps reported it to be user-friendly. And I quoted one of the comments from our participants here, as she mentions that Mimosa is quite easy to use and very straightforward and easy to understand academic according to the steps. They also suggested for the guideline in simple sentences, and the video tutorial will be better, especially for the older individuals. Moving on to the teleconsultation suggestions, our participants think that teleconsultation is suitable for the stable patients, and they also requested for more interactions and questioning during the teleconsultation sessions. Other than that, ensuring a stable internet connections and creating a 24 hours emergency response hotline were also suggested by our participants.
So, in conclusion, teleconsultation is a reasonable alternative as a long-term follow-up for consultation for both patients and caregivers. Patients value the combination of both the physical in-clinic visits and teleconsultation to be the most appropriate treatment of care for the continuing of care of oral cancer and OPMDs. The results of the study have showed the implications for healthcare providers, policymakers, and patients, providing insights into the effectiveness, acceptance, and barriers of teleconsultation in order to improve patients' outcomes and healthcare accessibility in the context of oral cancer and OPMDs. The study is subject to certain limitations that warrants consideration. Firstly, the generalizability of the finding is constrained by a relatively small sample size. The limitation stems from the initial limited number of Memasa WhatsApp users resulted in a restricted pool for recruitment. Subsequently, the sample size is further reduced as some of the patients opted not to participate. And finally, the reliability of the data may be impacted as the extended usage period of Memasa WhatsApp exceeding 6 months for most participants.
Excuse me, presenter, I'm sorry to interrupt, but we have to continue.
So this is our arrangements, and that's all from us. Thank you.
Thank you to the presenters. We'd like to open the Q&A session to the judges.
Okay, thank you very much for your presentation. It's an interesting project, nevertheless, but the sample size is overly small and you're making generalized statements which you have to be a bit more careful, yeah? So you cannot get any more bigger than 14. I mean, how can you analyze that? That's question number one. I will just go. Number two, my question is, who developed the questionnaire? Because you have two phases. One is the questionnaire, and second one is the interview, right? Yes. So that questionnaire, who developed the questionnaire?
All right, so thank you, Prof, for the questions. We do acknowledge our small sample size simply because our data collection start from March 2023 until May 2023. And we know that a normal qualitative research study will require around 12 to 13 response to achieve the saturations of data, but we acknowledge our small sample size because of the time constraints and also the specificity of the populations being studied. But I think despite having this small sample size, we managed to draw some quality and meaningful finding through this study. And for the second questions, yeah. And unfortunately, for the Malay respondents, there were no Malay respondents in this study because during this, at the time periods of from March 2023 until May 2023, most of them are receiving active treatment, so they were not included in this study as well, because that's the protocol for teleconsultations.
No, I didn't ask that. I asked you, you use a questionnaire. Who developed the questionnaire? Is it a standard questionnaire or you developed the questionnaire?
No,
because
it was,
there must be process.
the questionnaire was, thank you, Prof, for the questions. The questionnaire was actually adopted from a study.
What study?
A pilot study regarding.
So actually the questionnaire was adopted from a pilot study done in 2022 by Dr. Senthil Manuel Rajendran. The study is entitled Accelerated Implementations of Teleconsultations for Monitoring of Oral Potentially Malignant Disorder due to the emergence of COVID-19.
Yeah,
so we adopted that questionnaire and use it again in this study. And we add some more of in-depth interview so we can get a more detailed elaborations and information from the patient itself.
Okay, because I think your questionnaire is quite weak. You know, you need to go through certain process before we can take the results that you have produced. Yeah.
Did you have any information on number of teleconsultation visits, number of teleconsultations per patient? Because you have perception and accessibility,
we don't
can
have,
be different if you have the number of.
Yeah, we actually don't have the exact number. Yep. So, okay.
And you could have extended the time period. You have just look at the patient for a period of 2+ months.
I'm sorry to interrupt,
Yeah.
but we have to move on to the next presentation.
Thank you, Prof.
Thank you, judges and presenters. We will now move on to the next presentation from Si Ying Hui and Tan Chin Hong, OP number 11, with a presentation titled Apoptosis Induction Capability of BRDE-loaded PLGA nanoparticles against H103 human oral cancer cells. To the presenters, you may now begin.
A very good afternoon to distinguished professors and doctors, honorable judges, and my fellow friends. My name is Si Ying Hui, together with my partner Tan Chin Hong. Today, we are going to present our topic about the apoptosis induction capability of BRDE-loaded PLGA nanoparticles against H103 human oral cancer cells. Do you know? Based on studies, oral cancer is the 6th most common cancer worldwide, whereas the incidence and mortality rates of oral cavity cancer in South and Southeast Asia are among the highest globally. In Malaysia itself, mouth cancer is ranked as top 20 in Malaysia with 2,000 oral cases in a 5-year period. And it is undeniable that we have the current conventional treatment modalities, namely surgery, chemotherapy, and radiotherapy. However, they have faced significant challenges due to their ability to induce systemic toxicity, high recurrence rates. They also negatively impact patients' quality of life due to some of the patients are diagnosed at a very late stage of the oral cancer, and some of them are resistant to the chemotherapy treatment. We thereby have Biosebanja rotunda, also known as finger roots, or in Malay is known as temu kunci. It is a herbal medicine plant in Southeast Asia and China that possess various chemical components that are able to treat various diseases, including cancers. For example, it has demonstrated the ability to treat or kill the HG29 colon cancer cell lines, and it possesses anti-SARS-CoV-2 properties. This has led to a paradigm shift of researchers to further explore the potential dietary biomolecules to treat cancers. Concurrently, PLGA nanoparticles stands out among other drug delivery systems due to its biocompatibility, as it does not cause any unwanted local or systemic reactions. It is biodegradable with the formations of cleavable monomers, namely lactic acids and glycolic acids, which will further be metabolized in the Krebs cycle. Most importantly, it is approved by FDA and has attracted much research interest. Thereby, that's our interest to further study on how the BRDA encapsulated into the PLGA nanoparticles can kill or inhibit the oral cancer with the objectives of, first, to explore the apoptotic inducing activity of Biosebanja rotunda extract-loaded PLGA nanoparticles against H103 human oral cancer cells and its underlying mechanisms. Second, to investigate the role of BRDE PLGA nanoparticles in cell cycle phases. Now, I would like to explain about the methods of our project. Our project is started with the preparations of dichloromethane extract of Biosebanja rotunda, followed with the preparations of BRDE PLGA nanoparticles in a 5:1 ratio using the nanoprecipitations method. The H103 human oral cancer cells are then cultured with a 10% DMEM-F12 media, then incubated until it reaches a 90% confluency before being incubated overnight again. Finally, the H103 cells are then treated with various concentrations of BRDE PLGA nanoparticles and incubated for 24 hours before those apoptosis assays and cell cycle analysis will be carried out. So the first apoptotic assay is the NSINS 5 propydium iodide assay to differentiate the early and late apoptotic cells from the necrotic cells. The treated cells are harvested and centrifuged, followed by the additions of 1 times binding buffer, 5 microliter of FITC annexins 5, and 5 microliter of propidium iodide. It is then incubated for 15 minutes before being analyzed under the flow cytometer. The next apoptotic assay is the tunnel assay to determine the DNA fragmentations in apoptosis. The treated cells are harvested and centrifuged before fixations with 1% of paraformaldehydes for 15 minutes. They are then washed with PBS twice before fixations with 70% of ethanol overnight. DNA labeling steps are then carried out with the TDT enzymes and BRDU TP, and followed with the 1-hour incubations before being labeled with the FITC labeled anti-BRDU antibody. Lastly, would be the staining with the propidium iodide RNAs for 30 minutes before being analyzed under the flow cytometer. Moving on to the next assay, the ROS measurements to determine the intracellular ROS during apoptosis. The treated cells are incubated in a 5 microliter of DCFHDA dye, the fluorescence dye, for 40 minutes, followed by the washing with PBS thrice, and observed under the inverted fluorescence microscopes. Not to forget the caspase 8 and 9, which are very important to determine the extrinsic and intrinsic pathway of apoptosis. The treated cells are centrifuged and incubated with 1 microliter of FITC IATD FMK and FITC LEHD FMK respectively for 30 minutes, then washed with PBS twice and centrifuged before being analyzed again under the flow cytometer. Last but not the least would be the cell cycle analysis to determine the inhibitions of proliferations of H103 human oral cancer cells in various cell cycle phases. The treated cells are centrifuged before the fixations with 70% of ethanol overnight. They are then washed with the PBS twice and centrifuged again before being stained with the PI staining solutions for 30 minutes and finally analyzed under the flow cytometer. Next, I would like to pass the floor to my friend to continue with the discussions and results.
Thank you very much, Ying Hui. So, dear judges, I'm Chin Hong. So, we'll continue the presentation. Before we come to the results, let us discuss what is apoptosis. Apoptosis is a programmed cell death that eliminates damaged cells, including cancer cells, without provoking inflammations. The biochemical features of apoptosis includes the externalization of PS, caspase-activated mediated activations, DNA fragmentations, and increase the intracellular ROS. All these biochemical features will build the foundations of all the assays that just been mentioned. I'll explain it one by one later. The first is the anderson 5 propidium iodide assay. It's to differentiate between the early and late apoptotic cells from the necrotic cells. During the early stage of apoptosis, the PS is externalized to the outer leaflet of plasma membranes, released to the anderson 5 proteins to bind to it and emit fluorescence. Through this assay, we found there's a significant increase in both early and late apoptotic cells in a dose-dependent manner, which indicates that this nanoparticle is able to induce apoptosis through the externalization of PS. The second assay to carry out as a tunnel assay is to detect the presence of DNA fragmentations. DNA fragmentation is an important health marker as it exposes the 3-hydroxyl group, which allows the TDT reaction to be undergone by the BRDUT, and then it's been bound by the anti-BRDU antibody and emits fluorescence. Through this assay, we found that there's a significant rise in the tunnel-positive cells with a dose-dependent manner, which indicates that this nanoparticle is able to induce apoptosis through the DNA fragmentations. The third assay that we carry out is the intracellular ROS measurements. DCFHDA enters to the cytoplasm and the mitochondria and is being hydrolyzed by the esterase to form the DCFH and is oxidized by the ROS to form the DCF fluorescence. Under the fluorescence microscope, we found that there's an increase of green fluorescence intensity in a dose-dependent manner, which indicates that this nanoparticle is able to induce apoptosis via increase the intracellular ROS. The fourth assay is the caspase 8 assay, that TNF-alpha is going to bind to the TNF receptor, leads to the activation of the death domain, and followed by activation of the TRADD and FADD, followed by activation of caspase 8 and induced apoptosis. In our findings, we found that this nanoparticle significantly activates the caspase 8 activity in a dose-dependent manner, which indicates that this nanoparticle is able to induce apoptosis via the extrinsic pathway. For the caspase-9 assay is to determine the intrinsic pathway of apoptosis. Stimuli such as RLS is going to increase the permeability of the mitochondria, leads to the release of cytochrome C and APF1 into the cytosol from the mitochondria, and leads to the activations of the caspase-9 activity and induced apoptosis. Through this assay, we found that this nanoparticle significantly activates the caspase-9 activity in a dose-dependent manner, which indicates that this nanoparticle induced apoptosis via intrinsic pathway. The last was the cell cycle analysis. Uncontrolled cell cycle contributes to the development of cancer, and there are 4 phases for cell cycle: the G1 phase, S phase, the DNA synthesis phase, G2 phase, and the M phase, which is a mitotic phase. Through this assay, we found that this nanoparticle is able to arrest cells at the G2 M phase and the S phase. Cell that is arrested at the G2 M phase will be induced apoptosis, and the cell arrested at the S phase will lead to DNA reparation or induced apoptosis as well. The limitation of this study that number one, multiple attempts will be carried out due to there's a contamination during the cell culture, and also that we are unfamiliarized with the assay protocol during the initial attempts. Second, this is an in vitro study where its result is may going to be different from the in vivo study due to pharmacodynamic of these nanoparticles. We are proud to say that in conclusion, this nanoparticle is able to induce apoptosis via intrinsic and extrinsic pathway indicated by externalization of PS, DNA fragmentations, increase of intracellular RLS, and activates the caspase 8 and 9 in a dose-dependent manner. Besides that, this nanoparticle is able to arrest cells at the G2 M phase and the S phase. This nanoparticle is a promising chemotherapeutic and chemopreventive agent against oral cancer. Besides that, this research aligns with the National Cancer Control Blueprint 2021 to 2025, which focus on developing cancer treatment, and also aligns with the SDG Target 3B by the United Nations, which significantly contributes to reduce the disease burden in developing countries. These are the future directions. We hope to explore the efficiency of these nanoparticles against other cancer cell lines, and also the potential of these nanoparticles in dentistry, and the in vivo study of these nanoparticles against oral cancer, and the pharmacokinetic and pharmacodynamic of this nanoparticle. This is the acknowledgement slides, and these are the reference slides. Before I end the research, BRD, PRJ nanoparticles, a promising chemotherapeutic agent against oral cancer. Thank you very much.
Thank you, presenters. I would like to open the Q&A session to the judges.
Okay, a lot of work. Who did the experiments?
We are the one did.
You did the experiments?
We did it, everything. We did it from the cell culture. We prepared the nanoparticles, and also that.
Okay. You used only one cancer cell line?
The reason that we're using one cancer cell line, as this is a previous project extended by our friend Ahmad Akhtar in 2023, and they found, and then they have done an MTT assay to screen that among all the cancer cells, the H103 is the most effective cancer cells that for this treatment, for this BRD nanoparticle.
Yeah, good. Why didn't you get a control cell line, like normal cell lines?
We have done the human gingival the previous team, our team previously has done the human gingival fibroblast cells, and also has done the H400 cell lines. So we have found that this H103 cell line is the best among all of it. And
Don't
also
you
the
think
human
if there is a normal cell line, there is a good comparison?
H103 is a cell line that has been, is a cell line that it is at the tongue, which is normally that the cancer occurs at that site.
No, that is not what I am telling. Don't you think if you have had a normal cell line, not a cancer cell line, then you could have had a good comparison?
Thank you, Prof, for the suggestions, and we'll look into it and see if we can further extend our projects using the normal cell lines as a control.
But previously in the MTT assay, that we found that that in that report they found that that it doesn't damage the human fibroblast cells. So that's why that if this cell it doesn't it doesn't induce apoptosis or doesn't damage the cancer cells from the previous result in the MTT assay. From there, it has been shown that apoptosis will not induce apoptosis or damage the cells.
Now, in the cell cycle, which stage you get apoptosis induction?
In the cell, we use the G2 M phase and the S phase as well. These
Sorry?
are two cells that induce apoptosis. The cell.
What is the specific place where you get induction of pro-apoptotic genes? Is it a gate or is it a phase?
It's a phase.
Which phase?
G2 M phase and the S phase.
It is the
The
G1,
control-
G1S phase.
G2 M phase, and the S
What
phase.
is the most pro-apoptotic gene?
The pro-apoptotic proteins will
No,
be.
which gene induces apoptosis mostly in the cell cycle?
Sorry?
In the cell cycle, which particular gene induces apoptosis mostly?
Here on the hidden side here we have a schematic diagram of all the of this cell cycle that can show that this.
No, I don't need to see. I'm asking you.
P53 gene.
Okay, you see now you showed there is
I'm sorry to
increased
interrupt,
ROS, right? Reactive oxygen species.
Sorry, Prof.
In
Sorry to
cells.
interrupt. But we've already run out of time.
All right, okay.
Next, I'm pleased to introduce to you Evelyn Yoh Lee and Catherine Loh Hyu Dong, number OP12, to present their research titled Orthognathic Surgery, Pre-Treatment Information and Patient Satisfaction.
Question. A very good afternoon we bid to honorable judges, lecturers, fellow colleagues, and friends. I'm Evelyn, and this is my partner, Catherine. Our topic for today's presentation is orthognathic surgery, pre-treatment information, and patient satisfaction. This is the table of content for today's presentation. Now, let's get started. Combined orthodontic and orthognathic surgery is done to correct dental skeletal and facial discrepancy. The complete treatment process is involving pre-surgical orthodontics, surgery, and post-surgical orthodontics. The entire treatment process spans a lengthy duration. Therefore, achieving patient satisfaction after their long-time commitment is the major goal of treatment. However, patient satisfaction seems to be multifactorial, as surgical success alone may not guarantee a happy patient. According to Rittersma in 1989, a right amount of pre-surgical information are very important to ensure patient preparedness and their satisfaction with treatment outcome. However, to the best of our knowledge, currently there was no studies on this topic in Malaysia. Therefore, the objective of these studies, including first, to analyze the demographic profile of patients who completed orthognathic surgery at Universiti Malaya. Second, to assess the source, type, amount, and timing of pre-treatment information. Third, to assess post-treatment patient satisfaction. And finally, to investigate the association between pre-treatment information and patient satisfaction. Now, let's delve into methodology. We conducted our study using total population sampling method at Faculty of Dentistry, Universiti Malaya. Ethics approval were obtained from Medical Ethics Committee, Faculty of Dentistry. For participants, we included Malaysians who completed combined orthodontic and orthognathic surgery with surgery done at Faculty of Dentistry, Universiti Malaya within the last 10 years, in addition with at least 6 months post-surgery period. On the other hand, we excluded patients who cannot understand English and also patients with cleft lip and palate or craniofacial syndrome, patients on bisphosphonate medication, immunosuppressed patients, and those who are reluctant to participate in this study. For instrument, we modified content and face-validated a researcher-administered questionnaire, which was originally developed by Al-Kharafi in 2014. Prior to data collection, both interviewer and note-taker were trained and calibrated. For data collection, we interview each patient individually using Google Meet platform. The entire interview process was conducted in English, and their responses were recorded on individual printed questionnaire for each participant. Besides, each interview were auto-recorded with note-taker note-taking. For data analysis, we use SPSS software version 39.0, and we examine our collected data using descriptive analysis. Other than that, we also employed chi-square test or feature exact test to explore the association between pre-treatment information and patient satisfaction.
Thank you, Evelyn. I'm Catherine, and I will guide you through our results. In the past 10 years, 62 patients underwent orthognathic surgery at Universiti of Malaya. Among them, 58 were eligible for our study, and 31 of them consented to participate, resulting in a final response rate of 53.4%. Demographically, our participants' mean age was 31.5 years old, The majority, accounting for 61.3% of them, were male. Ethnically, the breakdown was 67.8% of Chinese, 29% Malay, and 3.2% of Indian. Education-wise, around 84% of our participants had at least a degree, 9.7% completed high school education, and 6.4% had a diploma. In terms of socio-economic groups, around half of the participants belong to the M40, followed by B40 and T20, which were reported at 32.3% and 16.1% respectively. Regarding treatment characteristic, 64.5% of the participants received double jaw surgery, while the rest had a single mandibular procedure. In addition, 87.1% of them received conventional orthodontic surgery, while the remaining 12.9% underwent surgery-first orthodontic approach. Moving on to the average total treatment duration, which was 4.6 years, with post-surgical orthodontics lasting around 1.1 years. The primary reasons for treatment, as reported by 77.4% of the participants, was to address their bite. This was closely followed by 74.1% of the participants who would like to improve their appearance. Only 32.2% of the participants stated speech and strict teeth as their reasons for treatment. In our study, we also found that 61% of the participants underwent orthodontic surgery following dental practitioner recommendations. 19% of them were self-motivated, while the rest were influenced by people around them. Ladies and gentlemen, moving on to our second objective. Majority of the patients received information from both orthodontists and surgeons before, during, and at the end of pre-surgical orthodontics. One participant, accounting for 3.2% of the sample, reported no information was given before pre-surgical orthodontics. And all patients who could recall reported information were given to all of them at the end of pre-surgical orthodontics. Our study found that 100% of other participants received information about the treatment. Less than 30% were shown photographs and models. And internet resources like websites and online videos were less used. Now, let's look at patient perception on general information provided. Overall, most were well informed, as only 0 to 6.5% of the participants were not informed regarding this. However, 22.6% of the participants were not informed regarding possible risk of braces, while 12.9% lacked information on orthodontics relapse and retention. Moving on to patient perception on surgery-related information provided, specific information regarding risk and discomfort following surgery were generally very well informed to the patients, except for permanent damage to dentition, where 22.6% of the participants reported no information was given. In terms of functional and social problems during the recovery period, about 1/3 of the participants reported that 5 out of 6 pieces of information were not delivered. Regarding self-compliance, 16.1% of the participants reported that they did not receive any information regarding the use of elastics, while 45.2% of the participants lacked information on the need for jaw and lip exercise. However, all patients received information regarding oral hygiene and smoking cessation advice. Following this, I will be discussing about our third objective. As high as 83.9% of the participants were very satisfied with total cost of treatment. However, less than 40% were very satisfied with total treatment duration and treatment duration of braces before surgery. In terms of treatment duration of braces after surgery, half of the participants who underwent surgery-first orthodontic approach were not satisfied, while 11.1% of the participants who received conventional orthodontic surgery reported dissatisfaction. In terms of treatment outcome, most were satisfied with all aspects of the treatment outcome. In particular, chewing and eating function following orthodontic surgery was reported as very satisfied by 74.2% of them. On a side note, 32.3% of the participants found the ability to form relationship to be irrelevant. In line with our fourth objective, we found that 3 out of 14 domains, namely treatment flow, need for orthodontics pre and post surgery, and total treatment duration were significantly associated with patient satisfaction, while the others were not. With this, I will pass the time to my friend Evelyn.
Moving on to this discussion, according to Al-Kharafi in 2014, self-motivation is the key motivation for patients to seek orthodontic treatment. However, in our study, only 1/5 of the patients were self-motivated, while dental practitioners were the key person who motivate them. This condition may be due to lack of knowledge and information regarding orthodontic surgery and its accessibility. Next, study done by Cunningham and Williams stressed that information need to be delivered and revisited at times. This may due to patient expectations are not static and to change during treatment, and also to ensure patient able to retain the information provided from time to time. In our study, we found that information were delivered at multiple stages, involving before, during, and at the end of pre-surgical orthodontics, which on par with the findings from those studies. Moreover, 100% of patients claimed that they received information verbally, and only 29% of them were shown relevant photograph. However, according to Castles in 2003, they highlighted that without photograph being used, only 14% of information able to remember correctly, and most of them cannot recall the information provided. Therefore, it is clear that verbal method alone may not be effective in information delivery, and clinicians need to be emphasized more on the use of photograph in the future. Now, let's address the limitation of this study. First, we encountered a low response rate, and we get feedback from patients that they more prefer self-administered questionnaire due to their busy schedules. Second, there was a potential for recall bias, as our study recruited patients who underwent treatment up to 10 years. So, our recommendation for future study are developing and using self-administered questionnaire, and also conducting a national survey to enhance the statistical power for research findings. Within the limitation of this study, following conclusion can be made. First, patients were generally well-informed and also satisfied with most aspects of pre-treatment information. Second, pre-treatment information such as treatment flow, need for pre- and post-surgical orthodontics, and total treatment duration significantly impacts patient satisfaction. And finally, our findings could help to develop guidelines for patient education prior to surgery, and so create patient-centered resources such as websites and booklets for Malaysians in order to improve their overall satisfaction. Finally, we would like to thank to everyone who helped and guided us in this research. And this is the list for our references. And that's all from us. We welcome any questions. Thank you.
Thank you, presenters. I would like to open the Q&A session to the judges.
Okay, thank you for the presentation. You mentioned earlier in your presentation that there's no study like this. Other than, usually no study doesn't mean that we have to do a study. But what are the, other than no study, what is the real motivation for you to do this research?
Thank you, Prof, for your question. Actually, me personally is a patient who going to underwent the orthodontic surgery in the future, and therefore I'm very interesting in this topic as I want to know like what to expect the surgery will be, and like the risk, is it like associated with the patient satisfaction? And currently also the orthodontic surgery is becoming more common and so gaining popularity in Malaysia. So I think it is a very interesting topic for us to investigate. Is there any factors that will affect the patient satisfaction for the final outcome, as sometimes the surgical success alone may not guarantee that patient is happy with the result. So we want to like find the association between, is there the information delivery or the delivery method will be affect the final treatment outcome and so patient satisfaction.
Besides, as an undergrad dental student, we are less exposed to orthodontic surgery. That's why I'm keen on doing this research so that I know more about orthodontic surgery, and in the future, when I am practicing at private clinics, I can identify those who need orthodontic surgery and can direct them to specialists like oral surgeons. Thank you.
One question, or rather pointing out to you, yeah, you are not using, you have a small sample size and it's over a 10-year period. Why is exclusion criteria not able to speak English is exclusion criteria? What happens if you go to orang asli village and all this thing? I mean, they don't speak English. So, what I'm saying is we are multi-pluralistic society. Even if you don't speak English, there are many all the languages we all know how to speak. So you can go and find. That shouldn't be the exclusion criteria because it reduces your sample, okay?
Thank you, Prof, for your suggestion. We will try to expand our study and also include in a multi-language questionnaire in the future. Okay.
We have 10
Now, when I
seconds.
look at this, you haven't done any statistical analysis, only percentages. Why is that?
Doctor, I'm sorry, could you repeat?
I'm sorry to interrupt, but we are out of time.
Oh, thank you, honorable judges.
For the final presentation, I would like to call upon Rachel T. Hui Wen and Tan Xian Yi, number OP13, to share their presentation on infrazygomatic crest mapping for temporary anchorage devices, TATs, in Mongoloid patients, a cone beam computed tomography study. To the presenters, you may now begin.
Good afternoon, esteemed judges and distinguished guests. I'm Rachel and he is Xuan Yi. It is our pleasure to stand before you here as the final team for the Enlightening Dental Conference today. We are honored to present to you our research titled Infrazygomatic Crest Mapping for Temporary Anchorage Devices, TATs in the Mongoloid Patient, a cone beam computed tomography study. Our research delves into a crucial aspect in orthodontic treatment, focusing on optimizing the placement of TATs in the infrazygomatic crest area in the Mongoloid population. So this is the table of content for today. I would like to start my presentation by introducing the groundbreaking innovation in orthodontics, which is the TATs, or what we call the temporary anchorage devices. In physics, Newton's law of motion states that every action force, there is an equal but opposite reaction force. Active tooth movement can cause unwanted tooth movement in the neighboring teeth. So to ensure adequate anchorage, TATs were developed. Here, we see how the envelope of discrepancy in orthodontics describes the limit of tooth movement and how these limits increase with the orthopedic growth modification as indicated in the yellow zone. However, with the usage of TATs, more tooth movement can be achieved as compared to orthodontics alone or orthodontics with orthopedics as indicated in the green zone. This range falls short of surgery as it provides the greatest tooth movement, however, with a different set of risk and complications. So previous studies have shown that the optimal extra-alveolar site for the TATs placement in the maxilla is at the infrazygomatic crest area. Anatomically, it is a pillar of cortical bone located at the zygomatic process of the maxilla. While clinically, it is a palpable bony ridge that runs along the curvature in between the alveolar and the zygomatic process of the maxilla. However, TATs comes with its risk and complications such as sinus perforation and also tooth root injury, which may eventually lead to failure. For the best application of TATs in clinical practices, it is necessary for us to understand the anatomy in relation to its potential risk and complications involved. However, with the scarcity of data that provide conclusive data applicable to our population, Our study aimed to map the topographic thickness of the infrazygomatic crest area of the maxilla in Mongoloid population for the insertion of TETs by assessing using CBCT scan and investigate the ideal location and optimum angle for insertion to enhance the orthodontic treatment and also to minimize the complications to adjacent structures. The primary objective of our study is to determine the alveolar bone thickness at the infrazygomatic crest area at the mesiobuccal and distal buccal roots of the maxillary first permanent molars at various angles, particularly the 30, 45, and 60 degree. While the secondary objective is to compare the thickness of the alveolar bone in between different ethnicities, which is the Malay and the Chinese, in between different genders, and also between the left and the right sides. Moving on, the genetic diversity among human species can be classified into Caucasoid, Mongoloid, Negroid, and Australoid races. Our multi-ethnic Malaysian population mainly comprises of the Malay, Chinese, and the Indian. Apart from the Indians who are genetically closer to the Caucasoid, our study mainly investigate on the Malaysian Mongoloid, which is the Malay and the Chinese. Relevant ethical approval was received. So our research is a retrospective single-center study on CBCT by using the iCAD imaging system from the Oral and Maxillofacial Radiology Unit. Sample size of 80 CBCT scans was calculated by using the data from the Matias paper. So the CBCT scans was chosen from the subjects based on the inclusion criteria, such as they are of Chinese and Malay races, age more than or equals to 18 years old, absence of pathology in the infrazygomatic crest, normal maxillary sinus flaw, no alveolar bone loss, no previous orthodontic or orthognathic surgery, no syndromes affecting the area of interest, and it is the double buccal-rooted maxillary first molar. So how did we conduct this research? Prior to the study, we have conducted a validity and reliability test among the observer and within the observer and also calibrated with experienced researcher. Both shows moderate result and reproducibility in all locations. So first, the CBCT scans were loaded into the software called the Blue Sky Plan 4 to obtain a multi-planar view of the scans. Then, we used the axial slice to locate the mesiobuccal root of the maxillary first molar and the coronal slice to measure the thickness of the infrazygomatic crest. Then, you can see in this slide, on the left is an illustration diagram, while on the right is a CBCT scan. The first reference line was drawn from the mesiobuccal cusp tip of both maxillary first molar, and this represents the maxillary occlusal plane. A tangential second reference line touches the buccal surface of the mesiobuccal root of the maxillary first molar and is marked as line B. Then, the marked sinus point S was determined by the intersection of line B with the floor of the maxillary sinus. Different angles for TETS insertion were measured at 60 degree, 45 degree, and 30 degree to the occlusal plane, and each line was labeled as B1, B2, and B3 respectively. So the thickness of the infrazygomatic crest were measured from SB1, SB2, and SB3, and same goes to the CBCT scan. The same steps were repeated for both left and right sides and on the mesiobuccal and distal buccal roots of the maxillary first molar, and all the data were keyed into the Microsoft Excel database and SPSS for data analysis. All of the objectives were analyzed by using the independent t-test. So now I'll pass on to my partner.
Thank you, Rachel. Good afternoon, I'm Shen Yi. Let's now move on to the results section. 80 CBCTs were taken from 56 Malay and 24 Chinese patients. This shows the distributions of patients according to the genders. Male subjects, 42, slightly outnumber the female subjects, 38, and the mean age of the samples were 29 years. Table 1 outlined the descriptive analysis of the infrazygomatic crest thickness based on the hypothesized angle of TETS insertion. In general, the infrazygomatic crest thickness increased as the TETS insertion angle increased, with the thinnest at 30 degree, 2.87 mm, and the thickest at 60 degree, 3.86 mm. Overall, the bone thickness at the distal buccal root was thicker than the mesiobuccal root, but was not statistically significant. While for table 2 and 3 shows the detailed measurements of the mesiobuccal and distal buccal roots of both ethnics according to sites and genders. The infrazygomatic crest thickness show no statistically significant difference between the right and left sides. Independent t-tests show no statistically significant difference between the genders as well. One interesting observation was at 60 degree. Chinese male presented with the thickest bone, followed by Chinese female, Malay female, and then Malay male. While for the distal buccal root, Chinese male still presented with the thickest bone, followed by Malay female, Malay male. And in this bar chart, we can observe the distributions of patients according to text insertion angle. At 30 degree, it shows the least percentage of exceeding 6, 7, and 8 millimeter, with none exceeding 8 millimeter. Moving to 45 degree, it shows more percentage exceeding 6, 7, and 8 millimeter as compared to 30 degree. Lastly, at 60 degree, it shows the greatest percentage of exceeding 6, 7, and 8 millimeter. Therefore, at 60 degree is the best angle of text insertion as the thickest bones was there. Building upon the results of our study, let's now delve into the discussion. In our study, we found that infrazygomatic crest having mean thickness range from 2.86 to 4.07, which is similar with the studies by Liu, who reported 2.9 millimeter at the lateral wall of maxillary sinus where tests were positioned. Next, our study also shows no statistically significant difference between the right and left side, which is consistent with the previous studies by Liu and Li. Furthermore, our studies also have similar representations as Li, who reported infrazygomatic crest was thicker in male compared to female subjects. However, our analysis did not find statistical significant difference between the genders. Lastly, our study also found that infrazygomatic crest was thicker in Chinese compared to Malay individuals. Notably, this is the first study to examine the infrazygomatic crest of the Malay subjects, and our findings were consistent with Lim, who reported significant differences in bone thickness at first molar region among different ethnicities, indicating a dependence on ethnicity of patients. Like all other research, our study has its own limitations that should be considered. Firstly, as a retrospective study, there's risk of bias, particularly selection bias. Secondly, the findings of retrospective study may not be applicable to broader population or context, affecting their generalizability. Lastly, our study utilized a reference line that may not be reproducible in all patients. It is not a true occlusal plane reference, and it may influence by the molar tippings or loss of cast tip structures. In light of our studies, we would like to suggest that the use of tests should be, we would like to suggest that the risks and benefits of utilizing tests should be considered on case-by-case basis. Next, we also would like to suggest that orthodontic practices maintain an inventory of tests with varying lengths to cater the diverse needs of patients. Lastly, we would encourage future researchers to conduct a prospective multi-center study to provide a comprehensive representation of the population. In summary, our study has revealed several key findings. Firstly, the infrazygomatic crest thickness increased as the text insertion angle increased. Secondly, the mean thickness ranged from 2.86 at 30 degree to the upper right mesobuccal root to 4.07 at 60 degree to the upper left distal buccal root of the first molar. Thirdly, the infrazygomatic crest tend to be thicker in Chinese compared to Malay individuals. Additionally, there were no statistical significant difference between the genders as well as the left and right sides. Lastly, we would like to recommend that ideal text placement is at 60 degree to the infrazygomatic crest area above the upper distal buccal root of the first molar, as the thickest bone at this area will allow longer text insertion. And we would like to express our sincere gratitude to our supervisors and also statisticians. And this is the list of our references. Thank you all for your time and contributions.
Thank you, presenters. Now I would like to open the Q&A session to the judges.
Hi, thank you for the presentation. May we know what is your demographic distribution of your 80 patients? How many Malay, Chinese, male, female? You didn't present that data?
Yeah, we present it at the first slide of our results, which we have 80 CBCTs from 56 Malay and 24 Chinese patients.
Female?
And for male, 42 male subjects compared to 38 female
Okay,
subjects.
sorry, well, I have missed that. But how do you decide the Malay and Chinese? Do you have any stratification in terms of mixed marriages? Are they pure Malay? Are they pure Chinese? To what generation? Because when you come to ethnicity, this is very important.
Okay, so to confirm the ethnicity, we will call the subjects and confirm that they are prior to them. There are two generations who are Malay or Chinese, and also by this, we will take the statistic from the all Malaysian population by the races demographic to confirm that we are using more Malay than Chinese, because in the Malaysian statistics there is 70% of Bumiputra and 20% of Chinese.
Yeah, okay. Thank you. Very good. But Bumiputra doesn't mean Malay. You have to understand that. Okay, the other one that I think may influence your data is you have your variable is ethnicity, gender, height, and thickness, but yet you use an independent t-test. So independent t-test will inflate the type 1 error if you do everything one-to-one. So
Okay.
I don't know why you use independent t-test.
Okay, thank you for your question, Prof. So because we think that it's an undergrad study, so it is sufficient for us to look into the data separately. That's why we use an independent t-test. But however, we know that if we need to group the variables together, we need to use either ANOVA test for if there's two variables, or ANCOVA test if there is 4 variables.
Yeah, I think you should not think that because this is undergraduate study, therefore you use a simpler test. You must use the right test. Okay, just like just now, doesn't mean that there's no data, therefore we have to do research. There must be a real question to why we do things. Okay, so I hope you understand this.
Okay,
Thank you.
Prof.
There's 10 seconds left. Okay, thank you to the judges and presenters. This marks the end of the oral presentation. Thank you all for joining us. I shall pass the floor now back to the MCs.
Thank you to the moderators and the presenters. Ladies and gentlemen, now we will be displaying video presentations for the top 3 winners from the international presentations who presented earlier. Ladies and gentlemen, please kindly direct your attention to the screens for the international presentations.
Simvastatin regulates autogenic differentiation by stem cell isolated from apical papilla. Simvastatin has emerged as a promising candidate to modulate stem cell behavior, affecting cell proliferation and autogenic differentiation in various types of stem cells. Stem cells isolated from the apical papilla or scabs are the main cell source in regenerative endodontic treatment due to their ability to withstand pulpal inflammation and necrosis. The successful regeneration of the dentine pulp complex hinges on the migration of the stem cells into and their proliferation in the root canal pulp complex, as well as the ability of the stem cells to differentiate into odontoblasts-like cells. The aim of this study was to investigate the effect of simvastatin on scabs viability, proliferation, migration, and osteogenic differentiation in vitro, which could potentially enhance regenerative endodontic treatment. Scabs were isolated, characterized, and then treated with various concentrations of simvastatin. We first evaluated cell viability and proliferation. Next, we evaluated the cell migration capability of scabs using an in vitro scratch assay. And then we evaluated scab osteogenic differentiation. And finally, we evaluated the gene expression profile using transcriptomic analysis by high throughput RNA sequencing. In the cell viability and proliferation assay, the live day staining at 24 and 48 hours and MTT assay at 24 hours revealed no significant increase in dead cell in all simvastatin treated group, indicating simvastatin did not induce any immediate cytotoxicity in scabs. Cell proliferation was assessed by MTT and colony forming unit assay. The MTT result demonstrated a dose-dependent reduction in cell number, which was significant on day 3 and day 7 with 500 and 1000 nanomolar of simvastatin. The colony forming unit assay also showed a dose-dependent reduction in colony numbers and cell density except for 100 nanomolars. On day 7, 1000 nanomolar of simvastatin trigger early cell apoptosis and alter the cell cycle by significantly increasing the sub-G0 population and slightly decreasing the G0/G1 population. In the cell migration experiment, at 24 hours, 500 and 1000 nanomolar of simvastatin reduced the cell migration rate. This effect became significant when the observation period was extended to 48 hours. In the osteogenic differentiation evaluation, simvastatin reduced ALP staining in concentration-dependent manner and increased mineral deposition in concentration-dependent pattern, significantly at 1000 nanomolars. The mRNA expression of osteogenic marker genes was evaluated at day 7, showing a significant upregulation of DMP1, OCN, and OSX genes with 1000 nanomolar of simvastatin. The gene expression profile of simvastatin-treated scabs showed that 559 genes were downregulated and 463 genes were upregulated. The top 112 differentially expressed genes are presented in the heat map. The enrichment analysis showed that the upregulated genes were related to TGF-beta signaling, cytokine to cytokine receptor interaction, including the BMP2 and MAPK signaling. The downregulated genes were associated with homologous recombination, cell cycle, and p53 signaling. So studies have found that simvastatin lower lipid levels by inhibiting the mevalonate pathway, which is a source of precursor crucial for small G3S function like RAS protein. So the alteration in this pathway can activate the RAS, MAT, ERK, BMP2 pathway, promoting the osteogenic differentiation. The upregulation of the MAPK pathway further supports this hypothesis. Additionally, the upregulation of the TGF-beta pathway, including PI3K/AKT and TGF-beta1/BMP2, also supports osteogenic differentiation. The downregulation in homologous recombination, cell cycle, and p53 pathways correspond with the increase in cell apoptosis we observed. Although simvastatin decreases scabs proliferation, viability, and migration, it remains a potential inducer of osteogenic differentiation and may be useful as an adjuvant in regenerative endodontics. And furthermore, it could also serve as a promising pulp capping material and aid in periodontal regeneration. Thank you for your attention.
Warmly welcome honorable judges in the audience. I'm Tak Thanh Dong from School of Dentistry, Hanoi Medical University, Vietnam, and it's an honor for me to be here in our conference and presenting the study about clinical features of MIH affected permanent anterior teeth and treatment experiences using trans-illuminated light. Well, as you can see, MIH or molar incisal hypomineralization has been a frequently encountered dental condition worldwide. And for treatment, the resin infiltration, which is a minimally invasive procedure using the icon DMG, is currently showing positive improvement and receiving significant attention. Therefore, our study aims to evaluate the characteristic of MIH lesion on permanent anterior teeth and assess factor related to resin infiltration procedure. This is a cross-sectional study, including the MIH affected permanent incisor and canine after a diagnosis of MIH. Reflected light and trans-illuminated light photographic images were taken. And we apply the recent classification by Omar and David J. Manton. You can see for A here is a non-color and B is a color lesion. C is heterogeneous and D is a homogeneous lesion. And E, F, G here is the 3 level of lesion size. Next is surface integrity. A is sound enamel, B is enamel craze line or ECL, and C is post-eruptive breakdown or PEB. Next, we have lesion types. We have type A is type 1 if the area is an isolated and homogeneous lesion. B is type 2 if the area is an isolated but heterogeneous lesion with opacity and extension. And C is multiple isolated opacity separated by a sound enamel. Now let's look at our treatment protocols based on the icon tree and the EAPD guideline. You can see we have 5 main stages. The first stage is isolation and cleaning. Next day, we have microabrasion with opalus. Next, we have icon etch, icon dry. Next is icon infiltrant. And the last stage is possible composite fillings, glycerin, and polishing. Now let's look at the most important part, the result of discussion. You can see from table 1 and table 2 down here, we have found the significant association between the color, lesion color, and the rate of developing ECL or PEB. But this is understandable because yellow and brown opacity have been scientifically proven to be softer and more porous, so we have a higher risk of developing ECL or PEB. Another noticeable factor we found interesting was that female has the lower risk of having color lesion, but higher risk of having ECL or PEB. Well, higher color lesion found in male could be understandable by knowing that female tend to have higher interest in oral and general health. But given that the color lesion has been shown to increase the risk of ECL or PEB, this put us a question about whether specific hormones about gender might play a role in this one. And for treatment, you can see the color lesion are more likely to require spot transformation to improve the post-eruptive operative aesthetic appearance. And female were also reported to have the higher likelihood of using spot transformation because they often show higher attention level to the beauty and aesthetics. And homogeneous lesion also are more likely to demonstrate the higher need of spot transformation because these lesions were usually associated with the more severe destruction of the MIH lesion, thereby increasing the likelihood of staining. And lastly, looking at the chart, you can see here, for PEB, require the lowest etching cycle, about like 4 etching cycles, because the enamel surface has been broken down with a decreased mineral density. And moreover, looking at this chart, you can see that more opalus cycle in general for microabrasion require lower etching cycle because the access depth from opalus was significantly higher than etching. Therefore, for deep MIH lesion, the higher number of opalus cycle could reduce the unnecessary etching cycle and lower the treatment time. So in conclusion, lesion size, color, and gender are significant for evaluating the rate of ECL and PEB. For resin infiltration, lower number of etching cycle were needed for PEB. And spot transformation using 5% sodium hypochlorite was required for color, homogeneous lesions, and female patients. So therefore, dental practitioners need to take careful account of these factors to guarantee a comprehensive approach for patients aesthetically affected by MIH. But that's the end of my presentation. But thank you for listening.
Hello, it is an honor to present my research project here at the 25th University Malaya and 3rd International Dental Student Scientific Conference. My name is Lou, and my project focused on optimizing an analysis pipeline to identify genetic variants in amelogenesis imperfecta, which will be short for AI during this presentation. First of all, to give you some background information, AI is a genetic disorder that affects the formation of dental enamel in primary and secondary dentitions. Reports have I work with the Leeds AI research group here in the UK and conducted my project using exome data generated from 96 AI participants. The first part of my project focused on the optimization of an analysis pipeline. From this diagram in the method, we can see raw exome data was first aligned with the HG38 human reference genome. Then different bioinformatics tools were applied to process the data. The sequence variants were then annotated according to the updated SNP and indel and CAT databases. The last step is to filter all the variants against various parameters. After reanalyzing this AI cohort, we found 52 variants that were not recognized during the previous analysis. Different versions of the reference genome, updated databases, and different threshold parameters used for filtering all contributed to the new findings. During my project, 4 of the variants were prioritized for further investigation based on their extremely low allele frequency, high CAT score, and the likelihood of being pathogenic variants causing AI. We can see here in Figure 1, 3 families from Birmingham all had this homozygous ACP4 variant. The pedigrees and electrophoregrams showed variants segregated with an autosomal recessive inheritance pattern. The presence of the same variant in 3 different families from the same geographic area also suggests they may share a common ancestor. This can be investigated by determining the haplotype of nearby variants using long-range PCR in the future. The other 3 variants we tested here require more work to determine their associations with AI. For example, in Figure 2, the LTBP3 variant found in family 276, hypomaturation AI is not consistent with the described hypoplastic LTBP3 related phenotype in the literature. Now, if we look at the LAMA3 variant identified in family 278, although the irregular hypoplastic enamel is consistent with the reported phenotypes, there may exist another variant contributing to AI based on the digenic inheritance pattern of LAMA3. In conclusion, cohort analysis demonstrated an improved ability to identify AI variants, and it was time-saving in comparison to the previous case-by-case analysis. This built data repository allows future sequencing to be compared to a standard aligned dataset to exclude any artifacts or false positives. We hope in the future, efficient genetic analysis can be achieved by using this updated pipeline to identify AI variants in the future. If we can establish a relationship between genetic variants and clinical presentations, relevant management of AI can be delivered timely in a structural and scientific approach according to the genetic findings. And that concludes my presentation. Thank you for listening.
Thank you. Now, we will have a sharing session by Ms. Vivian Wong Siu Yao on protecting patient smiles against dentine hypersensitivity. Ms. Vivian is the Senior Product Specialist at Helion, formerly known as GSK Consumer Healthcare Sendirian Berhad, one of the largest providers of specialist oral health. With a broad range of science-based products such as Sensodyne, Parodontax, and Polydent, Vivian, already in the company for 8 years, is responsible for building brand equity amongst the dental healthcare professionals and dental institutions to drive continuous recommendations and endorsement of Haleon and oral healthcare products. Ladies and gentlemen, please welcome to the stage Ms. Vivian Ong Siu Yao.
Hello, a very good evening. My name is Vivian, a senior product specialist from Halion Malaysia Sdn Bhd, formerly known as the JSK Consumer Healthcare. So today, very happy to have this opportunity to share to you all a very new product that we just launched in January. So this is a toothpaste that we have, we call Sensodyne Sensitivity Gum and Enamel. This is a triple action with one toothpaste. So I will share further to you and what is this unique of the selling point of our Sensodyne Sensitivity Gum and Enamel. So this toothpaste is help your patients to prioritize all three conditions at once. It can help to reharden the enamel, helps to restore the gum health, and also provide a long-lasting sensitivity protection in just 2 weeks of time. So your patient's enamel plays a vital role in protecting from the dentin hypersensitivity. And you can see from here, the enamel is, although the enamel is harder than other parts of the body, but over the time, it can be gradually wear away. So acid softened enamel, such as attrition, abrasion, it also will cause your patients to have this tooth wear. So what is the prevalence and causes? So how prevalent is erosive tooth wear? So this study has shown that everyone with the natural teeth is at the risk. So the global prevalence range between the 20 to 45%. And in European study, at the age of 18 to 35 years old, it shows that 57% of the subjects has some sign of enamel erosion. And the prevalence in China, in the age of 35 to 49 years old, it shows that 67.5% of the patients having the dentin exposure and 64.7% in the same group. So what is the risk factor for sensitive and erosive tooth wear? So you can see that more of the patients might have complained that they might have heartburn or acid reflux, or you can see that some of the patients have the acidic dietary intake. So nowadays you can see that a lot of patients, they are very health conscious. They drink a lot of lemon juices or isotonic energetic drinks that it might be very aggressive. So the role of diet in the enamel erosion, the acid-rich modern diets nowadays can contribute to demineralize of the tooth enamel. So this can leave the enamel weaken, and it will the factors will cause the patient have a greater risk to which include as few as 4 acidic challenge a day, prolong the exposure to dietary acids, and frequent intakes of dietary acid. So this is all the photo or the early signs of enamel erosion that you might see in your practice. You can see they might have surface change, okay, enamel thinning, and you can see the loss, the surface becomes shiny and glossy. So this is the early sign. So if it not detected early, it can be, enamel erosion can be progressed. So you can see that the teeth can become shorter and it can make them too difficult to do the restorative, okay? And you can see this is all the image that enamel erosion. So prevention is the key. Doctors or the future dentists, so you can actually help your patients to make the case or the scenario more worse by you can teach them to follow the following steps. So the first one, you can ask your patients to minimize the exposure to acid. So like they can actually reduce the consume of the acidic food and drinks, and they can do not hold the food or acidic food against their teeth, okay? And also they can brush their teeth with appropriate technique and the timing. So like brush gently through with a soft toothbrush and avoid brushing immediately after consuming the acidic food. And also you can ask your patients to use a specialized toothpaste which is optimized for high fluoride uptake. which can ensure the toothpaste have a standard or low abrasivity, and recommend a specialized toothpaste to help to prevent the enamel wear. So for today, I would like to share to you our latest product, which is our Sensodyne Sensitivity Gum and Enamel, which can help to reharden the enamel, helps to restore the gum health, and to provide a long-lasting sensitivity protection in just 2 weeks of time. So we have studies and clinical to show on how it can help your patient, okay? The active ingredients for this toothpaste that come with the stannous fluoride and the sodium fluoride. So study have shown that by using the Sensodyne Sensitivity Gum and Enamel compared to normal fluoride toothpaste only, from the graph over you can see that after week of 8, 63% greater in reduce the sensitive relief. And also you can see that from this graph, you can see it significantly reduced the bleeding gums in just week of 2. So you can see the bleeding index is reduced. So how is this Sensodyne Sensitivity Gum and Enamels that come with the stannous fluoride works? So you can see that it can help to improve the gum health through the effective plaque control. So you can see from the image over here, the top one, which is represent the green color, which is represent the live bacteria, and the first is the 3 species, and the center, which is 7 species, and the right side is 10 species. And treatment after using a stannous fluoride toothpaste, you can see that the live bacteria all become red color, become dead bacteria. So you can see that how effective stannous fluoride can help to improve the gum health through the effective plaque control. So you can see that early and mature the plaque are affected by the antimicrobial actions of the stannous fluoride. So the early stage and the matured and the plaque stage, just like your mild, moderate, and the severe of the gum disease. Okay. And the unique point for our Sensodyne Sensitivity Gum and Enamel, that actually we do have the study shows that it helps to strengthen the enamel surface. So we have studied and shown comparable placebo and as well as the Crest Pro Health. You can see that it's significantly more effective at promoting remineralization in the acid softened enamel compared to the placebo. And the Sensodyne Sensitivity Gum and Enamels come with these unique features that you can see from the left image. They have this spherical silica. You can see that come with these softer, rounded physical properties. So it can resulting in a lower RDA. So the toothpaste come with only 22, which is lower than 30, the RDA. Compared to the traditional type of the silica, you can see that the edge come with a rougher shapes and forms. So a low abrasive formula, which can be gentle on enamel. And this toothpaste, right, come with this latest microfoam technology. So what is this microfoam technology, right? It's contain 38 times smaller particles, microparticles designed to rush in between the teeth and along the gum line. So it can help to deliver the active ingredients like the stannous fluoride to hard to reach area easily, like interdental and along the gum line. And hence, it can formula targets and remove the plaque bacteria for healthier and firmer gums. So you can see it instantly start to protect against sensitivity by creating a protective layer while removing the irritating plaque with this microfoam technology. So you can see how it goes through the gum line and also the interdental part. So to summarize my session over here, the toothpaste that we launched, the new introduced is one specialized toothpaste that can help your patients with 3 conditions. So come with this microfoam technology and as well as the stannous fluoride and the sodium fluoride. It contains 1,450 ppm fluoride. So it's a high content of fluoride. So it's clinically proven, can help to reharden the enamel, helps to restore the gum health, and provides long-lasting sensitivity protection in just 2 weeks of time. So this is the product tool that can actually help your patients to help doctors to recommend to your patients. So when your patients comes to you, you can ask probe further whether they got sensitive teeth. If yes, then whether they got any sign of early stage of perio or gum issue. If yes, then doctors you can further to check with them whether they have tooth enamel erosion or discoloration. If yes, they need the triple action. So the left side, which is all the yes, then come to they need a triple actions formulation toothpaste. And if the patients tell you, oh, I just have sensitive teeth and also only gum issue, then just go for our dual action, the Sensodyne, sensitivity, and gum. But how if your patient just tell you, oh, I just have sensitive teeth, I don't have any gum problem, then just go for our singular treatment, Sensodyne, repair and protect, or the Sensodyne rapid relief for the fast relief. And the last one, if the patient say, oh, I don't have any sensitive teeth, I only have gum problem, then go for our Parodontax, which contain the sodium bicarbonate and the sodium fluoride, which can help to remove the plaque bacteria even better. That one to treat your patient that suffer from bleeding gum, gingivitis, and the periodontitis. Okay, thank you so much and have a nice day.
Thank you, Ms. Vivian Ong Siu Yao.
And now, we would like to invite Mr. Wilson Wong, Head of Career and Mental Wellness of Clinic Pergigian Doctors Wong and Partner, to the stage to give a talk entitled Mental Health and Self-Care for Dental Professionals. Please welcome.
Hello, selamat petang dan selamat sejahtera semua. A very good afternoon to everyone. First of all, allow me to extend my appreciations to the organizer, as well to Tatin Jane, for giving me this opportunity to be here talk about mental health and self-care for dental professional. Izinkan saya juga untuk membentangkan presentasi saya dalam bahasa Inggeris ya. Before I go for the presentations, let me talk about a little bit about myself. My name is Wilson Wong, as you know. I've been in corporate for almost 26 years, and I'm in the area of human resource. I work with MMC and local company. I've been holding various of senior management person HR. Generally, my job involves I recruit talent, I develop talent, I promote talent, and I terminate people. People who are not performing, people have committed misconduct. That's some of my responsibility in all these years and 26. And to be very frank with you, in out of 26 years in HR, I've seen how people struggle, working very hard day and night in order to sustain their career and also to build their career to the aspiration that they want to. I also seen how people struggle very, very hard just to attain and maintain their career. And when they struggle, many of them end up with serious mental health issues. Even I know some cases that end up with hospitalizations. So this is where my duty here come in here to understand what are the challenges they are facing or my client is facing in career. And we found ways and means to help them go through these difficulties, help them rebuild, rebrand their career so that they can achieve their inspired career. And that's also where it's my function at Dr. Wong and Partners. And along with my career, I actually further my study and I completed a master in counseling. And through these studies, I understand better what is mental health, how important is mental health, and how mental health impact the career and how career impact the mental health. Being dentist is also a career, a very, very important, precious, and respectful career. We can talk about that later on. So this is my agenda. I'm going to talk about what is mental health, some statistics affiliated with dentists, why mental health important to you, what causes mental health, sign of mental health, sign of potential mental stress, what stops you from seeking help, self-care to evaluate mental stress, and where are you now? Now, I know I just got about 15, 20 minutes of presentations. Please do remind me and hope that, if I overshoot the time, please forgive me, and I try to remind myself to be conscious of the time. Now, I know all of you are elite, all of you are academicians, all of you educated, well-educated, yet I still need to come back into the very basics of my presentation. It's the definition of mental health, so that you and me, we are at the same page. According to WHO, mental health is a state of mental being that enables a person to cope with stress of life, realize their ability, learn well and work well, and contribute to the community. In short, when you have a good mental health, it means that your cognitive, your emotional, your behavior, your psychology are able to perform adequately and normally. Let's look at the other end. If you are facing challenges in mental health, well, perhaps you might be facing mental stress. And mental stress, in fact, all ethnicity, ages, gender, professional, and group, happen to you, happen to me, happen to everyone. Now let's look at a bit of statistics, especially statistics related with dental. According to ADA, which is actually American Dental Association 2021, in his article called Dentist Health and Wellbeing Survey, it has indicated that 54% of dentists reported having medium and high level of depressions. Let's look at internally Malaysia. It was a very impressive research done by Noritan, Lydia, Rahima, and Nohria in 2017. And the title of the research is called Self-Perceived Mental Well-Being Among Malaysian Dentists. And in this report itself, I think Prof is laughing there, it might be someone that you know here. In this report here, indicated 61% of dentists perceive having positive mental well-being. That's great. But there are 30% stated that they were stressed physically and emotionally. And this 30% is what we are concerned about. Let's go further. MOH, Malaysia's Minister of Health, in 2017, in their publication entitled Mental Health Problem in Malaysia, it indicated that 1 in every 4 worldwide experience mental disorder. In the same publication, it indicated that 1 in every 3 Malaysians experience mental health issue. It is alarming, my friend. So what is mental health? Why mental health so important? Now, since COVID-19, people have been talking mental health, nothing new anymore. But the problem now is how serious people perceive mental health. Long cut short, okay, with a time frame, let me briefly talk about this slide. Why mental health so important to you? Because mental health will decide the quality of your life. And your quality of your life will decide the strength for you to face life uncertainty. It enables you to make informed decisions and live our life with a sense of purpose. You know what you're looking forward to. An ability to deal with emotional and physical problems. You and me, friend, we are human beings. We are up and down. We can smile, we can sad, anytime or a moment. So a quality life allows us to face that uncertainties. A good quality life as well allows us to cope with our daily, day-to-day challenges and day-to-day activities. In short, having a good mental health, it helps you create a good quality life. And a good quality life will make you be a happy, successful, and satisfied human beings. So what causes mental health? Now, I'm sure this is nothing new to you. You have seen this before, somewhere, someplace. But then, how often this has triggered your mind, whether I am facing this issue caused by this reason? Let's look at the first one. Let's look at the first one who caused mental stress. Having multiple important decisions with limited time frame. Being a student, you need to complete your assignment. I've been a student before. You need to complete your assignment. You ensure you must good result. You also ensure that your practical do well. Everything, and plus with your family issue. Being a doctor, when you're a graduate or those dentists out there, not only ensure that you must get good customer service to customers so that you won't have complaint from the customer service. And if you are practicing your own, you must ensure that you have enough clients to sustain. plenty of issues, plenty of responsibility. It's a very stressful thing. Let's look further. Long working hour. Being dentist is a service line. And service line, generally that the time working hours are unstable. So whether 9 to 5, you might be working in shift, you might work on Saturday, Sunday. Sometimes you could burn out as well too. The third reason why could cause mental stress is not having the most present patient with high expectation. I'm sure many of you agree with me, especially those now are practicing dentists. I'm sure you and me will hope that all clients that we have will come in with a smiling face. Good morning, doctor. Thank you very much. Do whatever my teeth. And thank you very much. I leave here without any complaint. We all hope that. But the fact of life is not like that. We have all kinds of clients. We have clients coming with a sour face, high expectation. They pay you some fees or some service fees and they expect you do wonder. They make them give them tip-top performance and show that when they're extraction, not even a single pain. Very high expectations. Now, the second one is deal with patients with extreme fearful anxiety. I think that's not new. Had a honest speaking, that applied to me as well. Perhaps I can share with you one of my own personal experience. Okay, if time allows. Do you want to hear or not, my guys? Okay, organizer, if time runs, don't blame me. Request from the audience, yeah? Okay, this happened to me 10 years ago, real thing. It's actually, I'm going to see a female dentist. Again, no prejudice on female dentists, nothing on the gender. It's just that it's a real story, so I cannot change the character. Okay, so it's a Chinese female dentist. I went there to extract my wisdom tooth. Everything fine, then he did injections. While you're extracting my tooth, he said, wow, you have a very huge wisdom tooth. And then I can see it try to pull up my teeth. Wow, you have a very, very deep nerve inside your body, you know. Whew, I'm not sure I can or not, but I'll try it. Then I'm still trying. I know he's trying very hard. And then I think I'm not sure, should I get my milk clinic to help me? I may not enough strength. What do you think? Should I go for a milk clinic? Oh gosh, I'm opening my mouth. My eyes was looking big. And now you're telling me you're having issue of pulling my teeth. It's a true story. Anyway, these doctors are very nice. Finally, he managed to pull up, extract my teeth. He's a very nice doctor. In fact, after that, he even asked me, look at your teeth. Do you want to bring home as a memory? Well, to be frank with you, he's a very nice doctor. I know he's trying to make me calm, but unfortunately, the conversation, the topic wasn't help me, but give me more tension. I know he's under stress, but I just want to tell him that I'm even more stressed as a client. So it is indeed, yeah. The next that causes mental stress, job satisfactions. Yeah, this is a very topic, all right? It's a very topic in terms of job satisfactions. You either, when you are graduated, when you become a dentist, you either been offered a task which is too simple that you think you can do better, or you've been asked to do A to Z, where you just join as a dentist and may not have experience. Both parts find that you have a stress in your work. In stress in work as well too, is also related with your age. In the mental health, we call that midlife crisis. If you heard that word before, it happened to me. Very frank, I can stay in HR, being here for 27 years. I can stay in HR very comfortably. I can change another company, high positions with a quite decent salary. But I choose not to for the last few years because that's not what I want. As I growing older, I noticed that chasing career, chasing for money, chasing for status, chasing for power, no more my core of value, no more the something that I'm looking for my life. What I want is to help people going through difficulty in life, in their career, so that they can be happy people. Seeing people smiling is something that the greatest fulfillment I never had in my life, which is true since I become a counselor, come with HR consultations. I have great, wonderful satisfactions which I never had while I was working in a corporate. So again, your job satisfactions will change as age catch up. Now, having that thought, not an issue. Now, what's the problem come in? The problem come in when you say that you are no more interested in your job, but you don't know what to do, don't know where to go. And hence your leg are tight because you have a lot of commitment, financial, and you drag your leg to your office and start working. That's where the stress come in. I've seen a lot of clients with this, and this is where we always help the client, help them build and rebuild their career paths on that. The second last will be the non-conducive working environment. Now, non-conducive environments is also a very big topic. I can take whole day talk about it. When you work, whether on a private, in a government, or you have your own clinic itself, you don't work alone. Even you have own clinic, you have your partner, you have nurse to help you. All these things could be make you very frustrated with your work itself. I also want to tell you true story of conducive environment. All right, so let's go for the first one. In my research, through my master, my research will talk about midlife crisis. I'm quite well versed with midlife crisis topic. I've interviewed a lot of respondents. One of the respondents told me when I asked them a question, "Hey, have you ever gone through midlife? Have you gone through mental health crisis or challenges in your mental health?" He responded to me, "Oh, I did. Past few years, I have a horrible time. I hate my boss so much that there was a moment where I thought that I just want to punch him, kill him, and jump down from the window." Sounds scary, right? But it's a fact of it. Of course, it's the pressure given to the boss. The boss has been talking bad about him, giving high KPI that he couldn't achieve, talking bad among all them. But he was a manager position during the time. He just couldn't find the stress. But don't worry, this guy at the safe place now. He's moved on to another company, doing very well. And do you know what makes him stand up and walk away from the darkness of life or the career? It's the love that he has from his family. What makes him strong? Because he has a lovely wife. Always tell him that, no worry, if you think too stressful, take a break. I'll take care of the financial part. What makes him strong? Because you see two of his cute little girl, one boy, one girl. He wants to see his children grown up. That gives him the strength to move on, continue with life. He's definitely now fine, performing very well, right? So just like in counseling, what we did, always find the strength for our patients so that with the strength itself, you find something to hold on to walk away from the darkness of life and the challenges in the mental health. The other one, okay, time-wise, I just talk about one example. And the other one is talk about personal and family issues. And none of us go away from there. I'm sure you have issues. If you are with couples, with your boyfriend, girlfriend issues, family, if you're married, some I've seen for divorce cases because husband and wife, when kid grown up, another part of issue. All these reasons, 1, 2, 3, 4, 5, 6, 7, are the main reason that contribute to the cause of mental stress. Does any of these reasons alarming to you? Or are you facing some of these reasons that cause you also facing mental health stress? I'm very quickly go to this slide. I know because time-wise. Now, these are the signs of potential mental stress. When I talk about signs, I can divide into two areas. One is physical behavior, one is emotional behavior. Let's look at some of the things. Physical behavior sign: loss of interest in work, frequently complain of ache and pain, low energy, withdrawal from society, and so forth. When it comes to the emotional part, you will does not seem to be okay with anything, change your mood of behavior, sudden mood, and then the persistent feeling of hopelessness and helplessness, and so forth. Now, that doesn't mean that if today you go home, you feel very tired, you feel no energy, that doesn't mean that you're having mental health issue, okay? That's fine. Generally, when you're having mental health, we have some guideline as under the DSM, which is used by most of the mental health. In fact, we do have assessment to assess whether you are under mental health stress. In fact, when we meet you up at client for first 2 sections, we will ask you a lot of questions about your history, how is the condition now, to quantify whether you're really going through facing some mental health challenges. So not to worry about that. Now, what concern is on the top 2 arrow, career and mental health? Why they are facing each other? It's because they are interconnected, they are not standalone. Career affect mental health affect career. Also, very frank, if you facing mental health, will you seek help? Will you? Will you? Will you? To be frank, from the circle that I know, from the client I see, chances are you will not. Tell you a true story that I actually, I'm providing a service to an organization. One day, a staff texts me, "Hey Wilson, can I see you outside for a while?" I said, "Sure." Hey, you know what? I think lately I'm very depressed, but I don't want to come to your room. I don't want to come to that counseling room because otherwise I'll come to that counseling room. Have you thought that I got mental health issue? Can I see you during lunch hour? So that when we talk, people thought that we're just talking about lunch. No one knows that we talk about mental health. I have happened to talk to some doctors, my friends, and about mental health. I remember very well one of these doctors told me, these are things, actually down that statement is come from that doctor. He's not a dentist, yeah? He's just a normal GP doctor. He said, as a doctor, I am not allowed to be unwell. I'm not so sure how true it is, but I respect his point of view. He said, as a doctor, I'm concerned how client look at me. If I know that I'm having mental health, I'm not sure how they're going to perceive me. As a doctor, I'm concerned how my supervisor, colleague, family, and others view me. And as a doctor, I'm concerned if they know I'm having career challenges, would it impact on my career opportunity and progressions? I'm not going to talk about this slide because this is a very big topic that we can talk whole day as well. I want to leave it to you. You do your evaluations. Is that also stopped you for seeking for help? If you are facing any mental health challenges, you give yourself an answer. This should be my second last slide. So we talk about what is mental health. We talk about importance of mental health. We talk about what impact mental health and what stops you to seek for mental health. Now let's look at self-care. What can you do if you are experiencing some mental health challenges? These are some of the challenges. First of all, identify the cause of mental stress. Just like you all being dentists, if you see a client look at the teeth, you also must find out what is the problem with their teeth so that you know you can use what kind of treatment to the client itself. Same go to here. When we see client, we will ask actually, what can I help you? What are the challenges you are facing? And to be frank with you, most of the time, many of the time, pretty often, the client will tell me, I don't know what's wrong with me, but I just know that I'm very tired. I just know that I have no appetite. I just know that my mood swings very fast. Not be surprised. So if you are facing that issue, I strongly advise you to go for point number 2, seek help from mental health professional, either seeing a psychiatrist, clinical psychologist, or mental health counselor. To be frank, in terms of mental health, these are 3 big scope of professional, and each of us here do mental health in slightly different way, but we all corroborate each other. The third is showing compassion to yourself. This is very interesting. You know, Malaysia being Malaysians, I've been seeing a lot of YouTube, a lot of foreign talk about Malaysians, always have very good heart, very friendly. When you see your friends having suffering, not doing well in exam, you consult a friend, not so sad, your result, don't really try harder. If you see a beggar at the road strike, you think, oh, I'm so sorry for the beggar. But when you are facing stress, have you ever shown compassionate empathy to yourself? Pose a question. For those that are having headache, I'm sure sometimes you feel headache. I used to face headache. What do? You will just knock your head. Oh, I'm so painful. My brain, I'm so painful. Why this time I got exam? Generally, this is what you can do, right? Perhaps next time when you face headache, you do some empathy and compassionate to yourself. Talk to your brain. Hey, brain, thank you very much. I know lately my exam, I didn't have enough sleep. I know you'll be holding on with me. Thank you very much. I really appreciate for that. Thank you with me. Take that as another part of your body. Show your empathy, show your compassionate to your body who have been supporting you. Trust me, you'll feel better. Number 4, sharing with frustrated party, family, and friends. Now, you look at my statement here, trusted party. I'm pretty emphasized on trusted party. Why? Because I've seen before as well, if someone are not, let's assume that you choose a wrong friend to tell about your mental health issue, or rather you not even a mental issue, just about your feeling, and say, hey, today I feel very tired. I'm a bit worried that I'm having a bit stress or a bit depression. You're having depression. Then if you go to a wrong person, the words might spread around from not really having depression, just being tired, it becomes depression, mild depression, moderate depression, and major depression. Entirely, end of the day, everybody label you're having depression, which you are not at all. It's just that you're sharing with the wrong party. I also very particular on this point about sharing a trusted party. Yeah? Let's say that you're having a bad feeling, don't feel happy. Yeah, assume that you find you a little bit down. You didn't do an exam, you tell your friends. If a wrong friend, they might end up saying, I told you already, you should do this. Instead of showing sympathy, empathy, they start scolding you. I'm not sure about you. For me, that is stress for me. Number 4 is be always mindful to be present. This is one of very, very important technique, especially come to mental health. Yeah, a lot of time when you're under mental stress or you're under pressure in your exam, your mind fly away. You just know the pain that you are facing, but you don't know what you are doing. You're doing exam. So that is something that very important. That is called mental health. Now, you can find Google, internet. What are the different strategies for mindfulness thing? Now, mindfulness strategy is a certain technique that will help you to bring you back into the current, bring you back into the present. Some of the simple technique will be like technique manafast. Breathe in 5 times, hold your breath 5 times, breathe out 6 times, continue 4, 5, 6 times. It will help you to lower down your heartbreak, heart pressure and heart beating, and also it will calm you down. Some of the other mindful activity like talk about 1, 2, 3, 4, 5. 1 thing you can smile, 2 things you can taste, 5 things you can touch, and so forth. All these activities you can find easily in the internet, all with the same purpose, is to bring you back to the present, bring you back from your mind flying around, feeling focused about painful, sadness, depression, bring you back to where you are. Now, even a very short period of time by practicing this technique, at least at that moment, you're out from mental health stress. You're back to where you are. It's very important. You might join some support group and assume you find that you're not ready to face or look for any mental health support or talk to anyone face to face. You can go for online mental health support like Taran Kase, Befriender, and so forth, and take some break. Now, taking some break here, that doesn't mean that today I'm very bad word. I tell my boss I'm taking 1 month break, I'm going to Bali. No, it's not that. Taking a break can be a short period of time. If you happen to be scolded or blamed by a customer, just walk out from your place, take a coffee, look at greenie, and do some mindfulness activities, technique to make you back to normal. This is also considered take a break. This will be our last slide on mental health. I'm going to end my presentation by giving you back this picture. This picture is reflecting where you are at your mental health stage. Where are you now at the moment? Are you at the bottom there lying on the floor that looking for help? Are you the picture that hugging at the tree trunk that halfway don't know where you're going up or going to down and just looking for some people, nice people come around, hey, let me give you a hand? Or you're swinging left and right at the trunk that you don't know what is a problem with your mental health. Or you are falling down, that you are facing serious mental health issue. Think about it. Look at it carefully. Where are you now? And decide where you are. Be sincere to yourself and think what you're supposed to do to evaluate the stress, the challenges that you're facing now. I'm going to end up my presentations with 3 statements here. Doctors or dentists are not immune to mental health conditions. Career as a dentist and mental health are closely intertwined. And last but not least, taking care of yourself is just as important as achieving success in your career and life. Thank you very much. That's my presentation on mental health. And before I end these sections, I think Dr. Wang and partners, and I guess many of Dr. Professor who knows about Dr. Nicholas Yap Han Lim, who's a dentist who actually passed away, and we believe related with mental health issues. Let us give a few minutes tribute to him. No matter where he is, hopefully he will be peace and happy. Thank you very much again. Terima kasih. Thank you.
Thank you, Mr. Wilson Wong, for the interesting lecture. We are very sorry and condolences to Mr.
Moving on, we would now like to invite Dr. Jazli Aziz, Elective Committee Chairperson 2024, to deliver his speech.
Thank you to the Masters of Ceremony. Assalamualaikum warahmatullahi wabarakatuh and a good evening to Prof. Zamri, our Dean, Faculty of Dentistry, to our welcome guests, all members of the Faculty of Dentistry, and of course, all our students. So to begin, can I just quickly ask all of our year 5 students to just please raise your hand quickly, just so that I can see where you guys are? All right. So to all of you, as the elective committee chairperson, I would like to personally congratulate all of you on finally completing your elective project. Congratulations. I can personally say that you all did a very good job on your reports. And for today, I've been going up and down between here and the library. I saw a few presentations and a few poster presentations. You all did a very good job. So while this is a competition, I just want all of you to know that you should be proud of your accomplishments. And yeah, so be proud of everything that you've accomplished in this past year. This conference has always been a springboard for our year 5 students to showcase their research findings and also to foster their spirit of scientific inquiry. Unfortunately, to the outside world, dental research may not exactly be that glamorous, but as I'm sure that everyone here knows, that dental research is indeed very vital to the advancement of the field. Without it, we wouldn't have any innovations in dental materials, in dental treatment, nor in patient care. This conference, as you can see, has been organized for the past 25 years. So to put things into perspective, 25 years ago, I was just a small little skinny primary school student. And I'm sure many of our students actually weren't even born 25 years ago. So that's how much time has passed. And I'm sure you can imagine how different the practice of dentistry was 25 years ago compared to now. And all of these advancements, all of these innovations, they all began from research, just like the research that you have presented here today. Throughout my time as a coordinator, I have seen firsthand the dedication shown by all of our students. They contacted me at odd hours in the night, 10 p.m., 11 p.m., sending me messages, weekends, public holidays, and I know that the students even sacrifice their own holidays to do their research, working in the lab. So this has all been, this has all showcased exactly how dedicated they are to conducting and completing their research. And hopefully this small taste will be able to inspire some of them to go on and further pursue more scientific research. This conference, however, is not just about presenting research, or it's not just about conducting research. It's also about honing a vital skill, especially in today's digital world, science communication. Right? In this age of social media, there is a lot of information online. Not all of it is accurate. Not all of it is true. Unfortunately, there are many social media influencers who have huge followings, who share inaccurate medical advice because they lack the proper scientific or the proper medical training. And because of their large followings, people tend to listen to them. So this is why, for you, people who actually do have the proper medical training, it's important for you to hone your scientific communication skills. Because as dentists, one day, you will all be meeting and treating patients daily, giving you a very good opportunity to speak to the public face to face, giving them proper advice and ensuring that they do not follow the ill teachings of the social media dentists, right? Also, as much as this elective project has been about conducting research, I hope that the students also realize that this is also an opportunity for you to learn. You have learned about the rigors of the scientific method. You have learned about the intricacies and the complexities of statistical analysis. And you've also learned about the significance of dental research. So once again, I would like to congratulate all the students on a job well done. And I would like to thank all their supervisors, the assessors, as well as the judges from today for their hard work, dedication, and commitment, not just towards evidence-based dentistry, but also towards providing the scoring for our students, because ultimately, this is still a requirement for their degree. I would also like to take this opportunity to thank my committee members, Dr. Izian, Dr. Alia, Dr. Sofia, and Dr. Najiha for coming along with me on this journey and for a job well done in coordinating this project. This conference may be the end of the journey for our year 5 students, but hopefully this will also be a stepping stone for them to achieve greater things in their careers. Thank you very much.
Thank you, Dr. Jazli. Now we invite to the stage the 25th Universiti Malaya and 3rd International Dental Students Scientific Conference Chairperson 2024, Associate Professor Dr. Rose Anita Omar, to deliver her speech.
Testing. Yang berusaha, Prof. Zamri Razi, our Dekan, Dekan Fakulti Pergigian, para juri, para sponsors from Helion, Dr. Wong and Klinik Pergigian, Dr. Wong and partners, Helion, okay, and other sponsors, ahli-ahli jawatankuasa dan pelajar-pelajar yang dikasihi sekalian. Assalamualaikum and good evening, everyone. Today, as we know, we gathered here to mark a significant milestone to our Dental Student Scientific Conference. Yeah, celebrating its silver jubilee. As we know, our Faculty of Dentistry, Universiti of Malaya, being the first and the longest running Dental Student Scientific in the country. This year, we celebrate this moment with the involvement. It's very historical. Yeah, we celebrate this with the involvement of the international participants from 15 universities all over the globe. Yeah, from near and far. Okay, we have Indonesia, Philippines, China, Vietnam, Thailand, Uzbekistan, as well as from United Kingdom. Ladies and gentlemen, okay, today I'm sure you couldn't agree more with me that we have witnessed the quality of the research from our undergraduate students to be of high standard encompassing multidisciplinary aspects and utilizing modern and advanced technology in the research. I'm sure the judges must have a tough time selecting the best among the best. We're certainly honored here today to have our renowned academics who are very experienced in research. To those who don't know, they are our former Dean, Prof. Rosna, and Prof. Rahima. She's not here. And not to forget our internal judges, Prof. Tilak, Prof. Hayati, Prof. Chai, as well as AP Dr. Sharida, our head department, my head department. And to our sponsors, yeah, thank you very much for sponsoring our event. We hope all of us have made time to visit their booth. To those who haven't done, please do so, yeah? Thank you, sponsors, always for supporting our events. And for our students, especially our year 5 students, yeah, who are the shining stars today. You are the shining stars today, yeah?
Congratulations for successfully completing your research projects and your presentations. Indeed, you are all winners, but as a norm of a competition, we need to announce the top performance. For those who didn't win, don't be disheartened, yeah, please, okay, as you're all winners as well. The fact that you stand here in front, presenting your work and facing challenging questions from our judges, yeah, is commendable. Remember, this is just the beginning of your lifelong learning. Let's echo what being said by our keynote speaker today. Stand up and be counted. Lastly, for my ever dedicated and wonderful committee, thank you for your time, dedication, and support to make this a successful event. It shows our commitment to serving our students with excellence. Congratulations all. I'm not talking, not to take too much time of you. I'm sure you can't wait to find out who's the winner and who's going to hold the trophies there, okay? Okay, with that said, I hand over the floor to our esteemed MCs. Okay, thank you and best wishes to all. Assalamualaikum.
Thank you, Associate Professor Dr. Rose Anita.
Next, we will proceed with the summative feedback from the head judges of oral and e-poster presentations. With that, we would like to invite head of judges of oral presentation, Professor Dr. Rahima Abdul Kadir, to share her feedback. Please welcome.
Hello, everyone. Yeah, I am, one thing I don't like to go behind here because I cannot see all of you, yeah. So a very good evening. Thank you very much for staying back and let me just walk. Yeah, it's easier for me to walk. Yeah, and I'm very grateful to the organizers for inviting me and with the two colleagues that I have with me today. I know we may be a little bit brash, so we seek your forgiveness to all the presenters, yeah. But it is for your own good, yeah. And then, of course, this is the opinion of the judges, more or less, yeah. You have done a superb job. So give a hand to every one of you. Yeah. And we don't forget your supervisors. Your supervisors certainly have done their job too. So I appreciate your supervisors, yeah? And then, of course, remember, you win or you lose today, doesn't matter. You are all winners already. Yes. And a number of projects, I must say, and my colleagues are also saying that are competition materials locally, regionally, and globally. So we have many conferences coming up that may be including even the students competition. I urge you guys to go for it, yeah, and join us, whether it's at MDA, the local one coming up with SIAT, and the student nationals conferences and so forth. Go for it, yeah. And then, of course, a number of projects have values in terms of publication materials. So maybe while you're waiting for, I'm not asking you now to do it, yeah, year 5, maybe while you're waiting later, you know, when after you've done, you can still contact your supervisors, and if you want to write and send in a publication with your supervisors, who knows? It has potential in terms of publication, because I think some of us, we know we are all in the editorial board of other journals as well. Okay, most important of all, we can see that you are proud to have done it. Remember, this is at the level of undergraduate research. You must think back. If you are not very happy with what you have done today, do a reflection. Think back. This is part of learning, okay? Part of your learning experience at the tertiary level. First level. Who knows, in future you want to do masters. Well, you have already a background of research, isn't it? But I must say, understand that at this level, you are all doing undergraduate research. So we don't expect bombastic research. No research can be claimed as perfect. No, perfect research, is not a research. Yeah, so you are all in the process of learning, and if possible, do your research because you are curious, you want to know more. Yeah, not because you just want to finish off my degree and then go off and go to convocation and get your degree. That's not it. When we do research as a student, even as a student at undergraduate level, it is because we felt it is a learning experience. It's a first time exposure. It's something I'm curious about. It's something that maybe I'm interested in OS. Maybe I'm interested in public health. That will be the last, yeah, for many of you who are interested. Or I may be in OP or Resto. Then this is an opportunity for research to be done at that level. For this, I know it's coming up to the year 4 and below. And then, of course, just some advice from a long-term veteran who have been doing this. This is my 47th year of academic life. Yeah. Okay. Presentation style, what everyone needs to relearn. Yeah, that's relearn because even me, I learn every day. Okay, oral presentation needs you to talk and communicate. Don't look at the floor. Talk, yeah, effectively to get your message across because that's why you are put as oral presenters. And then the nose. Today I'm talking about this, the mumbling. There's no mumbling. Shouldn't be any mumbling because we can't hear just now some of you talking what you're talking about or fumbling with remote control. We can see some of you holding on to something, as though your life depends on it. These are things that you need to be careful about when you are doing oral presentation, especially for competition. And shaking the mic, you may not be shaking the mic, but I've seen people who shake the mic and because they're nervous. Suddenly they're nervous, they're holding the mic, as though they are going to, drop down. And then, of course, extensions, just keep it as cool and close as possible. Body language. Don't move too much. Yeah, you're not on a disco platform. Don't move too much. Yeah, and don't keep too still and like a robot too. Have some form of interaction with the audience. Yeah, and and eye contact, which we have seen just now. People are looking down at the stairs there. So, so you need to be more careful. And dressing, formal dressing, even in your abstract sheets. I can see in the outside sheet got t-shirt lah. Student wearing t-shirt, be formal, yeah, because this publication is formal, abstract, yeah. In future, please make sure that if it's a coat, everybody has a coat. And then, of course, coat and tie, we see. What are the pluses? We saw many who speak up with confidence. Very good. Very well done. And we need you to talk. Make sure you know your stuff. It's you who's doing it, not somebody else who is doing it. Because we can detect that if it is not you who is doing it. And then you need to improve on the right technique to answer, yeah? Because you listen. Then you say, if you don't know, be honest. I'm sorry, so Prof and so the judges, I'm not quite sure. Maybe I need to go back and have a look again. There's nothing wrong, but at least you're being honest rather than trying to be defensive. That's not what we want because usually judges are experienced people. And of course, this doesn't happen today. I'm happy. No consultation while on the platform because both of them are there. Yeah. And obviously, many of you have rehearsed. You know, it's like even we see trains going very fast, express trains. We cannot catch up with the train before us. And don't forget, there's a value of dentist. Smile. Yeah, even though you're nervous, smile and you are done. And then, of course, these are just for you. Yeah, we based on experiences that we have had presenting in our younger days at IADR, at wherever, how many slides in the time frame that you're given. The maximum for a 15-minute presentation is 15 minimum, maximum 20. That is based on 15 minutes, yeah, depending on the presentation. And you actually have factual slides, flash slides, because the last few ones that we see rushing through the slide, we also cannot see before we see it's gone. You know, how can we judge? It's there. And then my partner was asking, do you see it? I also didn't see it because I didn't get the opportunity to see. And then, of course, when you go to them, wow, bombastic, yeah. But I know there are a few that just this morning and this afternoon where we actually see too simplistic slide, yeah. Not too colorful. Wallpaper, when you use a slide, the backdrop should be hue in color, not glaring. It's harmonious. You are, look at it, it's nice because we are the ones who judge you, so we look at it, it's nice. And good size font, because today you all did very well, but there are a few that needs to improve the slide when they are doing it. And the most important is graphs and tables. Okay, graphs and table. Only present if you have too much data, don't put everything there. You are going to flash, nobody sees what you are talking about. So you only do highlights, only the important ones that you highlight. Yeah, you have to split up. So this is just what do you call this? A suggestion to you all. Plan on time allocation for oral presentation. I have there 10 minutes or 15-minute presentation. Usually it works. Yeah, usually it works for scientific presentation. Maybe in future, if you are going for IADR meeting coming up soon, you might want to have this and to guide you. Okay, I'm done. Best of luck to everyone. Thank you very much for having me here. Thank you, Dean.
Thank you, Professor Dr. Rahima Abdul Qadir, for the constructive feedback given. Now, moving on, we would like to invite the head of judge of the e-poster presentation, Professor Dr. Rosna Muhammad Zain, to share her feedback. Please welcome.
Assalamualaikum and a very good evening. First and foremost, I would like to thank Prof. Zamri and the organizing committee for forcing me here, but I had a good day. Okay. And thank you, Prof. Rahima. You have presented everything. So I have very little to say. All right, let's start. First of all the poster presentation, all the poster presenters, congratulations. You have all done very well. Okay. And I have nothing much to add in terms of presentation style, because in terms of the slide, because you only have one slide. And I think you didn't have you can't put a lot of things. So I think you follow a template, and I think you've got it all. The only difference is your presentation style. So what you did was, I guess you're all using some kind of software or something, because I initially thought that I have to go and stand near the poster because I will not be able to read. But interestingly, I'm sitting quite a distance, and of course you can't read the whole poster, but you stress the paragraphs and it comes out, and it's really nice. Okay, so congratulations to all of you. And as far as we three judges are concerned, you are all winners. You know, we cannot really differentiate very much, but someone must be number one, someone must be number two. So we came up with that. And then the other issue that we have is that you have the different types of research. Some may seem to be high-end research. Some may seem to be a normal research. But whatever it is, you must make sure that you understand whether it is a high-end or a low-end research. It is still your research, and you must understand, and you must be able to present it well, which I think majority did that. But a few can be corrected, because there are some who actually talk without having without being consistent with what you are stressing. For example, somebody just talk, but whatever they're stressing hasn't changed. And so it's very difficult for us, the listeners, to just listen to your talk. We have to put our eyes with whatever you're presenting so that we can follow you. So, but that is all. Otherwise, everything is good. And then, hang on. Yes, soon. I'm going to finish soon. No, nothing much. Everything Prof. Rahima has said. Okay. The only thing is, it's not so much for the presenters, but also for the future. For the future of us organizing, we find that the posters can be quite challenging for us to evaluate, because it is all just one slide, and then the presenters sometimes find it difficult because there's so many things to put in. And the other issue is the different types of research. We feel that perhaps it's time to categorize the research into different aspects, and then maybe have more prizes, meaning that one category has 1, 2, 3, another category has another 2, 3, but maybe 2 or 3 category depending on. This is, I think, a suggestion to the Dean's Council. Yeah, Prof. Zamri? Prof. Zamri. Never mind, he's not listening. Okay. No, I'm saying that it's a suggestion to the Dean's Council, because we find it very difficult when we have one, say, lab research, and then we have another which is more public health and epidemiology. We find it very difficult to put them in the. We feel that they all deserve to be given a lot of marks or something like that, and yet we have to make comparison, and can't help sometimes. If the presenter is very good, we may get impressed more onto the lab research because we are lab researchers. I mean, we are, so this is where I feel that we should be categorized. I'm suggesting you categorize, and then you can put 1, 2, 3 or whatever, and then the university that wins have more marks to collect. Correct now? Yes. Okay. So I think that's about all that I have. Thank you very much. And again, congratulations to all. And congratulations to supervisors. You all have done well.
Thank you, Professor Dr. Rosna Muhammad Zain, for the feedback given.
Now, we will proceed with a token of appreciation and award ceremony. We would like to invite the Dean, Yang Berusaha, Professor Dr. Zamri Ratzi, accompanied by Associate Professor Dr. Wan Nur Azrina and Associate Professor Dr. Ros Anita for the token of appreciation presentation ceremony.
To begin with, we will gladly invite our sponsors. Our platinum sponsor goes to Clinic Pergigian Doctors Wong and Partners Dental Surgeon represented by Mr. Wilson. Next, our gold sponsor, Helion Group, represented by Miss Vivian. Next, our bronze sponsor, Ultraden Products Malaysia, Sendirian Berhad. And last, but most certainly, our bronze sponsor, Southern Lion, Sendirian Berhad.
Thank you, Professor Dr. Zamri. Kindly remain on the stage, please. We would now like to invite Professor Dr. Siti Adiba Othman, Deputy Dean of Postgraduate, and Professor Dr. Zamroz Yuzaidi Muhammad Yusuf, Deputy Dean of Development, for the token of appreciation presentation ceremony. Now, we would like to present a token of appreciation to the honorable judges, without whom this event would not be a success. We now invite to the stage the judges for the oral and e-poster categories, starting with Professor Dr. Rahima Abdul Kadir. Next, Professor Dr. Rosna Muhammad Zain. Professor Dr. Noor Hayati Abu Qasim. Professor Dr. Wani Nayake Mudian Selage Tila Karitne.
Professor Dr. Chai Wen Lin. And lastly, Associate Professor Dr. Sharida Hasnur binti Safi.
Thank you, Professor Dr. Zamri, Professor Dr. Sidi Atipa, and Professor Dr. Zamros, and all the judges. You may now take your seats. Unfortunately, the judges for the international category could not make it today. We would like to take this opportunity to thank the judges of the international category for their contribution. Thank you to Professor Dr. V. Ratna Devi, thank you to Associate Professor Dr. Zuraiza Muhammad Zaini. And finally, thank you to Dr. Maria Angela Gonzalez. Now, we move on to the International Awards ceremony. Starting with the consolation prizes in no particular order. The first consolation prize goes to Pipiada Mikornthai from Khon Kaen University, Thailand. The second consolation prize goes to Chanyarat Sanpraset from Chulalongkorn University, Thailand.
Third place goes to Park Rutham Rongsis from Chulalongkorn University, Thailand. Second place goes to Tha Thanh Dong and Tran Antoine from Hanoi Medical University, Vietnam. And first place goes to Lu Liu from University of Leeds, United Kingdom. Thank you and congratulations to the winners.
Ladies and gentlemen, the list of winners for the participants in the presentation series have not been finalized. Please give us a moment to finalize this list. Thank you.
We are sorry for the delay. Please do give us 5 more minutes. Thank you.
Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan penggunaan ubat gigi Sensodyne, sensitivity, gum dan enamel baru melegakan gigi sensitif, membantu memulihkan kesihatan gusi dan menguatkan semula enamel. Saya sangat rekomendasikan, ia sangat efektif. Adakah anda tahu, gigi sensitif kebiasaannya disebabkan oleh masalah gusi dan kelemahan enamel. Enamel adalah lapisan paling luar pada gigi kita dan ia boleh terhakis dengan makanan seharian kita seperti makanan manis, masam. Saya mengesyorkan
Thank you for your patience. The list of winners are in. So we will now begin with the announcement of the e-posters presentation winners, beginning with consolation prizes in no particular order. So the first Sorry for the technical disruption. Okay. Sorry. Now, we would like to invite Professor Dr. Rosna Muhammad Zain, former Dean of Faculty of Dentistry, University Malaya, to present the awards to the e-poster presentation winners. There will be 2 consolation prizes in no particular order. So the first consolation prize goes to Ahmad Auzai bin Zulkarnain, Muhammad Zarif Bunyamin bin Bazrul Hisham, with their supervisors, Associate Professor Dr. Chen Yang and Associate Professor Dr. Lim Gui Song. With the title of the presentation, The Effects of Commercially Available Probiotic Supplements in Individuals with Halitosis, a Comparative Proteomic Approach. We would like to invite the supervisors on stage. We would like to invite Associate Professor Dr. Chen Yang on stage. And see the for the second consolation prize. For the second consolation prize, Lim Shiming and Farah Adiba binti Nur Haizam. We would like to invite the supervisors also, Dr. Mar Hazlinda binti Jamaluddin. The team presented with the title of Chairside Smoking Cessation, Knowledge, Attitudes, Practices, Level of Confidence and Barriers Among Recently Graduated and Clinical Undergraduate Dental Students in Universiti Malaya. Moving on. The third place goes to Muhammad Mukhlis bin Azman and Intan Shaira binti Muhammad Zarani. We would like to invite the supervisors, Dr. Amir Hazwan bin Abdul Harahim and Dr. Rabia Al-Adawiyah binti Rahmat. Please welcome. The title of the team's presentation is Dental Age Estimation Using Developing Permanent First Molar in Malaysian Children. Now, second place goes to Chan Jia-yu and Lee Mao. We would like to invite the supervisors, Associate Professor Dr. Nur Azlin Yahya and Associate Professor Dr. Hani Muhammad Ali Ahmad. The title of the presentation is Cytotoxicity of a Fast-Set Radio-Opaque Malaysian White Portland Cement with Reduced Particle Size on Dental Pulp Stem Cells. And now, on to the first place. First place goes to Leilani Anak Perempuan Tanapalan and Taibi Mahmudi. With their supervisor, Associate Professor Dr. Wan Nur Azrina Wan Hassan. With the title, Gaze Behavior of Orthodontic Patients Towards Malocclusion in Male and Female Subjects. Thank you, Professor Dr. Rosna Muhammad Zain.
Now, we would like to invite to the stage Professor Dr. Rahima Abdul Kadir, former Dean of the Faculty of Dentistry, Universiti Malaya, to present the awards for the oral presentation category. We will begin with the two consolation prizes in no particular order. The first consolation prize goes to Chong Chi Chi and Lu Zeyun. We also invite to the stage the supervisors, Dr. Ayman and Dr. Muayed. The title of their presentation was Comparison of Flexural Strength of Different Thicknesses of 3D Printed Denture Resin. Moving on to the second consolation prize, which goes to Oi Ziwei and Suprin Yi. We also invite to the stage Dr. Eunice So, Professor Dr. Siti Adibah Othman, and Associate Professor Dr. Sarita Sivarajan. The title of the presentation is Perception Between Orthodontics, Orthodontists, Orthodontic Postgraduate Students, and Patients in Orthodontic Treatment Needs Assessment using Conventional and Modified Index of Orthodontic Treatment Need Aesthetic Scale. Next, the third prize goes to Tan Ziliang and Tan Kersin. We would like to invite to the stage the supervisors, Dr. Arif and Associate Professor Dr. Noor Azlin. The title of their presentation is Morphology and Characterization Comparison between Various Calcium Phosphate and Bioactive Glass. The second prize goes to Jocelyn Lai Unler and Wu Winnie. We invite to the stage the supervisors, Dr. Jazli Aziz and Professor Dr. Wan Himaratul Aznita Wan Harun. Their presentation was entitled The Effect of Lactobacillus helicobacter Exposure on the Expression of Porphyromonas gingivalis fimbriae Genes. And now, the winner of the first prize goes to Habib Firzik bin Hassanusi and Putri Nur Alia binti Khalid. We invite to the stage Associate Professor Dr. Hani Muhammad Ali Ahmed and Dr. Noor Sakina Muhammad Noor. Their presentation was entitled Root Canals Detection in Mandibular Incisors, a Microcomputed Tomography Study. Thank you, Professor Dr. Rahima Abdul Kadir. Moving on, we would like to invite Associate Professor Dr. Ros Anita Omar, Chairperson of the 25th Universiti Malaya and 3rd International Dental Students Scientific Conference, to present the award for Best Presenter in the Oral and E-Poster category.
And the award for Best Individual Presenter for Oral Presenter goes to Habib Firzik bin Hassanusi. We would like to invite the supervisors also, Associate Professor Dr. Hani and Dr. Nora, on stage. And the Best E-Poster Presenter goes to Tayabe Mahmoudi. We would like to invite the supervisor, Associate Professor Dr. Wan Nur Azrina Wan Hassan on stage.
Thank you, Associate Professor Dr. Ros Anita Omar. Now we will move on to the overall award category, which comprises of marks from the presentation as well as the report.
We would like to invite Professor Dr. Nur Adina Baharuddin, Deputy Dean of Research, to present the Bronze Award. The winner of this category will bring home a trophy and certificate. The winner of the Bronze Award goes to Habib Firzik and Putri Nur Alia. We would like to invite the supervisors, Associate Professor Dr. Hani and Dr. Nora, onto stage. Thank you, Professor Dr. Nur Adina Baharuddin.
Now, we would like to invite Associate Professor Dr. Wan Nur Izrina Wan Hassan, Deputy Dean of Undergraduate, to present the Silver Award. The winner of this category will bring home a trophy and a certificate. And the winner is Jocelyn Lai Unler and Wu Winnie. We would also like to invite to the stage the supervisors, Dr. Jazli Aziz and Professor Dr. Wan Himratul. Thank you, Associate Professor Dr. Wan Nur Izrina Wan Hassan.
Finally, we would like to invite Professor Dr. Zamri Radzi, Dean of Faculty of Dentistry, Universiti Malaya, accompanied by Professor Dr. Wan Himratul Aznita Wan Harun to present the Gold Award. Winner of this category will take home a round trophy, a Gold Award trophy, and a certificate. The winner of the Gold Award goes to Tan Ziliang and Tan Kesin. We would like to invite the supervisors, Dr. Arif and Associate Professor Dr. Nur Azlin. All right, so I just say thank you. Do I say, do I ask? Doctor, Doctor, do I ask Prof. Zamri to remain on stage? Yeah. Thank you. We would like to call upon Professor Dr. Zamri Radzi and Associate Professor Dr. Wan Nur Azrina, Associate Professor Dr. Rose Anita Omar, and Dr. Mar Hazlinda Jamaluddin on stage for the passing of baton ceremony. Please welcome. Dear audience, it is with our great pleasure to announce that for the 26th Universiti Malaya and 4th International Dental Students Scientific Conference 2025, it will be chaired by Dr. Mar Hazlinda Jamaluddin, Head of Department of Community Oral Health and Clinical Prevention. And with that, we have reached the end of our program today. A big thank you to all who contributed in numerous ways to make this event a success. And a special thank you goes out to our sponsors today.
Ladies and gentlemen, we hope that this scientific conference will always excel and become our inspiration to move forward. This brings us to the end of the 25th Universiti Malaya and 3rd International Dental Students Scientific Conference 2024. We hope to see you all again next year. Please do scan the QR code that is going to be displayed on the screen for your attendance and e-certificate. For our dental students, please do physically sign the attendance sheet that is placed at the registration table outside the auditorium. Everyone is welcome to head to the cafe as refreshments are provided for all our guests. Thank you once again and have a pleasant day.
We would like to request that the audience gather to the center for a final photography session. Oh, at the foyer, sorry, I apologize. We would like our dear guests and audiences to gather at the foyer for a final photography session to mark the